bronchoscopy. He is specialist in chronic obstructive sleep and tuberculosis. With due respect, I now invite Dr. Chavan sir to deliver his. Sir.
So thank you very much for inviting Raicon and Raigad Medical Association, and can we serve to the community and to the patient and healthcare. So there is a branch of intervention pulmonology who is just beyond the pharmacology in the chest medicine. Patient is the aspiration or biopsy like a FNAC of the mediastinal lymph node and the mass surrounded nearby the airway structure. And the pulmonary rehabilitation, obstructive sleep apnea, smoking cessation, long-term oxygen therapy, these are the treatment option which is available in our field without any kind of drugs. So diagnostic modes are available in pulmonary medicine like any microorganism like tuberculosis, which is commonest condition in our country. We can biopsy endobronchial or transbronchial lung biopsies, fibrosis or non-specific interstitial pneumonia. With the help of the bronchoscopy, flexible and rigid, we remove the foreign body. We do the balloon dilatation of the airway stricture. With the EBUS, there are two types of EBUS, convex probe EBUS and radial probe EBUS, a medical thoracoscopy. The PFT and diffusion capacity to see the lung capacity of the patient in the interstitial lung disease and fibrosis. The diffusion capacity detect the early stages of the interstitial lung disease. Then of course CT chest, blood test and microbiology are bronchoscope. Flexible bronchoscope which is a fiber optic, and there is a one bronchoscope which is a rigid bronchoscope. So what diagnostic procedure we can do with the flexible bronchoscope is a bronchoalveolar lavage, which is the sampling of the sputum or airway secretion, or transbronchial lung biopsy and needle aspiration biopsy like a FNAC. In a therapeutic, we do many therapeutic procedures like electrocautery, cryosurgery, balloon dilatation, airway stenting, wall replacement, and a commonest therapeutic procedure is a foreign body and the collapse of the lung in the emergency situation in a ICU because of the mucus plug. So with the foreign body, I'll present first one case. A 36-year female underwent root canal for dental caries, aspirated a dental drill during the procedure. And the dentist contacted us that he done an X-ray and that the dental drill he's seen in the lungs. So this is the dental drill which lodged in the lung, and patient presented with us. So we did a CT to confirm, and then we did the bronchoscopy. With the help of the rigid bronchoscope, because flexible bronchoscope, we may injure the airway because the drill was the sharp in nature. So this is the dental drill that we removed. This is the dental drill we removed after the successful flexible bronchoscopy to the rigid bronchoscopy. So in that we use both flexible and rigid bronchoscope. So second case, a 12-year male had aspirated a plastic vessels like CT that having the outside and there is a chip inside. We used to see in a previous days. So ENT person removed the content of the vessel thing. So we did a bronchoscopy on that patient through the rigid bronchoscopy, and with the help of the rigid flexible. While entering in the vocal cord, we have to take care of the vocal cord injuries, because vocal cord injury may get damaged the vocal cord, and then voice of the patient may change. This is the trachea, and once you go down, we see the carina, and there is a narrowing in. So this is the narrowing part, this is the left and this is the right one which is narrowed, that we dilate with the help of the balloon. So we inserted a balloon in that narrowed part of the bronchus, and with the help, we inflated the air in that balloon, we dilate that partially, but later on this patient required a surgery. So with the help of this balloon, we able to dilate partially, but it was a long standing, then this patient referred to higher center and thoracic surgeon reconstruction of the airway. This is the guide wire we inserted initially. So again, one more case, 24-year female presented with a cough and breathlessness during the COVID season, because on auscultation wheezing was started and wheezing still persistent, X-ray done, that was shows no significant. Because of the COVID, there was no PFT done that time, dose of the inhaler increased, no response, HRCT chest done which shows narrowing of the left main bronchus, bronchoscopy done to confirm it was endobronchial TB, and gene expert and culture were positive, started AKD, and then later, because that wheezing was not improved, so again the bronchoscopy done to dilate to check the thing, and again balloon dilatation done for this patient. This is the narrowed part again. One more case, 27-year female was on AKD. On AKD, she presented with a wheezing, check bronchoscopy done, which shows the narrowing and dilatation. So, stenosis of the airway can be presented like asthma, can be presented after the treatment of the TB, post-TB stenosis, or can be presented because of the long-standing post-TB sequelae. So this is how we able to dilate this structure, stenos airway, with the help of the balloon and under the guidance of the bronchoscope. So these are the airway initially dilated, and later these are the post dilatation. These are the instrument, these are the balloon which help at a different pressure to dilate. We have to give the multiple setting to the patient, because one dilatation may not able to help. So second intervention in our pulmonology is a EBUS TBNA, which is a endobronchial ultrasound guided transbronchial needle aspiration. It's like a aspiration of the cervical lymph node under guidance like a FNAC. It's a aspiration of the lymph node with the help of the ultrasound processor attached to the bronchoscope by the pulmonologist. So endobronchial ultrasound guided transbronchial needle fine needle aspiration is a novel minimally invasive method to sample peribronchial or lymph node using a real-time guidance. I'll present small case of 40-year female diabetic hypothyroid cupped dyspnea, low-grade fever since 4 months, multiple course of antibiotic, no response. X-ray done shows mediastinal widening, CT thorax, necrotic mediastinal lymphadenopathy, carinal, subcarinal and pretracheal, no parenchymal lesions. That's why we did a EBUS. So this is the needle which go directly in the lymph node under the guidance, and we sample. We aspirated the pus, which gives result within a 2 hour by examining dry slide. Dry slide gives us a AFB positive within 2 hours. AFB culture and DST done to rule out the MDR TB. On core biopsy, it was epithelial granuloma consistent with TB. Cytology, granulomatous inflammation. On that sample, we can do the microbiology, histopathology to rule out the malignancy and MDR TB. This is the EBUS technique, this is the ultrasound processor at the tip of the bronchoscope, which able to guide us to biopsy lymph node under vision. This is the representative video of the EBUS process. EBUS TBNA.
Next, flex the scope to re-engage with the airway wall and locate target area on the ultrasound image.
Bronchoscope, ultrasound probe near the node. You have to
Release the needle adjuster and advance needle into the target. Remove the stylet and attach the prepared syringe on the aspiration port. Turn the stopcock on the syringe to the parallel position to apply suction. Move the needle slider back and forth in the target area several
and
times.
that enter under vision to directly in the lymph node to sample the this is the needle which is moving in and out. So in a mediastinal widening on CT scan, diagnosis can be tuberculosis, can be sarcoidosis, can be malignancy, can be lymphoma. That is not only malignancy, not only TB. It can be TB, it can be malignancy, lymphoma, or sarcoidosis, or in a TB it can be multi-drug resistant tuberculosis. So diagnostic approach for the any mediastinal lymphadenopathy, initially mediastinoscopy, CT guided biopsy, conventional TB, and a EBUS TBN. EBUS TBN is the latest non-invasive method that we can do in a simple basic evaluation in a endoscopy room with under local anesthesia on a daycare basis. Within a 4 or 5 hours we are able to discharge the patient. There are very minimal complication. I never seen any complication in my patient during the EBUS procedure. Sampling, we can choose to send the sample for the TB gene expert, TB culture, AB dry slide, histopathology and cytology. These are the two type of this is the convex EBUS. We are able to diagnose the mediastinal lymph node or peribronchial masses, and this is the radial EBUS. We can able to diagnose the peripheral tissues with the help of the radial EBUS. So this is the procedure. We enter in the trachea. This is the needle coming under, this is the needle direct under vision. In the lymph node we go through and fro, and then we are able to sample the tissues. This is the lymph node without entering the needle. This is the needle directly under vision going in the lymph node, and these are the color Doppler images. That machine is having the color Doppler like a normal USG to show the blood vessels. This is the needle, how come it from the EBUS scope. This is the radial EBUS to biopsy the peripheral masses in the lung. So EBUS is an important diagnostic tool. It aids in the microbiological confirmation of the tuberculosis and the malignancy. We can able to diagnose a expert MTB or rifampicin resistant, which helps in the quicker diagnosis of the tuberculosis in MDR TB. EBUS TBNA, sorry for the spelling mistake, improves the yield in both granulomatous and malignant disease and lymphadenitis and staging of the lung cancer. Now the doctor Salil sir is here. So they used to send the patient, if the malignancy on the right side and the lymph node is on the left side, we are able to sample from the contralateral side to stage the cancer, not only for the diagnosis, to help the staging of the cancer also we used to do the EBUS sampling. The chemotherapy and the option, the surgical option are changed after that diagnosis. So third bucket in our tool is the fluoroscopy, that is called the medical thoracoscopy. Now bronchus, that is in the lung parenchyma, mediastinal node or mediastinal mass, with the help of the EBUS TBNA, EBUS or the convex or radial for the peripheral mass. Now what about the pleural masses, pleural tissues and pleural effusion. Many patients presented to us with the pleural effusion which are recurrent or undiagnosed pleural effusion. Common disease in our country is a TB, but the availability of the cancer specialist, the disease was there, but the availability and the diagnosis and facility, we are able to diagnose the malignancy more frequently. So any recurrent pleural effusion not responding to treatment, we have to go through in the pleura and see what is there, to biopsy the pleural nodules, or we have to remove the pleural sample. If there is a repeated USG guided tapping, there is a septation, we have to remove that septa. That is therapeutic fluoroscopy. So fluoroscopy is a single port medical thoracoscopy done by the pulmonologist, and surgeon does the VATS as a 3/4 surgery. So fluoroscopy is a medical thoracoscopy minimally invasive procedure that allows doctor to view inside the chest cavity with the help of the thoracoscope. Thoracoscope is like a mini bronchoscope with that enter like a ICD in the pleura, and that will able to biopsy from the pleura for the diagnosis of the histopathology for the TB, and we can able to remove the fluid, and we can able to remove the septa of the septa in the empyema. So there are diagnostic indication of the pleuroscopy like pleural effusion of indeterminate origin, staging of the cancer with pleural effusion of diffuse malignant mesothelioma, hormone receptor determination in breast cancer in culture and in culture in tuberculosis pleurisy, staging of the pneumothorax, diffuse lung diseases, and localized chest wall and lung lesions. There are therapeutic indication of the pleuroscopy like talc pudrage in a malignant and chronic recurrent non-malignant pleural effusion or malignant effusion, talc pudrage in a pneumothorax. If patient is having the recurrent pneumothorax on the same side, we have to do the pleurodesis with the talc or with the other agent under the guidance of the pleuroscope. Parapneumonic effusion and empyema for the opening of the loculation. If there is a no TB but empyema is there, there are multiple septations, then we have to enter inside and we have to remove the pus and break the septa to expand the lungs. There are some relative contraindication to medical thoracoscopy like inability to tolerate the lateral decubitus position because patient has to lie down on one side, unstable cardiovascular and hemodynamic status as in other cases also, presence of severe and uncorrectable hypoxemia despite oxygen therapy, bleeding tendencies, refractory cough, drug hypersensitivity, and reduced general health status. There are some absolute contraindication for the thoracoscopy and pleuroscopy. Lack of pleural space. If there is no space, you can't enter inside. That is the absolute contraindication. Advanced empyema, that we have to go for the surgery. Pleural thickening of unknown etiology. If there is a pleural thickening, we can't go inside. Suspected mesothelioma where the visceral and parietal surfaces are fused each other. Previous pleurodesis. If we done a previous pleurodesis, we may not able to do it. This is the thoracoscope, semi-rigid thoracoscope which have the tip and the simple like a bronchoscope, easy to handle and easy to maneuver. We can see the maximum structure inside. These are the rigid pleuroscope or thoracoscope like a rigid bronchoscopy like our laparoscopic apparatus. This is how we enter in the pleural cavity with the small incision like a ICD tube. We place this trocar inside, and with this through this trocar we are able to see the structure inside it. I am going to finish in 2 minutes, don't worry. Being an organizer in multiple conferences, I know the time limit. This is the pleuroscope which enter in the pleural cavity, which shows there are multiple white loculation. There are the white loculation. This was the patient who diagnosed with the TB, but ADA was negative and there was culture no positive, so we enter. This is the biopsy forceps. With the help of this biopsy forceps, we did the biopsy of the parietal pleura, and with the same forceps we just move here and there, and we are breaking these are the multiple septae present inside the pleural cavity in the undiagnosed pleural effusion. This young boy done in some months back only. So with the help of this forceps, we are able to break the pleura so lung can expand, and with the help of that biopsy forceps, we did the biopsy of the parietal pleura. That was the MTB detected on the. These are the some images. Last one slide. So take home message from the pulmonologist. A pulmonologist not only treat chronic lung disease like ILD, COPD, bronchial asthma with the drugs, but it can help. Pulmonologists help other specialty with the help of the advanced diagnostic procedure like bronchoscopy, EBUS, TBNA, medical thoracoscopy. Not only, and even we help the dentist to remove some foreign bodies aspirated during the procedures. Pulmonologists help in timely and accurate diagnosis and the treatment of the patient. Thank you. So in case any question you can ask now or later on also.
If anyone has any questions, they may meet sir personally after the lecture. Thank you, sir. Thank you, sir, for an excellent and enlightening presentation. Your talk has clearly highlighted the expanding scope of pulmonology beyond medications alone. I now request our chairpersons, Dr. Aditya Jangam and Vikas Gomare, to kindly felicitate our guest speaker, Dr. Vinod Chavan sir. I now request Dr. Vinod Chavan sir to kindly felicitate our chairpersons, Dr. Aditya Jangam and Dr. Vikas Gomare, as a gesture of appreciation. Before we conclude this session, we shall have our lucky draw. May I request Dr. Vinod Chavan sir to kindly take out the lucky draw winner. Scientific session. Thank you very much, sir. I now request Dr. Amruta Patil to kindly take over and continue.
Thank you, Dr. Sheetal. Good morning, everyone. We will continue with our, which is Update in Migraine Management by Dr. Rama Patil. Request our chairperson, Dr. Digambar Pawar, sir, and Dr. I request Dr. Digambar Pawar sir and Dr. Bhamere sir to please welcome our guest speaker, Dr. Rama Patil, by offering. She is working as a general neurologist at Dr. R.N. Patil's Suraj Multi-Speciality Hospital, Sanpada.
Good morning. I will talk in a bit detail in later. So the headache treatment has come a long way. In initial years, we had really limited options, but now in last 10 years, there has been really an explosion with in this consensus, and those are GPANs and DITANs. So I'll be talking about these two new options which have become available. So coming to the first new category of treatment, that is DITANs. So DITANs, as the name suggests, they are similar to triptans in that they act on a serotonin receptor, but it's a slightly different receptor. It's 5-HT1F receptor. The triptans act on 1B and 1D receptor, and it practically makes a major difference because many of you may know that triptans cause vasoconstriction, and that's why they are contraindicated in patients with cardiovascular risk factors or those with a history of cardiovascular events. But DITANs can be very well tolerated. They are very safe in patients with cardiovascular history because they don't cause vasoconstriction due to action on this different receptor. So the specific DITAN that was approved by FDA is lasmiditan, which is available in 3 different doses. It's just 1 tablet at the start of migraine, and it's statistically found significantly superior to placebo in various studies. And as I said, it's not associated with vasoconstriction, and there are no cardiovascular precautions. The downside of this medication is that a high percentage of patients may experience dizziness and sedation. It's quite high enough that there is driving caution for around 8 hours. This could be a limiting factor, but still we could adjust this medication into treatment regimen. If anyways patient is lying in bed, they are on weekends, they can take this tablet, or if they are anyways going to rest because of the severe migraine, they are at home or later in the day. So it still is important medication. It still has filled the gap of being useful in patients with cardiovascular precautions. Coming to the next category of new medications is GPANs. So GPANs, they act on a different receptor than DITANs and triptans, that is a CGRP receptor. So what is this CGRP? It's a hot topic in last decade in migraine area. So it's a 37 amino acidic peptide which is expressed in peripheral and central nervous system. It's involved in inflammation, vasodilation, and pain sensitization. So there's a busy slide, but it's important to know that this molecule was introduced in 1984, and it took us quite a while to translate this discovery and knowledge of CGRP molecule into a safe and effective therapy. So this was 2018 when the first CGRP targeted treatment came to market, and since then it has really changed the way migraine patients are treated. It has really changed the approach to migraine patients. So the pharmacological targets, as I said, it's mainly acting at pain transmission level. Blood flow in the cerebral blood vessels is regulated by this CGRP molecule, and also the neurogenic inflammation. So there are several different methods of blocking the CGRP activity to treat migraine attacks. So GPANTs, they act on CGRP receptor. These are smaller molecules, while there are some monoclonal antibodies which either target the CGRP molecule itself or the CGRP receptor. So GPANs, the FDA, there are two options approved by FDA, and you can see again they are superior to placebo, and when we compare the pain freedom at 2 hours, and they are very well tolerated. They have even lesser side effects than ditans. A very small percentage of patients may experience some nausea and somnolence, but otherwise very well tolerated. There is no risk of medication overuse, like with triptans. If patients keeps taking on triptans, there is a risk of worsening of headaches, which is not there with CGRP receptor antagonists. There is no driving warning. There is no risk of serotonin syndrome. The only precaution is that it is metabolized by the CYP3A4 pathway. So any inducer or inhibitor medicine taken by patient needs to be taken into account, and it should be avoided in pregnancy and severe hepatic impairments. So when to use neuro-acute medications as per American Headache Society guidelines, if there is contraindication to, intolerance to, or failure of at least 2 oral triptans, and if the patient has, as I mentioned a couple of times, these patients with cardiovascular history or risk factors, neuro-acute medications can be used. So these are not necessarily newer options, but the takeaway from the slide is that many of the first-line medication, that is triptans and NSAIDs, are available even in non-oral formulations like subcutaneous injections and nasal sprays, which are very useful in the patients who have severe nausea and vomiting at the start of attack, or who want rapid relief. The sprays and subcutaneous injections have faster absorption and faster rate of action. So sudden severe attacks could be managed with these subcutaneous injections or sprays. So coming to prevention, what is prevention? So basically it is not cure, but it is reducing the frequency and severity of migraine. So getting it down to the level where the patient has increased functionality. The prevention is mainly meant for reducing the acute medication use, and of course if we prevent number of migraine attacks, it is disease modification, because more the number of attacks, more the chances of patient going into the chronic migraine frequency. So if we give better prevention, it is going to prevent or stop the disease progression. So when to offer prevention is a bit of tricky question. It varies from patient to patient, but as per American Headache Society, we can see even less than 3 headache days a month with severe disability, we can think of starting prevention in such patients. The main purpose of giving prevention is reducing the use of acute treatment. Also, it is useful in patients who have contraindication to, failure to, or overuse of acute treatments. And if certain patients, by their preference, they want to start the prevention, as they want to avoid the acute medication use. So before going to the pharmacotherapy, I would like to talk about non-pharmacological treatments, because I feel they are equally important. So any consultation with migraine patient is incomplete without explaining the lifestyle modification to them, because migraine brain likes things to be regular. So regular sleep, keeping stress under control, staying more hydrated, keeping balanced diet, not skipping meals, moderate exercise, all this forms part of my discussion. And if I have to choose one, it will be sleep, because I feel it's a bit more modifiable than other things like stress, but definitely they are as important as giving medication to patients. Coming to nutraceuticals, these are useful alternatives, and there is a lot of evidence and studies for all these. The table summarizes all the important alternatives. So the one which I use most as adjunct to other medicines is magnesium, and so this is especially useful first step. Even you can add it as a monotherapy for those who are sensitive to medications, as they have good safety profile. And there are behavioral and complementary therapies like cognitive behavioral therapy, biofeedback, mindfulness-based stress reduction, etc. They all have good level of evidence. Accessibility is a problem. Getting behavioral therapy may be challenging for patients, but I explained to some of the patients at least mindfulness-based stress reduction, because there are free resources, there are many apps and websites for this, and it works really wonders in some of the patients. Coming to the pharmacotherapy, these guidelines are again older guidelines from 2012 from AAN, which lists some of the traditional but still very useful in around 70% of the patients. We know already valproate, topiramate, propranolol, amitriptyline. These are all the traditional oral medications which are still first line in all the migraine patients, but the only downside is that many of them are not well tolerated. They are not migraine specific, and so in 2021, the American Headache Society has formed a consensus statement, and these newer list includes the CGRP targeted treatments apart from the older molecules. So you can see it's interesting to see the candesartan molecule in the oral options. So if any person is hypertensive and has migraine, we can choose this ARB as in their regimen. So these newer guidelines also include the onabotulinum toxin. So what are the principles? The basic principles are that when we start any preventive treatment, we give it enough time to work, so at least 2 to 3 months for it to work, and when we see that there is better control, we try to come out of it. So the newer preventive treatment options include CGRP, monoclonal antibodies. So these are larger molecules, so these can't be taken orally, and there are parenteral, there are injective formulations which are either taken subcutaneously, or there is only one which is given intravenously every 3 months. All others are subcutaneous injections every month. So out of them, erenumab is widely every other day. So as I said, the side effect profile is, so many of the patients experience some nausea and constipation. Coming to the last exciting treatment area is neuromodulation. Neuromodulation, it is electrical or magnetic stimulation of brain or peripheral nerves, aiming to reduce the migraine frequency or severity. So it stimulates, basically it is stimulation of specific nerves like trigeminal, occipital, or brain areas like the motor cortex to disrupt the pain signals or modulate the brain activity involved in migraines. So you can see in this picture there are a variety of devices acting on variety of locations and variety of nerves. We'll see. So why is it needed? Because many patients say we don't want drugs, we want some alternatives. Many of them are intolerant to medications. Many have contraindication for medicines like pregnant ladies. Many are refractory to medications, no medication is working, and many prefer a non-drug treatment. So there are such 5 FDA approved neuromodulation devices. 2 of them which I use in my clinic, I'll talk about them. So Cephalio was the first device introduced, which is a trigeminal nerve stimulator. So you can see, maybe I have even brought it with me. If you can see me in the screen, maybe. It's a device with an adhesive strip of electrodes, which is placed over forehead, and it's applied to the forehead just above the eyebrows, and a session of around 45 minutes to 60 minutes stimulates the trigeminal nerve, producing a sedative effect that may relieve head pain. So slight side effects like irritation at the application site, fatigue during and after treatment may be seen, but otherwise one of the very well tolerated device. The other device is GammaCore, which is a vagal nerve stimulator. It activates is the size of iPhone. It's positioned on the neck near the vagus nerve, and it activates the vagus nerve with mild electrical stimulation, which is thought to modulate pain signals involved in migraine attacks. The third device is eNeura. It's transclear and greater occipital nerves. And there are mild local adverse effects like skin irritation and redness. So depending upon what is the purpose, if it's acute attack, it's during the attack we take a session of 45 to 60 minutes. If it's for prevention, we use all these devices on daily or alternate day basis. There are some contraindications because there's mild electric current that is produced. So epilepsy implanted medical devices like pacemakers, history of stroke, or any metallic implant in the body is a contraindication to neuromodulation. And coming lastly, this is the last slide. So there are some procedures performed in headache clinic, like onabotulinum toxin may be known to many of you. This Botox was FDA approved for chronic migraines, that is migraine which is lasting for more than 15 days a month. And if there are 2 or more preventive older medications are not working, Botox works very well for them. Then apart from Botox, there are some other nerve blocks like occipital nerve block and sphenopalatine ganglion block, and there are some trigger point injections. And so these variety of procedures are performed in headache clinic. So the takeaway points are that variety of new acute and preventive medications and treatments have become available in last few years with better tolerability, and they are more specific. And we should remember non-pharmacological approaches like behavioral therapy, devices, and procedures. Thank you.
Thank you, Dr. Rama Patil, for such a wonderful and enlightening lecture. Now, I request our chairperson to felicitate our guest, Dr. Rama Patil, by offering a memento on behalf of RMA Raicon 2026. I request our guest speaker, Dr. Rama Patil, to felicitate our chairperson, Dr. Pawar sir, and Dr. Bhamere. Wait a minute, ma'am. Now it's time for our second lucky draw. I request our speaker to do the honor, which is sponsored by Dr. Pushpak Chirmade Cancer Center at Vashi, Panvel and Thane.
Deepak Takke. Deepak Takke.
Dr. Deepak
Dr.
Takke.
Deepak Takke.
Deepak, Dr. Deepak.
Next. आहे? Yeah. Congratulations, sir. Now we will continue with our next scientific session by Dr. Salil Patkar, topic Understanding Immunology Oncology. I request Dr. to escort our lecturer. Welcome, sir. Dr. Sandeep Kamble. Sorry, Dr. Dhawale sir, please sit. I request Dr. Shripal Jain and Dr. Dhawale to welcome our lecturer, Dr. Salil Patkar sir. I request Dr. Salil Patkar to do the honors and take out a lucky winner sponsored by Mumbai Onco Care, Vashi.
डॉक्टर संगीता दाटे.
डॉक्टर संगीता दाते.
सरनेम नाही. डॉक्टर दशरथ सॉरी डॉक्टर दशरथ 343.
डॉक्टर दशरथ.
डॉक्टर मुकेश सिंग 260.
डॉक्टर मुकेश सिंग 260. That's all. Thank you. I am privileged consultant medical oncologist, 12 plus year experience in comprehensive cancer care, MBBS MD internal medicine, DM medical oncology, certified in immuno-oncology and precision oncology, Harvard College. Practices at Indian Cancer Treatment Center, Vashi and Panvel. Served understanding immunology oncology.
सो थँक्यू रायकॉनमध्ये बोलवण्यासाठी. माझं नाव डॉक्टर सलील विजय पाटकर. मी कॅन्सर स्पेशलिस्ट आहे आणि आज मी इम्युनोथेरपीबद्दल बोलणार. सो फारच इंटरेस्टिंग टॉपिक आहे इम्युनोथेरपी. इट्स अ कॉम्प्लिकेटेड टॉपिक बट वन्स यू ब्रेक इट डाऊन यू रिअलाइज इट्स फॅसिनेटिंग. ठीक आहे. देर इज अ यंग गर्ल. हर नेम इज एलिझाबेथ बेसी डॅशिल. शी इज अ 24-year-old यंग गर्ल, अपॅरेंटली व्हेरी प्रिटी. मी नाही म्हणत आहे, ॲक्च्युली पुस्तकांमध्ये तसा उल्लेख केला गेला आहे. अँड शी वॉज व्हेरी क्लोज टू द रॉकफेलर फॅमिली. रॉकफेलर फॅमिली ही स्टँडर्ड ऑइलचे ओनर्स होते अमेरिकामध्ये. इट वॉज वन ऑफ द रिचेस्ट फॅमिलीज इन अमेरिका ॲट दॅट पॉईंट. शी डेव्हलप्ड अ स्मॉल स्वेलिंग ओव्हर हर फिंगर. तर ती त्यांना जाऊन भेटली. ती म्हटली एक काम कर, डोंट गो एनिवेअर एल्स, तू हार्वर्ड मेडिकलला जा आणि तिथे डॉक्टर विलियम कोली आहेत, यू गो अँड मीट हिम, एव्हरीथिंग विल बी ओके. सो शी वेट विलियम कोली. विलियम कोलीनी बघितलं आणि म्हटलं काय घाबरू नको, दिस लुक्स लाईक पेरिऑस्टायटिस, यू शुड बी फाईन. बट शी केम बॅक 2 weeks later. 2 weeks later द स्वेलिंग हॅड इन्क्रीज्ड इन साईज. तर तो म्हटला ओके थोडं विचित्र वाटतंय, आपण एक बायोप्सी करून घेऊया. सो ही डिड अ बायोप्सी. बायोप्सी अनफॉर्च्युनेटली टर्न्ड आउट टू बी अ सार्कोमा, अ कॅन्सर. एक्साईज केलं, घरी गेली. बट शी वॉज बॅक आफ्टर 3 to 4 weeks. She had multiple lesions all through her body. The cancer had spread. It was an aggressive cancer. And unfortunately, she eventually passed away within the next few months. आता ही we are talking about the 18th century. 1800ची गोष्ट आहे. And it was not uncommon. आता सुद्धा it's not uncommon. But definitely तेव्हा it was not uncommon for somebody to die of cancer. Especially a metastatic stage 4 cancer. तेव्हा तर आपल्याला काहीच माहीत नव्हतं कॅन्सरबद्दल. पण तरीही it impacted William Coley, the doctor, very deeply. आणि तो म्हटला की मी असं काय करू शकत होतं या 24 वर्षाच्या पोरीसाठी दॅट आय कुड हॅव सेव्ड हर. ही डिसाइडेड दॅट आय विल गो थ्रू ऑल द रेकॉर्ड्स ऑफ ऑल द पेशंट्स टू सी इफ देर वॉज एनीबडी एल्स विथ अ सिमिलर डिझीज हू हॅड अ डिफरंट आउटकम. त्यांनी 7 ते 8 वर्षामागचे सगळे रेकॉर्ड्स जे हॉस्पिटल 8 वर्ष मागेपर्यंत गेला तेव्हा ही फाउंड 1 patient लाईक दॅट. ह्याचं नाव फ्रेडस्टीन आहे. हा एक जर्मन इमिग्रंट होता. ही हॅड कम विथ अ लार्ज मार्क्स इन हिज नेक. डॉक्टरांकडे गेला, इनऑपरेबल होता, व्हेरी क्लोज टू द कॅरोटेड वेराटिनॉल. डॉक्टर्सनी जेवढं काढू शकतं काढलं आणि त्याला सांगितलं भाई घर जाओ, तुम्हारे पास ज़्यादा वक्त नहीं बचा है, फ्यू वीक्स हियर एंड देयर. बट अनफॉर्च्युनेटली अगेन दिस इज द 1800. सो अनफॉर्च्युनेटली पोस्ट ऑपरेटिव्ह ही डेव्हलप्ड अ व्हेरी बॅड पोस्ट ऑप इन्फेक्शन, स्ट्रेप्टोकॉकस पायोजेनिस अर्सिपेलस ज्याला आपण म्हणतो. बट देन अनफॉर्च्युनेटली 2 दिवसात घरी जाऊन फॅमिलीबरोबर राहायला वेळ स्पेंड करायच्या ऐवजी तो 2 महिने हॉस्पिटलमध्ये राहिला बिकॉज ऑफ दिस पोस्ट ऑप इन्फेक्शन. ही डेव्हलप्ड हाय ग्रेड फीवर्स रिपीटेडली. Surprisingly, every time he developed a high-grade fever, the tumor size used to shrink. Right? आणि शेवटी मग तो 2 महिन्यानंतर डिस्चार्ज होऊन घरी गेला. परत कधीही तो हॉस्पिटलला आला नाही, कुठलाही काही फॉलोअप नव्हता. विलियम कोली म्हटला मी या माणसाला ट्रेस करतो, हा काय झालं त्याचं, डिड ही पास अवे, वेन डिड ही पास अवे, ऑल दोज थिंग्स. सो 8 years later हा त्याचा ट्रीटिंग डॉक्टर नाही आहे. ही वेंट अराउंड ट्राईंग टू फाइंड वेर ही लिव्स अँड ही फायनली डिड फाइंड हिम. ही रँग द बेल अँड इन्क्रेडिबली फ्रेडस्टीन स्वतः उभा होता दरवाज्यावर. त्यांनी दरवाजा उघडला. आफ्टर 8 years आफ्टर बिंग डायग्नोज विथ अ स्टेज 4 मॅलिग्नंट मेटॅस्टॅटिक सार्कोमा, ही वॉज अलाइव्ह अँड ॲब्सोल्युटली फाईन. And this led William Coley thinking. See, the only difference he could make out between Bessie and Stein was the fact that Stein had a very bad, severe bacterial infection. Remember, we are talking about 1890s. There is no concept of immunity. There is no concept of mutagen. There is no concept of B cell, T cell, white blood cells. काहीही माहीत नाही अँटीजेन अँटीबॉडी. पण विलियम कोलीनी स्वतःची एक तेव्हा हायपोथेसिस केली. तो म्हटला maybe the infection has awoken something in the body that helped fight cancer. And then he would make it his mission to find out whether he was right. त्याची एक्सपेरिमेंट्स त्यांनी स्वतःच चालू केले. हे एक्सपेरिमेंट जर आजच्या काळी केले असतं तर ह्याला जेलमध्ये टाकलं असतं. पण 1800s एथिक्स वेर डिफरंट, अंडरस्टँडिंग ऑफ मॉरल एथिक्स अँड हाऊ ट्रायल्स नावाचा इनफॅक्ट कॉन्सेप्टच नव्हता तेव्हा. सो विलियम कोलीने काय केलं, ही टूक स्पेसिमेन्स फ्रॉम ऑल पीपल इन द वॉर्ड्स हू हॅड कम विथ इन्फेक्शन्स. इफ देर वॉज अ पस वस ते सगळं तो ड्रेन करायचा आणि कुठलेही स्टेज फॉर कॅन्सर पेशंट्स आले त्यांना तो हे द्यायला लागला. Obviously, the results were not as predicted. He had mixed results. Most patients did not make it. Some of them did make it. Some of them developed high-grade fever. थोडा वेळ tumor कमी व्हायचा. But by and large, you could not really say what was going on. त्यांनी विचार केला, let me go and meet people who actually are at the forefront of their fields and try and understand this. तो म्हटला, if I can create the right toxin, the toxin which has the right amount of virulence, least infectivity, that would be great. तर त्यांनी काय केलं त्या काळी? It was a great time. All great stalwarts were there. He went and met Robert Koch. Robert Koch is the father of microbiology, who has ज्यांनी ट्युबरक्युलोसिस, कॉलेरा ह्या सगळ्याची डिस्कवरी केली. तो रॉबर्ट कॉकला भेटला आणि म्हटला, मला असं टॉक्सिन बनवून देऊ शकतो का? रॉबर्ट कॉकची एकच कंडिशन होती. तो म्हटला, तू ज्या गोष्टींसाठी वापरतो, आय डोंट अंडरस्टँड दॅट. यू आर ॲक्च्युली इंजेक्टिंग पीपल विथ इन्फेक्शन्स. आय डोंट अंडरस्टँड दॅट. आय विल मेक द टॉक्सिन बट लायबिलिटीज शुड नॉट बी माइन. तो म्हटला, इट इज माय रिस्पॉन्सिबिलिटीज, यू जस्ट गिव्ह मी द टॉक्सिन. आणि त्यांनी ते टॉक्सिन वापरलं. त्यांनी त्याचा नेक्स्ट पेशंट जो आला, मिस्टर झोला नावाचा एक पेशंट होता, ह्यूज मास अगेन इन द नेक. त्यांनी झोलाला हे नवं बनवलेलं, रॉबर्ट कॉक्सने बनवलेलं कोलिश टॉक्सिन दिलं. इन्क्रेडिबली मिस्टर झोला वेंट इन टू कम्प्लीट रेमिशन. फॉर द नेक्स्ट 15 years, with varied results, Coley would use his Coley's toxin to treat stage 4 cancer patients. Some patients would survive, some patients would not. Some patients would die of the infection themselves. The only issue was, Coley was actually doing immunotherapy a century before immunology existed. The problem was Coley himself did not know ki exactly काय चाललं, why was the body behaving in a certain way, because the science was not there yet. Unfortunately, for the next 30 years, he would struggle. And that has to do partly with politics, partly with economics, how things work. So Coley पुढे जाऊन he would join one of the biggest cancer hospitals in the world, back then also आणि आता सुद्धा, Memorial Sloan Ketteringला तो गेला, and he joined there. His idea was, मी माझ्या रिसर्च जो मी करतोय कोलिश टॉक्सिन्स, मी त्याच्यावर पुढे इथे काम करणार. At that point, the director of Sloan Kettering was James Ewing. James Ewing म्हणजे एविंग, ज्यांनी एविंग सार्कोमा ज्याच्यावर नाव दिलं गेलं. त्याच काळी अराउंड दॅट टाइम रेडिएशन हॅड कम इन टू प्ले. अँड एविंग्स यूज टू यूज रेडिएशन फॉर एव्हरी बोन ट्युमर पेशंट, एव्हरी सार्कोमा पेशंटला तो फक्त रेडिएशनच द्यायचा. ही रिफ्यूज टू एंटरटेन कोली. Part of that was, yes, radiation was a new technology, but then so was Coley. Coley was also coming up with something new, something innovative. पण त्याला ती ऑपॉर्च्युनिटी दिली नाही गेली. का? कारण हे सगळे हॉस्पिटल्स आज सुद्धा आणि तेव्हा सुद्धा दे रन ऑन फंडिंग. Memorial Sloan Kettering also ran on funding, and the biggest funder for Memorial Sloan Kettering Cancer Hospital was a mining industry. And the main product of that mining industry was radium. And the main buyer of radium was the biggest radiation hospital in the world, Sloan Kettering. So it was a unfortunate nexus of sort where hospital चालत होतं कारण स्लोन केटरिंगला पैसे मायनिंग इंडस्ट्री देत होती आणि मायनिंग इंडस्ट्रीचा प्रोडक्ट स्लोन केटरिंग विकत घेत होता. सो इट वॉज व्हेरी क्लिअर दॅट द डायरेक्टर ऑफ स्लोन केटरिंग वॉज नॉट गोइंग टू फोकस ऑन एनिथिंग बट रेडिएशन. कोली सेड फाईन, कधी ना कधी रिटायर होणार, वेन ही रिटायर्स आय ट्राय माय बेस्ट. He did retire. That was during the Second World War. Unfortunately, even after his retirement, Coley didn't get his chance. The new director of Memorial Sloan Kettering जो आला, his name is Colonel Rhodes, Colonel Dr. Rhodes. Colonel Dr. Rhodes हा 1950s मध्ये he took over Sloan Kettering. Prior to that, he was the chief of the military for chemical warfare for the US military during the Second World War. आय एम गेसिंग तुम्हा लोकांना आयडिया असेल ह्याची, मी पूर्वी कधी याच्यावर बोललो सुद्धा आहे की किमोथेरपीचा शोध कसा लागला माहिती आहे. आपल्या नाझीजनी, हिटलरनी ज्यूजना मारण्यासाठी कॉन्सन्ट्रेशन कॅम्प्समध्ये गॅसेस वापरले होते, गॅस चेंबर म्हणायचे त्याला, आणि जो गॅस वापरला गेला दॅट वॉज मस्टर्ड गॅस. अ ग्रुप ऑफ अमेरिकन सायंटिस्ट नोटीस की जेव्हा दीज ज्यूज वर बिंग किल्ड युझिंग मस्टर्ड गॅस इन गॅस चेंबर्स, देअर काउंट्स यूज टू फॉल प्रेसिपिटसली, धड करून WBC काउंट सगळं पडायचं. And they figured कि if the counts fall, then why can't we tame it, why can't we tone it, why can't we adapt it and use this mustard gas in a way that we can use it to kill the cancer cells as much as possible. त्या ग्रुप ज्यांनी ह्याचा शोध लावला, दॅट ग्रुप वॉज कर्नल रोड्सचा ग्रुप. सो इट वॉज व्हेरी ऑब्वियस. आता त्याच्यानंतर जो माणूस स्लोन केटरिंगला जॉईन करणार, ही इज द इन्व्हेंटर ऑफ किमोथेरपी. इट वॉज व्हेरी ऑब्वियस दॅट स्लोन केटरिंग वुड नाव गो टुवर्ड्स किमोथेरपी ॲज देअर नेक्स्ट वे फॉरवर्ड. इट इज सेड की कोहलीने ॲटलिस्ट 6 वेळा लिहिलेलं रोड्सला की मला एक 5 वर्षाची ट्रायल कंडक्ट करायला द्या टू प्रूव्ह दॅट वी कॅन डू दिस. ही ॲब्सल्युटली रिफ्युज्ड. अल्टिमेटली कोहली पास्ड अवे. For the next 25 to 30 years almost, no one would talk about immunotherapy. But there was somebody who believed in him, somebody who thought that he was a forgotten pioneer, and that somebody was his daughter. कोहली जेव्हा टॉक्सला जायचा, त्याची पोरगी तेव्हा 14 आणि 15 वर्षाची होती. शी used to follow her father all around when he gave talks. She had heard all his talks. ती सायंटिस्ट नव्हती, ती डॉक्टर नव्हती, बट शी हॅड सीन हर फादर्स राईज वेन ही हॅड समथिंग इंटरेस्टिंग टू से, अँड शी हॅड सीन द पॉलिटिक्स कम इन टू प्ले, वेर अनफॉर्च्युनेटली लेटर ऑन नोबडी वॉन्टेड टू हिअर वॉट कोहली हॅड टू से. कोहली हा रिसर्चर नव्हता, हा सायंटिस्ट नव्हता, त्यांनी काय रेकॉर्ड्स मेंटेन केले नव्हते, बट ही टूक डाऊन नोट्स अँड ऑफ एव्हरीथिंग दॅट ही डिड अँड रोट देम डाऊन. आणि कोहलीच्या पोरीनी त्याचे 15,000 नोट्स सेव्ह करून ठेवलेले 20 वर्षासाठी. कोहलीची पोरगी हेलन कोहली, she went and met everybody possible, all researchers, all scientists, all doctors, every known pharma, big shot hospitals, everyone. आणि म्हणतं की कोणीतरी ह्याच्यामध्ये बघा, there is something interesting here. Unfortunately for 30 years nobody paid attention to it, right? Finally रॉकफेलर फाउंडेशननीच तिला थोडंफार मदत केली. दे गेव्ह हर अ लिटल डोनेशन आणि त्याच्यानी ती नॅशनल कॅन्सर इन्स्टिट्यूट, शी वॉज वन ऑफ द पीपल फाउंडिंग द नॅशनल कॅन्सर इन्स्टिट्यूट, नॉट अ डॉक्टर, नॉट अ सायंटिस्ट, अँड देन शी स्टार्टेड वर्किंग ऑन दॅट. बट इट वॉज 30 to 40 years of complete silence, unfortunately. In fact, immunotherapy didn't fail for 100 years. Science was just not ready for it. The competition got so bad की रोड्सनी तेव्हा FDA मध्ये recommendation करून he got Kohli's toxins banned. He got them removed from FDA approval कडनं. Nobody talked about immunotherapy. The word disappeared altogether for 40 years from all textbooks related to cancer. But then glimmers of hope. Glimmers of hope. Let's talk about the immune system before I discuss what happened next. So late 20th century मध्ये पोहोचलोय आपण. We do know that there is an immune system. Now scientists ना तेवढं कळलेलं आहे. And we know that it is divided in 2 parts. Fast, blunt, non-specific. Attacks everything. Innate immune system मध्ये मेनली काय येतं? डेंड्रायटिक सेल्स, मॅक्रोफेजेस. कुठलाही बॅक्टेरिया आला, कुठलाही फंगस आला, पॅरासाइट आला, मॅक्रोफेज जातं. इट क्लिअरली सेज की बॉस ये तो अलग है, दिस इज अ फॉरेन थिंग. आय विल गो अटॅक इट, आय विल एनगल्फ इट अँड आय विल ईट इट अप. That's the basic system. It works very fast. Then there is a more adaptive immune system which is slow, it is precise, it is intelligent. Innate immune system चे जे macrophages आहेत ना, त्याला आपण garbage-men का policemen म्हणतो. Just eat up everything. The adaptive immune system though is more complicated. आता तेव्हा माहिती होतं, this is the early 20th century, we knew that there are B cells and T cells. एवढं आपल्याला कळलेलं. Let us talk about the B cells. A incredible thing. B cells काय करतात आपल्या बॉडीमध्ये? They make antibodies. We are all aware of that, right? But did you know this? That only one unique antibody. एक B cell फक्त एकाच प्रकारची antibody बनवते. If this sounds, if you are not impressed by this fact, atta in your and my bloodstream, currently there are 3 billion B cells circulating. 3 billion, which means there are 3 billion unique antibodies currently in your bloodstream produced by each and every B cell making one specific antibody. To put this in perspective, ह्याचा अर्थ हे झाला की तुमची बॉडी आता निसर्गामध्ये जे अजून आजारपण आले सुद्धा नाही आहेत, because there are no 3 billion diseases in nature. Your body is currently making antibodies for diseases that have not even come into existence yet. That is the level of complexness, that is the level of evolution of immunity that has taken place. आणि हे antibodies ते बनवल्यानंतर it fires them. They are sticky. They are like sticky proteins. It fires them out rapidly at a rate of 2000 per second. म्हणजे इंडिव्हिज्युअल बी सेल अँटीबॉडी एका मिनिटामध्ये 1,20,000 अँटीबॉडीज फायर करते. आणि एक बी सेल अँटीबॉडी फक्त एकाच प्रकारची बी सेल एकाच प्रकारची अँटीबॉडी बनवते. सो दिस इज हाऊ इट वर्क्स. से अ बॅक्टेरिया इन्फेक्ट्स, बॅक्टेरिया आत आलं, द बी सेल्स, all the B cells shoot out every individual antibody that is made. Remember, every individual antibody from every individual B cell is different. मग त्याच्यातली जी कुठली अँटीबॉडी जाऊन त्या बॅक्टेरिया का पॅथोजन का फंगसला चिपकते, that is the lock and key mechanism. Once that happens, they say that this is the particular antibody against this particular bacteria, and then it mass produces them on a large scale. That is how your immunity basically works, and that is why you don't usually have epidemics of bacteria. because you have 3 billion diseases साठी already prepared inside your body. But there is a problem. There is a blind spot. The blind spot is this: B cells can only attack things on the surface of a cell. So B cells can only attack what they can see. B cells cannot deal with problems that occur inside the cell. So this is one of the, आता कोणाला कळलं व्हायरसेसना बी सेल्स का काम नाही करत, व्हायरसेसचे का पॅन्डेमिक्स होतात, आपल्याला बॅक्टेरियल पॅन्डेमिक्स का नाही, कोविड व्हायरस का होता, बाकी पण जे होतं H1N1 इन्फ्लुएन्झा सगळे व्हायरसेसचे पॅन्डेमिक्स का होतात. द रिझन इज दिस: बिकॉज अ व्हायरस डज नॉट हॅव अ सेल बॉडी. अ बॅक्टेरिया हॅज इट्स ओन सेल बॉडी, अ प्रोटोझोआ हॅज, अ फंगाय हॅज, ऑल ऑफ देम डू, राईट. पण व्हायरसची सेल बॉडी नाहीच आहे. व्हायरस हे एका हेल्दी ह्युमन सेलच्या आतमध्ये जातं आणि मग त्याची जेनेटिक मशिनरी वापरतं टू क्रिएट मोर रेप्लिकास ऑफ इट सेल्फ. There is no cell body with a virus, so it is inside the cell, and a B cell cannot do anything about something going wrong inside the cell of the body, where it cannot find the surface antigen. This is where T cells come into play. T cells are responsible for handling internal threats. Their job: inspect the body closely, body cells closely, look for any abnormal internal proteins, kill the cell up close and personal, and so they play the main role in viral infections and other internal problems that may occur. But there was one basic belief at that point: T cells cannot work, or immunity cannot work against cancer. Cancer cells are just too similar to normal cells to be recognized. कारण cancer is not an external pathogen. Cancer तुमच्या शरीरातलीच सेलमध्ये काहीतरी गडबड झाली आहे, म्युटेट झालेलं आहे. बॉडी त्याला, इम्युनिटी त्याला ओळखू नाही शकत. सो द सेंट्रल डॉगमा इन द अर्ली 20th century, सेंट्रल डॉगमा मीन्स द सेंट्रल बिलीफ इन द अर्ली 20th century was that immunity fights cancer. Cancer is invisible to immunity. Immunity fights infection. Cancer is invisible to immunity. The belief was that cancer cannot be killed by immune cells. Very interesting. And this belief held for nearly 30-40 years. Then one doctor comes, his name is Steven Rosenberg. ह्या माणसाला एवढी चिकाटी आहे, we will see now. Rosenberg, first and foremost, he is a transplant surgeon. Rosenberg has nothing to do with cancer. He is not an oncosurgeon. पण त्याला एक सिंपल प्रश्न होता: आपण ट्रान्सप्लांटमध्ये काय करतो? आपण एक डोनर आहे, एक रेसिपियंट आहे, राईट. डोनरकडनं आपण एक किडनी घेतली, रेसिपियंटमध्ये ती दिली. सगळ्यांना त्या काळी हे माहिती होतं की तुम्हाला रेसिपियंटला फक्त किडनी इम्युनिटी सप्रेस करायला लागते. बिकॉज इफ यू डोंट सप्रेस द इम्युनिटी, व्हॉट हॅपन्स इज यू विल इदर हॅव अ ग्राफ्ट रिजेक्शन और यू विल हॅव अ ग्राफ्ट वर्सेस होस्ट डिसीज, विच मीन्स दॅट द बॉडी इज गोइंग टू रिजेक्ट इट. हे रिजेक्शनचं काम इज प्रायमरली डन by the T cells. This is something science had realized at that point, that the T cells play the main role in rejection. So Rosenberg had a very, very simple question. Remember, he has nothing to do with cancer. It's just common sense. He said, if the T cells can detect other humans' organs, why can't they detect a cancer cell? The hypothesis that changed everything, Rosenberg's belief or Rosenberg's hypothesis which he placed forward was this: if a T cell can detect non-self between two humans, it must detect abnormal self in cancer. एवढी कॉम्प्लिकेटेड इम्युन सिस्टम आहे की आपण दोन जणांचे लिव्हर, विच पॅथॉलॉजी सुद्धा, म्हणजे पॅथॉलॉजिस्टनी जर सेक्शन घेतले तो सांगू नाही शकत की हे कोणाचं लिव्हर होतं आणि हे कोणाचं, इफ दे आर नॉर्मल. बट युअर इम्युनिटी कॅन टेल की हे लिव्हर असू दे पण हे माझ्या मनुष्याचं लिव्हर नाही आहे, मी ते घेणार नाही. The immune system is that complex. If it is so complex that it can tell two different organs from the same species, why can't it tell the difference between a normal healthy cell and a cancer cell? This was Rosenberg's simple belief. So he said, ठीक है, ट्रान्सप्लांट सर्जरी चलते रहेगा, I will devote my life to this also. आता जस्ट मोजत जावा की रोझनबर्ग किती वेळा फेल झालेला आहे. फर्स्ट अटेम्प्ट, डी अँजेलो नावाचा पेशंट होता, स्टेज 4 स्टमक कॅन्सर बरोबर, स्पॉन्टेनियस रेमिशनमध्ये गेला, मीन्स हिज कॅन्सर इमिजिएटली स्वतःच गायब झाला. फॅन्टॅस्टिक. रोझनबर्ग म्हटलं ह्याच्या रक्तामध्ये असं काहीतरी असेल, समथिंग इन हिज ब्लड इज प्रोटेक्टिव्ह, आय विल यूज हिज ब्लड सॅम्पल्स. रोझनबर्ग टेक्स सॅम्पल्स ऑफ हिज ब्लड, क्रॉस मॅचिंग करतो आणि क्रॉस मॅचिंग केल्यानंतर ही फाइंड्स अनदर पेशंट विथ स्टेज 4 स्टमक कॅन्सर अँड ही ट्रान्सफ्युजेस हिम द सेम ब्लड विथ द होप दॅट नाव ही विल रिकवर. काहीच झालं नाही. द पेशंट पास्ड अवे. दे आर ऑल स्टेज 4 कॅन्सर पेशंट. द पेशंट पास्ड अवे अ फ्यू वीक्स लेटर. फेलियर नंबर 1. सेकंड, रोझनबर्ग डज नॉट गिव्ह अप. ही रीच सम ॲनिमल स्टडीज जिथे ट्युमर्समध्ये, माईसमध्ये ट्युमर्स होते, त्यांना ते ट्युमर्स त्या माईसमध्ये इंजेक्ट केले, अँटीबॉडीज बनवले, मग परत त्या माईसमध्ये इंजेक्ट केले, त्यांचे ट्युमर्स कमी झाले. रोझनबर्ग म्हणला ठीक आहे आपण हे ट्राय करूया. त्यांनी 6 पेशंट्समध्ये हे ट्राय केलं. All 6 died, complete failure. It's been 6 years now that Rosenberg, besides doing transplants, is now working on this. 2 attempts, all failed. And nobody knows exactly what immunotherapy is at this point. ठीक आहे. रोझनबर्ग काय करतो, कॅन्सर पेशंट्समधनं परत ड्रॉ करतो सॅम्पल्स, पिग्समध्ये इंजेक्ट करतो, पिग्समध्ये एक ऑटो इम्युन रिस्पॉन्स तयार करतो, पिग्सचे टी सेल अँटीबॉडीज घेतो, त्यांना सीव्हमधनं प्युरिफाय करतो आणि इंजेक्ट्स देम बॅक इन ह्युमन्स. 24 year old एका गर्लमध्ये तो ते इंजेक्ट करतो, 5 billion टी सेल्स, शी पासेस अवे, नो रिझल्ट. देन देर इज अन ॲक्सिडेंटल ब्रेक थ्रू. ॲक्सिडेंटल ब्रेक थ्रू होतो म्हणजे समथिंग हॅपन्स, बट इट इज नॉट रोझनबर्ग. नॅशनल कॅन्सर इन्स्टिट्यूटमध्ये अ ग्रुप ऑफ सायंटिस्ट इज वर्किंग ऑन समथिंग एल्स ऑल टुगेदर. दे आर ट्राईंग टू रिक्रिएट कॅन्सर सेल्स इन अ लॅबॉरेटरी, लुकिमिया सेल्स. दे डोंट सक्सीड. ते नॉर्मल टी सेलला कॅन्सरमध्ये कन्वर्ट करायचा प्रयत्न करतात, बट व्हॉट दे हॅपन टू डू इज दे ओव्हरनाईट मेक मिलियन्स अँड बिलियन्स ऑफ कॉपीज ऑफ नॉर्मल हेल्दी टी सेल्स. रोझनबर्ग इमिजिएटली त्यांना जाऊन भेटतो, म्हणतो की हे कसं केलं मला सांगा. ते से काम डाऊन, अवर ट्रायल फेल्ड, वी वर ट्राईंग टू क्रिएट कॅन्सर, वी डिंट. Rosenberg says that's fine. How did you create so many T cells overnight? They म्हणतात we developed a new enzyme. That enzyme is called interleukin 2. त्यांनी त्याला नाव दिलंय. We discovered a new enzyme. Rosenberg says fantastic. Can you give me that enzyme? They say sure. Only one problem. आम्हाला एक ड्रॉप इंटरल्युकिन 2 बनवण्यासाठी 9 कोटी उंदरांना मारायला लागेल. एक ड्रॉप. रोझनबर्गला बक्स भरून इंटरल्युकिन 2 पाहिजे. But Rosenberg still doesn't give up. He has a final. Rosenberg still doesn't give up. He has a final Hail Mary movement. Hail Mary म्हणजे काय? एक लास्ट टाइम. There is a young girl who comes. Her name is Linda Taylor. She has an aggressive metastatic melanoma. रोझनबर्ग फक्त या एका पेशंटसाठी, आता 20 पेशंट नाही, 60 पेशंट नाही, एका पेशंटसाठी तो म्हणतो मी दोन्ही गोष्टी करून बघतो. ही इन्फ्युजेस हर विथ 9 million units ऑफ इंटरल्युकिन 2. Then he infuses her with 9 million units of interleukin 2. Then he also uses antibodies बाहेर कल्चर करून तिच्या टी सेल्समध्ये इंटरल्युकिन मधनं. He injects that also in her over a period of 4 sessions. She develops the worst possible side effects ever. Linda Taylor on the 3rd day ends up in the ICU. She's gone in hypotension shock, fevers reaching 105, 106. Rosenberg म्हटला ही बाई सुद्धा जाणार. But here's where things change. The cancer completely disappears when she comes back 3 weeks later. This is for the first time a human cancer was cured using only the activation of the immune system. For the first time, January 16, 1992 ला USDचा FDA approval मिळतो for high doses interleukins 2, the first immunotherapy of its kind for cancer for metastatic melanomas and RCC. Only problem is this, it is extremely toxic. जे पेशंट वाचले सुद्धा ते म्हणतात आयुष्यात परत कधी नाही. Extremely toxic, worked only a few patients and really even Rosenberg didn't know how it worked. Then there was backlash. Backlash का झाला? Around the same time दोन गोष्टी कळल्या. Human papilloma virus is responsible for all cervical cancers. HCC is caused because of hepatitis B and C virus. So people started postulating की रोझनबर्गनी बरोबर रिसर्च केला, but he misinterpreted his data. What they said that what actually happened is that many of these cancer cells might have been subclinically infected by virus. The T cell actually went and attacked the virus. Coincidentally cancer पण होता, cancer पण त्याच्याबरोबर खतम झाला. So it was not the cancer that the T cell was attacking. So again for the next 10-15 years nothing would happen. After that we are reaching 2000. Enter James P. Allison. James P. Allison हा डॉक्टर नाही आहे, त्याचं ह्या सगळ्याशी काय अच्छा टाइम आप अर्धा तास झाला, थोडा वेळ घेऊ अजून. So I'll wrap up faster. James P. Allison is a biochemist. He has nothing to do with cancer, but he is working on an enzyme which is used to kill cancer cells in the laboratory. Okay, and it does kill blood cancer cells in the laboratory, but there is nothing remarkable about that. Why there is nothing remarkable about that? Because आपण laboratory मध्ये cancer cells ना खूप वेळा मारले. Problem is when you use those agents in a human body, things become very bad. But he notices something. He noticed that when these cancer cells died, the macrophages came and they engulfed them. They 80-28 जेव्हा on होता, it is a signal to the T cell that go ahead and now. But then one problem arises. They found that despite these two things happening, many a times the T cell was not activated. So then there was the possibility that not to find the third signal. Unfortunately, at the same time, people start getting interested. The world's largest pharma company, BMS, one of the largest pharma companies in the world, BMS also gets in finding the third signal. The third signal is found simultaneously by both groups. It is known as CTLA4. But here's the thing, दोघांनी पेपर पब्लिश केले. पण जेम्स ॲलिसननी सांगितलं की द CTLA4 इज इन फॅक्ट अ ब्रेक. इट स्टॉप्स द टी सेल फ्रॉम गेटिंग ॲक्टिवेटेड. BMSच्या ग्रुपनी जो पेपर पब्लिश केला त्यांनी सांगितलं की CTLA4 इज द ॲक्टिवेटिंग थर्ड सिग्नल. इट इज अ गो सिग्नल, इट इज द ॲक्सिलरेटर, इट इज द गॅस पेडल. सो दे हॅड both discovered it simultaneously. They had different hypotheses on what it does. Unfortunately, एक दिवसांनी जेम्स ॲलिसनला BMSनी बीट केलं पेटंट. प्रॉपर्टी फॉर CTLA4 अनफॉर्च्युनेटली वेंट विथ BMS. BMS बरोबर इंटेलेक्चुअल प्रॉपर्टी गेली, बट दे हॅड गॉट इट रॉंग. दे हॅड नॉट फिगर्ड आउट व्हॉट CTLA4 डज. BMSचा कॉन्सेप्ट चुकलेला, जेम्स ॲलिसनचा एक आहे. नॉट ओनली दॅट, इतिहासात पहिल्यांदा कळलेलं की हाऊ कॅन्सर इव्हेड्स द इम्युन सिस्टम. Basically, cancers, when they evolve, they make their own CTLA4 molecules which are breaks. So the T cell does recognize the molecules which are breaks. So the T cell does recognize the cancer cell. But when it goes to attack, the cancer says, "Ye to stop sign hai. I have made CTLA4. You cannot attack me," because that. Simply, James Allison said, if we can make antibodies against CTLA4, we have a drug for cancer. He did it in mice. He created CTLA4 antibodies. He showed that it works. 25 उंदरांना त्यांनी कॅन्सर दिला आणि त्यांना CTLA4 antibodies inject केले. 100% of them got cured. Even he didn't believe the results. He did it a second time. He did it with 50 mice. All of them got cured with cancer. There was only one problem. Not a single pharma company was willing to fund him. Ka? Because the patent is with BMS and nobody in the world wants to challenge BMS because there is no way you can win against BMS. So this is what happened. Finally, last 2 seconds. Didn't hold the patent. So simple happened. काय झालं असेल? गेस मारू शकता? एकदम सिंपल आहे. बी मेटास्टॅटिक मेलानोमा एका US प्रेसिडेंटसाठी वापरलं गेलं इव्हेंट कंप्लीट रेमिशन्स. Today we have ipilimumab, nivolumab, pembrolizumab, sepilumab, atezolizumab, durvalumab, dostarlimab, retalimumab, and this is just a start. हे आता माझा कलिग आहे कुणाल तो ह्याच्यावर कार्टी सेलवर बोलले. This is also an extension of that. Carti cell is also an extension of that. Just my conclusion. This is just the beginning. Think of how far antibiotics came since we first discovered penicillin. Alexander Flemingने almost आता 100 वर्ष होत आहेत माझ्या मते. त्यांनी आता किती antibiotics आले तेव्हापासून. It's been decades. We have only just started discovering. 2011 में मिला, अभी 10-15 साल ही हुआ है. Oncology has just discovered its penicillin. Picture अभी बाकी. Thank you so much. And sorry, time is up. No questions. Okay, any questions related to cancer? Anything? Kai? Sorry? Kai sir? Time is up. I agree.
Thank you, Dr. Salil Patkar, for such a wonderful, interesting, and by offering a memento on. I request, yes, Dr. Salil Patkar to felicitate our chairperson, Dr. Shripal Jain and Dr. Dhawale. It's time for our second lucky draw. I request Dr. Salil Patkar to do the honor, which is sponsored by Dr. Pushpak Chirmade Cancer Center at Thane.
Dr. Aditi Karve.
Oh,
73 number.
Dr. Karve sir.
Congratulations.
We will continue our next sessions with Dr. Anirudh Joshi sir. I request him to come on the dais.
Good morning. This is our 5th lecture, which is liver and kidney transplant. Why go far? Delegates, we now move to an interactive and clinically relevant session. Let's have a panel discussion about liver and kidney transplant. We are privileged to have a panel of expertise with us, Dr. Ravindra Gawat, Dr. Ananda Ramurthy, Dr. Aniket Hase, and Dr. Lokesh Sinha. I request our chairperson, Dr. Rahul Patil, Dr. Ritesh Jain, Dr. Kisan Mohite, to please escort the dignitaries on the dais. Sir, welcome. Welcome, sir. I request the chairpersons to please welcome our dignitaries.
4 माईक लागतील. लकी ड्रॉ कुठे गेला?
लकी ड्रॉ घेऊन आतमध्ये या.
Thank you. Now, before we commence our scientific program, I request our dignitaries to please announce the lucky draw winner. This lucky draw is MOC Hospital. And the winner is
Dr. Bhavesh Oswal, 103.
Dr. Bhavesh Oswal. Congratulations, doctor.
Congratulations.
We are honored to introduce our guest speakers to this panel discussion. Our first guest speaker, Dr. Ravindra Gawat, is a director of critical care department with more than 12 years of experience as a senior intensivist at Jupiter Hospital. Sir, an MD DCCM, his expertise in ICU care, sepsis management, respiratory failure, and is highly experienced in intubation, bronchoscopy, and critical resuscitations.
Our next panelist, Dr. Anand Ramurthy sir, who is senior liver transplant surgeon with more than 20 years of experience. He is one of the pioneers of liver transplant in India. Sir is director of liver transplant and hepatobiliary pancreatic surgery. He is also the founder member of South India's first successful liver transplant program and also the founder of Liver Transplant Society of India. Ramurthy sir has trained at Sir Gangaram Hospital, Delhi and King's College Hospital, London.
Our third panelist is Dr. Aniket Hase, who is consultant nephrologist and transplant physician who practices at the Jupiter Hospital. Sir has done his DNB General Medicine and DNB Nephrology, Medicity, Delhi and Fortis Hospital, Mumbai, and has 8 years of clinical experience.
Last but not the least, we have Dr. Lokesh Sinha sir, who is consultant urologist with more than nearly 9 years of experience. Sir has great expertise in endourology, laparoscopy, advanced stone disease management, and is a gold medalist in general surgery. Not only this, he has also published researches in national and international presentations. Dr. Lokesh sir also
Good morning and thank you organizers for having us here, and we are going to discuss some very interesting topic of transplant medicine and surgery, both liver and predominant focus on liver and kidney, and it's a panel discussion and it's an interactive session. So I would request all the audience as well to participate on a transplant program or the patient has to be transplanted. In that context, organ donation is so important. So my panelists have been already introduced. So we'll start with the case. The 65-year-old male meets with a road traffic accident, suffers a head injury. He was admitted to a nursing home, in peripheral nursing home like many of you would be practicing here. He is intubated because his GCS is around 5. Craniotomy was done after a few days, next 24-48 hours. Decompression craniotomy was done to reduce the edema, but the patient continued to deteriorate. He deteriorated further after 48 hours, and now you on round found that the patient is having dilated fixed pupils. However, his blood pressure was 140/70, his heart rate is 78 and saturations are 100%. So my question to you is, with the dilated fixed pupil, will you say that this patient is dead? Any takes? This is an interactive session. Is he dead or not? He is brain dead. So somebody said brain dead. Dr. Aniket, do you agree he is brain dead?
So for brain dead, we need certain criteria to be met.
Absolutely correct. So brain death is not something, some term which you can use that, what you say, loosely. So it usually happens in our practice when we come across such patients and we find that pupils are dilated, fixed, okay, there is no response, and the blood pressure is okay, with maybe with some noradrenaline support or whatever. And we tend to tell the patient and relatives that the patient is brain dead, and they would not understand what is brain dead. And it is also not right on our part that whether the patient is actually brain dead, right? Now, because brain dead is not like routine cardiac death where everything is evident. In routine cardiac death, the ECG shows a flat line and you can, or the pulse is not palpable, and you can easily say that the patient is dead, right? But if brain death requires certification with certain criteria, you have to fulfill certain criteria. You have to demonstrate that these criteria are fulfilled, the tests are positive, and then only you should utter this word that the patient is brain dead. Otherwise, it becomes a problem. So what are the criteria? Brain death is an irreversible coma with no evidence of brainstem reflexes. You have to go through all the drills of, checking those brainstem reflexes, and there is definite difference between a brain death and a coma. A comatose patient may not be brain dead, right? But the brain dead patient is definitely comatose, right? It is that way. So coma patient means they would have some spontaneous breathing effort. They might be breathing on their own. They might have a tracheostomy and breathing without a respirator, or would be on respirator, but there is no cranial nerve reflex, and you need to rule out some confounding factors, and you need to prove it with an apnea and a calorie test, and then only you can say that the patient is brain dead. So don't use this term very loosely. Now the next question comes is, can this patient, if you say this patient is brain dead, can this patient be declared at your nursing home? Can you say, you said brain dead, okay? So can you declare brain dead and give the body to the patient? Right, the patient is obviously going to ask you, what, BP to acha dikh raha hai? The BP is there, monitor pe you see the heart rate, when they check the pulse, okay, pulse is there. Doctor, how are you saying the patient is brain dead? How are you saying that patient is dead? That's why this term should not be used very loosely, right? So can you declare patient brain dead at nursing home? No, you cannot, but you can as well. If you have some brain death committee which has certified, and these brain death committees are available in bigger hospitals. They are not available at nursing home, but at bigger nursing homes or bigger middle level hospitals, you can definitely form the brain death committees, right? And the law endorse it. And those brain death committees only can declare that the patient is brain dead. And the brain death committee comprises of, Aniket, you want to answer that question?
It comprises of a neurologist, a neurosurgeon, a general surgeon, and a practitioner, an ICU intensivist.
So you need to have a committee of 4 people who actually endorse or who certifies that the patient is brain dead, and you need to have tests which are done 6 hours apart. The apnea and the calorie test, which will, with absence of brainstem reflexes, you test all the cranial nerves, you rule out all the confounding factors, and then say that the patient is brain dead. Right? The other option is you can shift such patient to the bigger hospitals if the relatives are willing for donation. We will come to that. So the question is, if you do, or if you declare brain death, or form a committee, the usual apprehension is, will I be implicated in some medico-legal hassles, isn't it? That is, the trauma patient hai, whatever brain death zala hai, pupils dilated, fixed hai, relatives तसे, they make lot of ruckus at the nursing home level. आपल्याकडे security तेवढी नसते, we can't afford also that much security. बरोबर ना? आणि पॅनिक मोड, दे आर इमोशनल. यंग पेशंट असतो मोस्ट ऑफ द टाईम. हा तर 64 year old होता, बट युजली पेशंट्स आर यंग वेन दे डाय, अँड इट्स अ व्हेरी टेन्स सिच्युएशन फॉर ऑल ऑफ अस, इजंट इट? सो आवर ॲप्रिहेन्शन इज, विल आय, ये तो ठीक आहे, आय मीन relatives right, but will I also be implicated medically? Am I going to face some problems if such things happen and I declare? So our usual response is that sab band kar do, dhire dhire let the patient go, right? And we tell them, as a treating doctor, will I face some challenges? Will I face some problems, charges? The answer to this is no, if you do everything correctly. Okay, so the best thing is that if, as I said, that there is a paucity of organ available for patients who are suffering from end-stage kidney, liver or many diseases, right? And they don't get organs because there are no live donor available, and at the same time there are no cadavers available. That is why there is an urgent need for identifying such patients and then transferring them to a bigger hospital where organ donation can be carried out. Now the question is, can this patient be shifted to Jupiter Hospital or any corporate hospital that which is nearby? Will you take this patient, 65-year-old suspected brain death?
So provided if the hospital where the patient is present does not have a brain death committee, and if the patient's relatives or family on being counseled about the possibility of brain death, they either want to hire medical care or they express interest for organ donation. In those cases, they can be shifted to
So if you have such patient who is willing for organ donation, you can definitely shift this patient to any bigger hospital which is nearby, which has a brain death committee, right? And you are not wrong in it. You will not be implicated medically in this case, neither the responsibility will be yours. The only thing is that the willingness of the relatives, and you need to actually talk and give donation, right? Because it would save many lives. That is very important. Rather than leaving it like that, not taking the responsibility, which we usually fear of, that ko ye jhanjat mein kaun padega. So there is no jhanjat. In fact, many hospitals in Thane and around, where we send our team, we send our ambulance, wherever there are potential organ donors, we go there, we assess them, we find out that they are like potential organ donors, get them to our hospital at Jupiter, manage them, and subsequently, of course, if the family is willing, and then they donate organs. Right? We carry out tests, we maintain them, we resuscitate them well. We also make the organs little better. Somebody's creatinine ज़्यादा रहता है, कोई hypotensive रहता है. You know, some liver functions are deranged. ATN हो जाता है. So all these things we manage. Infection हो जाता है. Very doable. And I would urge through this panel discussion that if you find some such patients, you must sort of talk to them or give them an option of organ donation. In fact, many countries like Spain, who have maximum number of organ donation, right? Amongst the world, the maximum number of
chronic long-standing illnesses like diabetes, hypertension, heart disease, etc. The third thing is that once they should not have any major addictions like alcohol or other diseases that can independently affect the liver or other organs in the body. Once these general criteria are met, then we do a medical evaluation. Medical evaluation in a donor is as thorough as a recipient evaluation because we do not want to take any risks on the part of the donor. The donor is a healthy individual who is donating a part of their organ to save the life of their loved one. So therefore, the priority is not to take any known risks on the part of the donor. So we do a thorough medical evaluation, first level being like a general health checkup, second level being where we assess the liver quality, the fat content, the size of the liver, the structure of the liver, make sure that the liver is a match for the recipient, and the third level is where the donor undergoes a thorough screening to assess fitness for surgery, cardiac, pulmonary, anesthesia, fitness to undergo surgery, and the fourth level is where they have to get permission from the authorization committee. The authorization committee can either be in hospital or it's a government constituted authorization committee where they have to get approval. So only once all these criteria are fulfilled, then we can go ahead with donation.
What about kidney?
So similarly for the kidney, the age of donation above 18 years and the maximum age can be as high as 65 to 70 years. So now current guidelines say biological age has to be considered. So we have to see how healthy the individual is, any comorbidities, And similar, like sir said, for the liver, similar steps of evaluation. Step 1 is general evaluation. Step on one kidney, that donor is going to survive, and plus it is adequate for the recipient. After considering all these factors, a thorough evaluation, donor can be taken. Also for diabetic and hypertensive donors, they can be accepted after thorough evaluation, and we find that there is no end organ damage in those patients, especially if they are considered only if they are above 55 years.
So that was for live donation, right? That age criteria is a little sort of stringent and strict when you are talking about live donation. If you have a donor which is 75-year-old for liver or 70-year-old for his son, will you take that? Probably not. Or depends on biological age.
No, because there is no, like, it's not a black or white cutoff. So in general, the risks over the age of 55 tend to get more. So that is why the age limit. For pediatric, we relax it to about 60. Beyond that, we do not. I mean, because this is not a very clearly defined cutoff, the biological age. It's a educated guess at best.
Same thing must be true for kidney also, right?
Yes.
Like with growing age, your organs are lose reserves, right? So it becomes little difficult to take one of them out, right?
Yeah. So for the cadaveric,
that was my next question, because this patient was 65-year-old who is probably a potential organ donor. So whether the criteria for this age as far as donations is concerned is same for liver, same for the live donor versus the cadaver donor. So for cadaver, do you extend the criteria a little bit?
So for the cadaver donor, the age criteria extends, as Dr. Anand also said. Here the safety and the organ remaining with the donor is not a criteria, because we will be retrieving whole liver or both kidneys. So here the criteria are to see whether those liver or kidneys, if we are taking independently, or sometime if it is a too much extended criteria, we may take as a dual transplant, when the donor is either very aged with some comorbidities, or if it is a pediatric donor where the size of kidney is very small, then we take dual kidney to the single recipient. The age criteria changes.
You will take two kidneys
in the single recipient.
Single recipient.
So the age criteria changes. We see the health of the kidney, whether they will be suitable for the recipient, and then we try to find the suitable age recipient also. If the donor is too aged or is a diabetes, hypertension, where we suspect the kidney function may not be very good, we go for elderly recipient as well as for the dual transplant, for the two kidneys to the one patient.
Right, correct. So when you are talking about cadaveric donor, because the number is so less and the demand is so high, right, and there is paucity of organs, the government or the organization which is set by the government has ZTCC, we call it as, they have extended the criteria to across the world also, in India as well, to around 75 years of age, right? And sometimes if you have borderline infections, you can implant two kidneys in one recipient. And similarly, because you get a whole liver, right? So it's not that you cut a liver and then implant, you implant a whole liver. So you can probably have a borderline donor there, which would be functional. The next question to Aniket is that which are the organs, apart from liver, kidney, we know, which are the other organs which can be retrieved from a cadaver donor? Live donors, of course, it will be 1-to-1. Live donors, only liver and kidney is possible. Heart is not possible, right? That's not possible, na? I was just checking whether you people are attentive. So those who smiled were attentive. Those who did not smile were not attentive. Can you take the heart? No. Can you take the brain? No, you can take if it is like somebody is eating up too much. Isn't it? Then you can say you can probably donate your brain. So which are the other organs which you can actually retrieve?
So from deceased donor, we can take pancreas, especially pancreas kidney, usually in the type 1 diabetic and certain type 2 diabetics are preferred. Then intestines, then other tissues like bones, cartilages, eyes, some vein grafts, these are also taken.
Pancreas, intestine, heart, lung, there are skin, eyes, there are so many organs which can be taken up apart from liver, kidney. So one donor, one cadaveric donor, one live donor will save one life, whereas one cadaver donor can save number of lives, at least 7 to 10 lives the patient can, a cadaveric donor can save. So that is an advantage of cadaveric donor over a live donor. You can give one kidney to one person, another kidney to another one liver to one person. If it's a pediatric one, you can give a small chunk of liver to pediatric patient and rest of the liver to another cirrhotic patient or somebody who requires it, right? And then of course you have intestine, you have kidneys, you have pancreas, you also have lungs. Lungs both have to be transplanted in one patient, right? It is not that you give one lung to one person and even heart can be transplanted, right? So many lives can be saved by one donor. So that is why cadaveric donation is so important, and we as a fraternity doctors need to take a lead now in increasing the number of cadaveric donors so that many lives can be saved. Dr. Ramurthy, how safe is this live donation? If somebody wants to donate a liver, usual concern is मेरे liver को क्या होएगा? तुम्हारा तो ठीक होएगा दूसरे का, but मेरा क्या? Or for that matter, if one person donates one kidney, what happens to the donor who is living with only single kidney?
So, first of all, the priority is donor safety for all living donor liver transplants. Again, as I said, the live donor is a healthy person who's donating their organ to save the life of their loved one. So, any known risk, given the extensive evaluation that we perform, if at any stage we detect a known risk that could impair the safety of the donor, we do not proceed with organ donation. We either ask them to come up with an alternative donor from the family, or we list them for a deceased donor organ transplantation. So we do not take any known risk on that part. The second thing that is important to know from an organ standpoint is that we all have about a 70% functional reserve of the liver, which means 70 to 75% of our liver is over and above what we require for normal metabolic function of our body. The liver also has a unique property in that it grows after donation, both in the person to whom it is transplanted to and in the donor in whom it is remaining. So the growth is initially very rapid over the first couple of months, and it grows to about 80% of its original size. And after that, growth continues, although at a slower rate, till the growth is essentially complete by about 1 year of age, 1 year of after donation. So because of this unique property of the liver, we are able to go ahead with living donation for the liver.
So very interesting fact that for the donor, except the surgical risk, then it is absolutely smooth, right? And the surgical risk is like any other surgery, which is hardly 0.1%, right, where then can get complicated. Otherwise, it is a very safe surgery for the donor, and the liver absolutely comes back to normal level within 1 year, and 80% to 90% function by 6 months. And the growth happens by 50 to 60% more in the first 4 to 6 weeks. So that is the beauty of liver donation, because the liver cells can regenerate, right? So it becomes normal. So you are again back to the same liver that you were. What about kidney?
So the kidney doesn't regrow like liver, but yes, as sir said, with every checkpoint in our evaluation for the donor, we see that donor safety is the priority. And at any point of time, we feel that any general medical condition is going to hamper the donor's future course of life, we do not take that donor. Individual kidney functions are assessed with a DTPA scan, and then we determine whether it is adequate. And after giving one kidney is sufficient for that donor for lifetime. And the risk of donation overall, even if, so the standard risk which says is, even if you donate or don't donate, the risk of getting kidney disease remains the same. But if patient has some underlying comorbidities, then over the 2-3 decades, the risk may increase by 0.5 to 1%, but still the overall absolute risk remains below 1% for the donors.
What is the next slide? Usually audience questions are at the end of the talk, right? But I am not going to give you that privilege. I want you to be attentive. If you have any questions till now, because we are going to move to the next section, that is of transplant. So as far as donation is concerned, because wherever I talk about organ donation, I usually find a lot of questions in the minds of the doctors and people. Lot of concerns and questions. No questions? That means in next year we are going to see hundreds of organ transplants or referrals of cadaver donor to different. Sorry? Within how much time we can take the organs? Good question. Thank you so much.
No, the priority is to keep the organs out of blood circulation for the minimum time possible. Okay, so rest depends upon logistics. When we have an in-house donor, that is the donor is located within our own hospital and the recipient is also located within the same hospital, then we do it in two adjacent theaters like operation theaters. And our cold ischemia, that is the period of time for which the liver is out of blood circulation, can be kept down to as little as 3 hours to 4 hours, which is just about an hour more than live donor liver transplantation. So it is very similar, the live donor waiting time, cold ischemia time, and the deceased donor cold ischemia time.
So probably she wants to know about the maximum time that you can wait.
So again,
so suppose the retrieval happens at Karzar, and then the transplant is happening at Jupiter or some other hospital?
Oh.
Jupiter, okay.
So now that depends upon the traffic. So you can reach there in 1 hour, you cannot
how
reach,
much time?
you may
How
not.
much time you permit?
So beyond 6 to 8 hours for a liver, we would be very, very careful, because we need to balance out the other risk factors. For example, in the case that Dr. Ravi has presented, the donor is already elderly. If the liver were to be fatty, or if there were any other problems like diabetes, hypertension or other things, then you want to balance out that risk by keeping the cold ischemia time low. So we only control what are the controllables or what are the modifiable risk factors.
What
so
about
beyond
kidney?
6 to 8 hours.
What about kidney?
Kidney can go up to the 24 hours, sometime beyond that also, but it has to be, if you are thinking that the implantation time will be more, it's better to preserve the kidney well perfused with the UW solution, keep it proper hypothermia, and now there is a continuous hypothermic machine, continuous flow has come, where you can just keep the kidney in that machine which continuously infuses the kidney with hypothermic solution, and the ischemia time up to 24 to 30 hours can be accepted for the kidney.
So to answer to your question, there are different timelines for different organs, which you can actually have that what is called as a cold ischemia time, right? Where the organ can be transferred from one center to other, and the least time that the organ can sustain an ischemia is heart. So that's why when you are talking about a heart transplant, you need to create a green corridor, which is not very true. Ideally you should, because earlier the organ would go to the transplant center, better are the results, isn't it? Because cold ischemia time more, the injury is more. So the heart has the minimum ischemia time of 3 to 4 hours, so maximum you can extend it up to 6 hours, whereas other organs like liver can sustain an hypoxia up to 6 to 12 hours. Kidney even can go up to 24 to 36 hours, right? And same is true for intestine also. It has to be again around 12 to 24 hours, intestine and pancreas. But the important thing is now newer techniques are coming up which do a regional perfusion, like ECMO. You have an ECMO for the whole body, extracorporeal membrane oxygen. You also have ECMO for particular organ. So you can selectively perfuse the liver for n number of hours. You can selectively perfuse the kidney for n numbers of hours, and then because there is no ischemia then, because you are perfusing it externally, and the ischemia time can be extended. You are talking about cadavering transplant, donation or transplant?
Any further lifelong
transplant?
Any further lifelong treatments to be taken for these patients?
You are coming to that?
Yeah. I mean, there were two questions. One question is why there is, lack of donation in our country. Why the programs are not really.
Is it our government's policies, or
what are the
it is
policies,
a supply?
Yeah.
Less supply.
And what was the second question? Sorry, I missed that because I was listening to this.
Second is the lifelong treatment follow-up for the recipient. That will be discussed.
Yeah, we'll be discussing your question later.
And
we will come to that.
What will be the
side effects, or
side effects?
Yeah, how the patients are going to flare,
Yes.
or survival and everything.
And how much expenses he has to spend?
Yeah, that we'll discuss. So, Aniket, you want to answer that question? Why there is lack of donation, like why our country is facing so many challenges as far as donation is concerned, where the demand is so high and the supply is very less.
So the answer is awareness. There is no much awareness also.
I would also like to know from the audience, what do you think? Why the donations are so less? One, he answered is awareness. Awareness among whom? People. Who are the people? Doctors. Right. So we also are included in people, right? So honestly, if I had to ask a question, how many of us know about organ donation? How many of us know about, these many organs can be donated? Now we talked about it. How many of you knew about this? How many of you knew about the cold ischemia time? How many of you knew about the corridors, green corridor? How many of you know about the process? Right? How many of you know that it is not a medical legal problem? Right? How many of you are scared? And how many of you actually were involved in an organ donation or a cadaveric donation when you had seen such patients? I am sure all of us have seen a brain dead patient in our hospital or any other hospital or in our practice. But how many of us are have proactively done? So that there lies the problem. So it's apathy or lack of awareness on the part of doctors, lack of awareness on the part of general public who are non-doctors, and of course the organizations, that is government and the non-government organizations, are not also very proactive, right? It is not very rewarding.
So one incident just last happened. Now the government and the Institute of Awareness is also improving. We have one in-house donation at the Jupiter Hospital, and we requested the civil surgeon, and he came and did the post-mortem in our hospital only. So that saved the time for the patient who was donating to shift to the government hospital to post-mortem. So now the government is also coming up with the plan to reduce the body handover time.
So the things are picking up. To answer your question, the awareness programs are more. The doctors are becoming more aware through programs and knowledge. Even on radio, FM, TV, also in advertises, you are seeing people are talking about organ donation, right? You can listen to FM, and the ZTCC is giving some different doctors mentioning about organ donation. So that is increasing. There are a lot of other factors like emotional factors, financial factors. Patient को लगता है कि if I am donating organ, 2 दिन रहने का खर्चा कौन देगा extra? Till the organs are donated, I will have to bear that expenses. The other thing is that people think that if I am donating my organ, it should go to my relative. They would ask you, if I am donating, ये liver इसको देना है, ये kidney इसको देने का है, वो kidney उसको देने का है. So they want to choose their recipients, which is again not possible because it's a voluntary donation. So these are the challenges in our systems. Probably they are getting better over a period of time. The government has also become very, very proactive. The non-governmental organizations are also coming up in a big way. The hospitals are carrying out many awareness programs, and what we need to have is probably inclusiveness from the government hospitals, right, which is there, but it is not to that extent where it should be. Now let us come to the second section, that is about the transplant. You had some question. Probably yes, it was there, but now, as I said, the government is very proactive. The policy makers have understood the importance, because many of them also required organs. Can he get a mic? Can he get a mic?
So that's why the rules are not that complicated. We assume that it has to be complicated. So if you have any patient who is supposedly brain dead, the relatives are willing, so it's better to coordinate with the hospital who is doing transplant, because their transplant coordinators know the rules very well. As I told, the last transplant we did in-house was a head injury, which was a medical legal case which needed post-mortem. Everything the government and the government hospital arranged in-house. The civil surgeon came to the hospital, he did post-mortem, so the body handling time reduced. Otherwise, the relatives, all apprehensions, even doctors' apprehensions are now being easily answered by the coordinators, transplant coordinators.
I will tell you, this is very easy. This is absolutely easy. The only thing that you need to do is inform the hospital which has a brain death committee or a nearest hospital which has a brain dead committee and who are willing to take the patient. Rest everything, I am telling you, we have so many patients which we get from nursing home or smaller hospital when the relatives are willing for organ donation. We send our team, the coordinator goes, he checks, we check whether the patient is brain dead, and then the rest of the everything is taken care of us. There is no medical legal liability, there is nothing. It's absolutely easy and it is absolutely hassle free. So many patients in recent last 3 months, we must have had 5 to 6 patients which were transferred from other hospital to Jupiter Hospital just for organ donation because the relatives were willing, and we took care of everything, you know, including transport and so on.
Sir, I want to add up, can I?
Sorry?
मे आय सगळ्यांना नमस्कार. मी डॉक्टर शीतल जोशी, मी ॲडिशनल सिव्हिल सर्जन आहे. मी अलिबागला असते. म्हणजे आय एम रिप्रेझेंटिंग गव्हर्मेंट इन्स्टिट्यूट राईट नाव. म्हणजे जे आपलं डिस्कशन चालू आहे त्याच्यामध्येच मला ॲड करायचं आहे की आता जसं सर म्हणाले की गव्हर्मेंट इन्स्टिट्यूट्स आर व्हेरी प्रोॲक्टिव्ह, तर दिस इज द फॅक्ट. नुकतंच सिव्हिल हॉस्पिटल आणि GMC अलिबाग आम्ही एकत्रित मिळून ट्रान्सप्लांटसाठी रजिस्ट्रेशन केलं आणि आम्ही सगळ्याच प्रायव्हेट हॉस्पिटल्सना आवाहन करतो आहे. म्हणजे 30 बेडच्या वरचे जे हॉस्पिटल्स आहेत किंवा ज्यांच्याकडे ICU आहे आणि ज्यांच्याकडे फंक्शनल OT आहे, या सगळ्या प्रायव्हेट हॉस्पिटल्सनी ऑर्गन डोनेशनसाठी रजिस्टर करावं असं मी आवाहन करते सगळ्यांना. आम्ही गव्हर्मेंट हॉस्पिटल रजिस्टर केलेलंच आहे, पण रायगड जिल्ह्यातलं फक्त एकच हॉस्पिटल जर रजिस्टर्ड असेल तर तेवढं पुरेसं नाही आहे. आता पनवेलमधली काही हॉस्पिटल्स रजिस्टर्ड असतील, म्हणजे पनवेल, कर्जत वगैरे हा एरिया थोडासा जो मुंबईच्या जवळ आहे, तिथली बरीचशी हॉस्पिटल्सनी तर जास्तीत जास्त रजिस्ट्रेशन करावं. आणि इवन साऊथ रायगडमध्ये जिथे फार कमी ॲक्सेसिबिलिटी आहे तिथल्या मोठ्या हॉस्पिटल्सनी सुद्धा रजिस्ट्रेशन करावं असं मी आवाहन करेन. आणि इथून याच्याही पुढे जाऊन आपण सुद्धा स्वतः सगळ्यांनी ऑर्गन डोनेशनसाठी रजिस्टर करावं असं पण मी आवाहन करेन. एक QR कोड असतो, त्याला फक्त आपण स्कॅन करायचं, आपले स्वतःचे डिटेल्स टाकायचे. म्हणजे जसं सर म्हणाले की अवेअरनेस, म्हणजे आपल्यामध्ये सुद्धा अवेअरनेस नाही आहे. आता आपल्यामधल्याच किती लोकांनी रजिस्ट्रेशन केलेलं आहे, मला नाही वाटत फारसं कोणी केलं असेल. आपण स्वतःसुद्धा रजिस्टर करूया आणि आपण आपल्या हॉस्पिटल्समध्ये, डिस्पेन्सरीजमध्ये तो QR कोड लावूया. ज्यांना रजिस्टर करायचं आहे त्यांना रजिस्टर करू दे. म्हणजे लोकांना माहितीच नसते, आपल्यालाही माहिती नसते. आपल्याला जी माहिती मिळाली आहे ती आपण लोकांपर्यंत पोहोचवूया. ज्यांना व्हॉलेंटरीली करायचं आहे त्यांना करू दे ना, पण ज्यांना माहितीच नाही आहे त्यांच्यापर्यंत माहिती पोचवायचा तरी आपण प्रयत्न करूया. सिव्हिल हॉस्पिटलमध्ये अनेक ठिकाणी आम्ही ते QR कोड लावलेले आहेत. वॉक इन पेशंट्स असतील, रिलेटिव्ज असतील, एनीवन कॅन रजिस्टर, एनीवन अँड एव्हरीवन कॅन रजिस्टर. आणि आम्ही जिथे जिथे कॅम्प्स घेतो तिथे आम्ही ऑर्गन डोनेशनची शपथ घेतो. आणि म्हणजे ज्या कम्युनिटीमध्ये, ज्या लोकॅलिटीमध्ये आम्ही जातो, म्हणजे माझी टीम जिथे जिथे जाते तिथे आम्ही ऑर्गन डोनेशनसाठी अवेअरनेस करायचा प्रयत्न करतो. Thank you so much.
Thank you, madam. That is a great initiative you talked about, and we really appreciate that. And we want it to be spread everywhere in the corners of the state and the country. And then obviously my surgeons would want those patients to be referred to them. What is the end stage liver disease? Let's come to the next section. When you say that this patient requires a transplant now, right? Enough is enough. First liver and then kidney.
Okay.
Recipient भी तो पता चाहिए ना? Who is a good recipient, who is not a good recipient?
So basically, when there is evidence of progressive, irreversible liver failure, then the patient needs an organ transplantation. Unlike kidney transplantation, where the patient goes on dialysis, there is no machine that can take over the functions of a liver. So once it is established that the patient, what are the signs of liver failure? The cardinal signs of liver failure are 4. Basically, the first decompensating symptom for a patient would be ascites or pedal edema, and second would be variceal bleeding, third would be jaundice, and fourth would be encephalopathy. So when a patient develops any of these symptoms, then we can establish that the patient has liver failure. Then we have mathematical models which can score the severity of the liver failure, and based upon that we tell that this patient has liver failure needing liver transplantation. This is for cirrhosis and chronic liver disease. Again, there can be other conditions like severe acute injury, like which can cause acute liver disease or fulminant liver failure as it is sometimes called, and sometimes acute on chronic liver failure. So these are some categories of liver failure that are present, and all of these, when it is established that the patient has the organ failure, then the only curative treatment is organ transplantation. Then on, what we have to make sure is that the patient is medically a suitable candidate to receive an organ transplant. That is, what are the other comorbidities that they have, whether the other organ systems are doing their function well, whether the patient is overall fit to receive a liver transplant, and this we ascertain by doing a formal medical evaluation.
What about kidney?
So again, the kidney failure are two types of failure. One is acute kidney failure, or it is called as acute kidney injury, or chronic kidney failure. Acute kidney failure is one where the kidneys are normal, there is a temporary failure and it recovers. While chronic kidney failure is the one where it is progressive, and then it progresses and goes to end stage kidney disease. That is when the kidney function is less than 15%, and when kidney is not able to do its function, like throwing out water, throwing out waste products, managing acids, sodium, potassium, and when that occurs, then our kidney needs support. Now support can be in form of either a machine or a transplant. Machine is our process we call as dialysis, which is an artificial kidney which does the function of the kidney, and other option is transplant, kidney transplant. So as sir said, again, the suitability for a candidate for transplant is that patient is in end stage kidney disease and patient other organs are fit to undergo a major operation or a surgery which will support again further the transplanted kidney.
Okay, so that is the time when actually you should refer the patient to a specialist, right? That you should not delay referring, otherwise the patient goes, have repeated admissions and they will die, right? So for kidney failures, end-stage liver failure or end-stage liver kidney disease, you should refer the patients to nephrologist and to the hepatologist, right, who is taking care of the liver patients, right? I think they have addressed the correct timing for transplant as well when the patient is really sick.
Only thing I would like to add is that all our organ systems are interdependent on one another. So it is not possible that one organ is in severe failure and the other organ systems are functioning perfectly. So every organ system gets affected by it. So the best timing for an organ transplant, especially say a liver transplant, would be when the liver alone has failed but the other organ systems are performing their functions effectively. So that is the time when the success rates would be the best, hospitalization would be least, and the cost would be the least. Normally when we, therefore we should refer the patient early because they need to look for two things. One is they need to find a suitable donor or wait on the wait list for a transplantation for a cadaveric organ. Second is to organize their financial things. So these are not directly related to transplant, but this is something that the patient needs time for to prepare themselves financially, physically, mentally. They have to prepare themselves. So all this process takes time. So it's not like a patient comes to us and we are able to do a transplant in a short period of time. So they
require evaluation, that you mean to say. So properly the patient needs to be evaluated before going for transplant, and that can happen with follow-ups on OPD basis as well, and then IPD whenever it is required. And they would be put in the list also as per the ZTCC, the transplant committee, where the first priority patient would get the organ as far as cadaver donor is concerned. If it is a live donor, then the list doesn't matter because it is between the donor and the recipient. Okay. Can cancer patients also have, like liver cancer? One sentence answer. Can liver cancer patients have a transplant?
Yes.
Yes.
Liver cancer patients can undergo transplant provided the cancer is confined to the liver and has not involved any major blood vessels.
What about kidney cancers?
Yes, they can undergo, as said, they are confined, they are not spread, and after certain waiting period defined for each cancer.
Now, the world is going from invasive surgeries to minimally invasive surgeries. Like you must have heard about laparoscopic surgeries being done in every field, including neurosurgery, right? And even robotic. So, Dr. Sinha, Lokesh, do you also do kidney transplant that is minimally invasive?
Yeah.
And are there any advances in liver as well? Quickly, if you can answer that.
So, when we say minimal invasive surgeries, like it is the surgery where we do minimum cut on the body with the maximum or optimal outcome compared to the open surgery. So, the transplant, as we saw, live transplant is composed of two surgeries. One is a donor surgery and one recipient surgery. In the past, donor surgeries used to be open, which used to be 11th rib cutting, muscle cutting, and a big incision, which used to be severely painful because of rib cutting and muscle cutting. Patient has a pain lasting for years and years. because of nerve involvement. Now, for last almost 2 decades, donor surgery has been replaced by a laparoscopic donor surgery, which is a very small phalangeal incision to remove the kidney, and whole surgery of removing the kidney is done laparoscopically. The advantage is the patient has very little pain, the patient can move early very fast, recovery is very fast, rest is not required, and the cosmosis is very good. So it's now very gold standard. Everywhere the laparoscopic donor is the gold standard. In the recipient surgery, the gold standard is open, because what we see is the kidney function is the priority of a transplant. But now over the last 5 years, with the advancement of robotic surgery, which can do complex minimal invasive surgeries like suturing, because robotic recipient surgery requires complex vascular suturing, where you have to anastomose artery to the recipient artery, renal vein to the recipient vein. And over last 5 to 6 years, multiple institutions have started doing it robotically, where the outcome of the kidney transplant function is equal to the open transplant surgery, recipient surgery, but with the better cosmosis, better post-operative recovery. We have seen now we have done almost 35 robotic recipient at Jupiter Hospital and our team in the hospital. So what we have found is there is a kidney function outcome is same, but the patient recovery, mobility and going to the normal work, the wound infection, because the patients are on high immunosuppression medicine, is very less with the robotic surgery. So now I can say for the donor, laparoscopic donor is gold standard, which has to be done, offered to the all donors. And robotic recipient surgery is in upcoming graph, where the outcome is similar to the open surgery with a better patient recovery time. So in the near future, it will also still become the gold standard for treatment of robotic recipient surgery.
Are we seeing it in liver also? Quick answer.
Liver is a far more complex surgery,
so it is,
and
as
we discussed, donor safety is something that is of paramount importance. So it has been done in select few centers, especially donor hepatectomy, both laparoscopic as well as.
So it's coming up. It is still not established
still not
completely.
well
Yeah,
established.
but it's coming up, and in near future it will be. Do you sometimes also do emergency transplant, liver transplant?
Yes.
Which are the patients who require emergency liver transplant? If you can name 1, 2, 3, 4.
So patients who come with the acute liver failure or a fulminant liver failure caused either by viral hepatitis or drug-induced liver injury or organophosphate, rat for poisoning, these are the patients who would come in for.
So yellow phosphorus poisoning, paracetamol poisoning, acute fulminant liver failure, this patient traumatic liver injury. These are the patients, carbon tetrachloride, anesthetic drug induced. So drug induced, Ayurvedic drug induced sometimes, So drug induced toxicity tablet, they require emergency transplant. Now 2 most important questions that all of us have. One is, what is the cost? Lastly, what is the cost of the transplant, liver and kidney both, and what is the success rate, isn't it? उसके सिवा क्या मतलब है? Ultimately it boils down to these 2. So what is your experience saying?
So cost of a liver transplant does not include only the cost of the procedure. The cost of the procedure is very simple. It's about 20 lakhs for a live donor liver transplant, and it's about 25 lakhs for a deceased donor liver transplant. However, there is a pre-operative evaluation which costs around 60 to 70,000, and post-transplant the patient has to go on immunosuppressive drugs, medications for the rest of their life, and they have to also periodically monitor the function of their liver.
So what would be the maintenance cost? That was a question from one of the audience.
So that process costs about 10,000 per month for the first year, and after the first year, when the patient goes on maintenance therapy and the testing becomes less frequent, then they have to keep aside 5 to 7,000 per month, and that cost will continue for the rest of their life.
What about kidney?
So kidney transplant cost goes around 8 to 10 lakhs, and the maintenance cost similar like liver. Initial year first 10,000 per month, followed by 5 to 7,000 for the immunosuppressive medicines.
So those are the numbers that mention kidney and liver transplant. Last
Sir, pardon me, we are just lagging the time.
So organ donation is so scarce, and these are the reasons why organ donation is not picking up, and it's good that the government and non-government organizations, the hospitals are taking efforts to run and propagate the program more, and in near future probably we'll have better transplants than or equal to the Western countries as well. Don't take your organs to heaven. Heaven knows we need them here, right? So please encourage organ donation and let more patients be benefited. Thank you so much.
Thank you, sir, and thank you all our esteemed panelists for sharing their valuable experience and practical insight. Now it's time for our second lucky draw, which is sponsored by Dr. Deepak Chirmade Cancer Center. Pushpak Chirmade Cancer Center. I request our panelists to do the honor. And the lucky winner is
Dr. Sangeeta Date, 2145.
Dr. Sangeeta Date.
Dr. Sangeeta Date.
Is she there? No, next.
Dr. Tushar Gawan.
Dr. Tushar Gawan.
Dr. Tushar Gawan.
459.
459, registration number 459. Is not there. Last. See, that's why it's
Ram
important.
Prasad Kandolkar. Ram Prasad Kandolkar.
Dr. Chandorkar, sir.
216.
Congratulations. That's why important to sit in the lecture conference hall.
A bag for carrying the organs once retrieved.
Thank you. Now I request our chairpersons to please felicitate our guest speakers, Dr. Aniket Hase, Dr. Anand Ramurthy sir, Dr. Lokesh Sinha sir, and Dr. Ravindra Ghawas sir, on behalf of Raicon 2026. Thank you. Now I request our panelists to please felicitate our chairpersons, Dr. Kisan Mohite, Dr. Ritesh Jain, and Dr. Rahul Patil. As we are lagging behind, we have to continue with our next session. Thank you, everyone. Thank you, sir. Thank you very much. Our next session is AI Cath Lab, What's Difference? Continue with our scientific program. Our next session is related to AI Cath Lab, which will be delivered by our guest speaker, Dr. Gautam Rege, sir. May I request our chairperson, Dr. Rajendra Chandorkar, and Dr. Ghansham Patil to please accompany our guest speaker to the dais. Now I request our chairpersons to please welcome our guest speaker, Dr. Gautam Rege, sir, by offering a bouquet on behalf of Raicon 2026. I request sir to do the honor for a lucky draw before we start. This lucky draw is sponsored by MOC Hospital. And the lucky winner is
Dr. Bhagwan Korale.
Dr. Bhagwan Karale.
Karale, sorry.
Dr. Bhagwan Karale is not there. Next.
Dr. Subhash Matre.
Dr. Subhash Matre. Congratulations, sir is here.
Congratulations, sir.
Thank you. It's my pleasure to introduce our guest speaker, Dr. Gautam Raigad, who is currently serving as consultant cardiologist at Jupiter Hospital, Thane. He is a prominent interconventional cardiologist. Sir has completed his MBBS from Pravara Medical College, Loni. He has also done DNB General Medicine, DNB Cardiology, and has over more than 10 years of experience in the field of cardiology, particularly coronary angiography and angioplasty, IVUS and OCT guided procedure. Additionally, sir has expertise in heart failure.
So that you are able to limit the entire exposure to only one level. So हे नवीन टेक्नॉलॉजीज सगळ्या लॅब्समध्ये नाही आहेत. काय अलाव करू का? ओके. So there is evidence also for this to suggest that AI is beneficial. It is not just dramatic science. आणि to summarize all of this की कार्डिओलॉजी आणि कॅथ लॅब ही टेक्नॉलॉजी वाढतच जाणार आहे. कारण the way we are going with non-invasive technology, stents, valves, devices, ki now even surgeons are migrating to this approach, where we have cardiac surgeons who are now migrating to doing TAVRs and something of that sort. So diagnosis मध्ये पण AI ला मदत होते. You may have heard की ECG मध्ये आता बघितलं असेल की ऑटोमॅटिकली रिपोर्ट येतो. What is that? That is AI. Procedural planning की देर इज अ सिम्युलेशन की असा स्टेंट आहे, असा ब्लॉक आहे, मी असं करणार तसं करणार, सगळं प्लॅन करून युअर ॲक्च्युअल प्रोसिजर टाईम इज व्हेरी शॉर्ट. इंट्रा प्रोसिजरल की वेन यू आर ॲक्च्युअली डुईंग द प्रोसिजर आपण बघितलं की ते टेक्निक्सनी आपल्याला टाईम पण वाचतो, रेडिएशन पण वाचतं आणि ओव्हरऑल आपला प्रोग्नोसिस इम्प्रूव्ह होतं. सो अल्टिमेटली वी वॉन्ट अ सिनर्जी. आपल्या सगळ्याच्या मनात एक भीती असते की AI आपल्याला रिप्लेस करणार आहे का. आता मी इथेच बसलो आहे, एआयने अँजिओप्लास्टी करून टाकली, किंवा मी इथेच बसलो आहे, एआयने ECG रीड केला. दॅट इज नॉट गोइंग टू हॅपन. कारण आत्ताही द AI मेक्स सो मेनी मिस्टेक्स की देर नीड्स टू बी अ ह्युमन आउटरीच टू चेक इट. बरोबर. सो इट ऑलवेज हॅज टू बी इन सिनर्जी. वी नीड AI टू लर्न अँड AI नीड्स अस टू चेक. अँड दॅट इज वाय AI इज द GPS. फायनली वी हॅव टू यूज अवर ओन ब्रेन. कारण पीपल गेट डंबर की सगळं AIवर आता काही लक्षात ठेवायची गरज नाही. तसं नाही आहे. यू नीड टू हॅव युअर ओन थिंग आणि यूज द AI टू ओनली काउंटर चेक. थँक्यू.
Hello. Yeah, sir, I would like to ask the question on behalf of audience. Here, sir. Here.
I'm sorry.
Here, chairperson.
Oh, sorry.
Yeah.
Yeah.
Sir,
Yes.
most of the recent stents are advanced and they are drug coated or drug impacting. But even then, we have to receive blood thinners. So why is that?
Correct.
I mean, if the stent is drug coated, then why should you require blood thinners?
Correct. So here we need to know ki why we are giving the antiplatelet and why the stent has the drug. Okay. So brief history आपण बघितली तर we used
स्टेंट्स बिकॉज वेसल यूज टू रिकॉईल. बरोबर, रिकॉईल हे एक फिजिकल फिनॉमिनन आहे. जर आर्टरी स्ट्रेच झाली इलास्टिक ह्यानी परत रिकॉईल होणार. ते रिकॉईल नको व्हायला म्हणून स्टेंट, इट होल्ड्स इट अवे लाईक दिस. बट पीपल स्टार्टेड रिअलायझिंग की त्या स्टेंटच्या आत पण द टिश्यू स्टार्ट ग्रोईंग इन स्टेंट रीस्टिनॉसिस. सो दिस ड्रग इज अ अँटी ऑर सॉर्ट ऑफ अँटी प्रॉलिफरेटिव्ह एजंट. म्हणजे काय की त्या लोकल टिश्यूवरती इट ॲक्ट्स की ते रिब्लॉक होणार नाही, बट इट हॅज नो अँटी प्लेटलेट ॲक्शन. बरोबर, सो अँटी प्लेटलेट ॲक्शनसाठी वी नीड टू टेक मेडिकेशन. सेकंडली की whenever we give antiplatelets, there are normally 2 for first 1 year and only 1 lifelong. So the dose also comes down. Current, for some reason there is a plaque rupture, so we need to have an antiplatelet.
Yes, and so when your cholesterol is under control, lipid profile is bang normal, even then you are supposed to take antiplatelet as well as anti-cholesterol medicines?
Correct. So control of lipid profile is again a very subjective thing. ह्याचं कारण असं आहे की आपण पोस्ट अँजिओप्लास्टी पेशंटचा लॅब रिपोर्ट बघतो, हां LDL बोल्डमध्ये नाही आहे अँड दॅट्स ऑल, असं नाही आहे. सो ॲट एव्हरी एज द LDL कट ऑफ इज डिफरंट. सो एस्पेशली पोस्ट अँजिओप्लास्टी नाव द LDL कट ऑफ इज 70. सो मेनी अ टाइम्स वी कंटिन्यू टू गिव्ह ॲट्रोसॅटिन हाय डोस. पीपल रिड्यूस इट की नको एवढं नको, आता नॉर्मलला आलं आहे, पण तसं नाही आहे. नॉर्मल फॉर पोस्ट अँजिओप्लास्टी LDL इज ॲटलीस्ट 70. जर सेकंड टाईम झालं आहे तर इट इज 55, इवन लोअर. सो यू नीड टू बी व्हेरी ॲग्रेसिव्ह इन कंट्रोलिंग द LDL.
Thank you, sir, for such an amazing talk. Now it's time for this lucky draw is sponsored by Pushpak Chirmade Cancer Care. I request sir to do this.
Dr.
Geetanjali Hazare. Congratulations. Now I request our chairpersons to please felicitate our guest speaker, Dr. Gautam Raigad sir, on behalf of Raicon 2026. Thank you. Now I request our guest speaker, Dr. Gautam Raigad sir, to please felicitate our chairpersons, Dr. Rajendra Chandorkar sir and Dr. Ghansham Patil sir. Thank you everyone. Thank you sir. We'll continue with our next session. I hand over the next session to my colleague Dr. Sharwani Kulkarni ma'am.
Thank you Dr. Sajid. We are running behind of schedule. Now we will time schedule. Now we will approach to our next lecture. The topic is approach to infertility. Speaker is our renowned personality, Director of Yashoda IVF Center, Dr. Balasaheb Khadbade. I am very happy to announce that Yashoda IVF has sponsored our women cricket tournament for Raigad Medical Association. So a big thank you to Yashoda IVF. I request our chairperson, Dr. Paura and Dr. Geeta Rao Hazare, to escort our guest speaker to dais. As it was a women cricket tournament, Yashoda IVF is a very big sponsor to our tournament. So a very big thank you to him. I request our chairperson to welcome our guest speaker with bouquet. Before we begin our knowledge of feast, we are going to draw a lucky draw sponsored by Mumbai Cancer Care and Research Center, Panvel Vashi. I request our speaker to choose the winner.
Dr. Rachna Mali.
Introduce our guest speaker, Dr. Balasaheb Khadbade, renowned obstetrician, gynecologist and IVF infertility specialist, medical director of Yashoda IVF Center, Infertility Center, Navi Mumbai, 15 plus year experience in fertility and maternity care, expertise in IVF, IUI, advanced reproductive technologies and endoscopic surgeries, recipient of Times Healthcare Leads Awards 2024 and Sakal 2025, Sakal Sanman 2025. So we let's our topic with approach to infertility.
Thank you, madam, for the kind introduction. Good afternoon, everyone. So it's always a pleasure to deliver talk in the Raicon. I am happy to share with you that in the last 3 years we have expanded to almost 12 branches in all over Maharashtra. But still, once the Raicon invitation comes, I always prefer to come here and share my knowledge with the colleagues. So Raicon is a great knowledge sharing platform. So coming to the topic, approach to infertility. So friends, now we will enter to the IVF lab and we will come out through the cath lab of the last lecture. So we will start from the basics. So this is the diagram we have seen in the anatomy book. Uterus, ovaries and fallopian tubes. So this is again a diagram we have seen in our embryology book, which is showing how the pregnancy occurs, ovulation and the embryo development, and finally the implantation. So these are the causes of infertility. Mostly female factors are present in 40% of cases, male factor is 40% of cases, and unknown factors are in the 20% of cases. As the rate of infertility is increasing in the modern society, it is the need of the hour to help the patients finding difficulty in conception with the ART treatment program. So what is assisted reproduction? When male and female gametes are manipulated outside the body, we call it as a assisted reproduction. So goal of the ART is to put selected spermatozoa as close as possible to the oocytes, which may help in the process of fertilization. So what are the treatments available at typical fertility center. So these are the hysteroscopy, laparoscopy, IUI, IVF, ICSI, laser, blastocyst, gamete freezing like oocyte freezing or sperm freezing, and the gamete donation program. So in the hysteroscopy we can see we are visualizing the inside of the uterine cavity. In laparoscopy, as we all know that we put the telescopes and we can visualize all the intra-abdominal organs including the pelvic organs, uterus, ovaries, and we can correct any pathologies like fibroid or cyst, or we can also do a diagnostic procedures like tubal patency test like that. Coming to the ovarian drilling. I have put this slide purposefully in the lecture slides because many times these PCOD patients are treated hurriedly with the ovarian drilling procedures, and finally sometimes these patients get a low ovarian reserve post surgery. So while treating a PCOD patient, we should try to have medical management as far as possible, and when medical management fails, then only we should go for a ovarian drilling procedure. So this is a diagram showing the IUI processing slides. So you can see this slide is a raw slide showing the so this is a raw slide, it shows debris, and this is a post-wash slide which shows clear sperms. So in the next video we will see how the semen preparation is done for the IUI. So we get active sperms at the top layer, and then these sperms are transferred inside the uterus. As we can see in this diagram, that the active sperms are taken in this test tube, and then we transfer these active sperms with the help of a catheter inside the uterus. So this is the process of the intrauterine insemination. So coming to the IVF, in IVF eggs are harvested from the woman's ovary and fertilized in the laboratory with sperms. The embryos are then transferred into the uterus. So in the next beautiful video we will understand the procedure of the IVF. So we are removing the eggs. So you can see with the help of the needle we are removing the follicular fluid from the ovaries. Then we are putting that fluid under the microscope. Then eggs are placed in the suitable culture medium. So we can see the small droplet culture here, and now we'll put sperms besides every egg, and we keep it in the incubator. So overnight this natural selection process occurs in the incubator, and one of the sperm fertilizes egg naturally. So after 17 hours later we can see the pronuclei, that is fertilization has occurred. Then the zygote is dividing in the 4-cell stage. Then we are using a ultrasound guidance to insert the embryo inside the uterine cavity. So 2 weeks later we do a beta HCG test to confirm the implantation and successful pregnancy results. So this is how the IVF is done. So coming to the ICSI. Before the ICSI came, the IVF result were maybe around 30 to 40%. But with the ICSI, the result has gone beyond 70%. So you can see in the diagram that this is the holding tool, we are holding the egg, and this is the injecting needle, we are directly injecting the sperm cell inside the egg. Again we will see one video by which we can see, and then we have retrieved the eggs. So we are injecting the sperm inside the egg. So this is the intracytoplasmic sperm injection procedure. After this, we keep these injected eggs inside the incubator, and then we keep it for the culture maybe 3 days, 5 days. Mostly we do a blastocyst culture, and after 5 days we transfer the embryos. So we do a PGT testing for the genetic diseases or the patients in whom 2, 3, 4, 5 IVF have failed, to know the aneuploid embryos, and by this way we can increase the results. So this is the trigas incubator in which we culture the embryos to a blastocyst stage so that we can increase success rate more 20%. So this is the video showing the laser hatching. So in the laser, we make a shell inside the embryo, and I think it's not playing. And we make these cells to get a way out to attach to the endometrial lining, and it increases the success rate in the failure cases or in the patients in whom the outer layer, that is the zona pellucida, is thick. So laser helps us to increase the success rate in such difficult cases. So this is the andrology lab. So these are the pictures from original pictures from our IVF, our center. So you can see in the andrology lab that there is a microscope, and this microscope has a camera, and we can see all the picture on the screen. So we have a system to record all the semen analysis reports so that these reports are reproducible, and these are the more authenticated reports. So this is again a ICSI machine. The ICSI video we saw, ICSI video. This ICSI is done under this machine. So these are the incubators. These are the cryocans. So in these cryocans there is a liquid nitrogen. Liquid nitrogen helps us to preserve the eggs and sperms and embryos for maybe 5 years, 10 years, 20 years, 30 years, like that. So the temperature inside these cans is minus 196 degrees Celsius. These cans should be refilled every 2 to 3 days so that the temperature remains constant and we can preserve these embryos, oocytes, sperms for years. So this is air purifier. This is one of the systems to make the lab with good air. The centrifuge. So I have tried small effort to help you to deal with your patients. So I have divided these patients into 2 categories. The first are the younger patients, less than 30 years of age. So take the history, confirm that the couple has regular intercourse, do the basic test, only TSH prolactin in the fasting, do an ultrasound, do a tubal patency test, semen analysis. If everything is normal, then give them the tablet of laterose, have follicular study, and plant relations. So this basic exercise you can do at your clinic level with the help of a radiologist. You can treat these patients and you can reduce the cost. So see, in the first slide we have seen that 40% cases are related to the female infertility, 40% are male infertility. In the male infertility, usually these things are neglected and male infertility evaluation is not done properly. So we'll go briefly through the male infertility evaluation. Then any surgical history of any vasectomy or testicular surgeries, inguinal surgeries, then family history, again a medical history of diabetes, hypertension, or any history of fever, any childhood history of having mumps or scrotal injury or testicular torsion, occupational history, maybe husbands are working in some heat environment and they get a low sperm count. So some factors are reversible. If we change that, then the sperm counts becomes normal. So that's why the history in the males also is very important. So again, the role of examination, scrotal examination, abdominal examination, then endocrine evaluation, genetic testing is done at the IVF center level. So again, coming to the semen analysis report. So these are the 5 abnormalities you can get in a semen analysis report. Oligospermia, the count is less than 20 million. Asthenospermia is the poor sperm motility. Azoospermia is the no sperm in the semen sample. See, before labeling a male with the azoospermia, we should take a lot of caution, because if we label azoospermia to a male, then that is a emotionally traumatic situation for that particular person. So before telling them that you are azoospermic, we should again do the semen analysis from an authentic laboratory. So in the authentic laboratory, we do centrifuge the semen sample at 3000 rpm for 15 minutes. The pellet sperm must be examined for the presence of sperms. If no sperms are found even on the centrifugation, repeat analysis should be done after 2 to 4 weeks. And if that is not found any sperm, then only you label that male azoospermic. You should not label directly from a laboratory. Usually these semen analysis are done by DMLT people and they don't have much experience. And in that case, we should avoid the trauma to the particular patient. Then again, the teratospermia is more than 70% abnormal morphology. Again, the management of male infertility is with the nutraceuticals. We can see a lot of nutraceutical products with the L-carnitine gene. Then these are the hot couples which should be referred to a fertility. Then these are the hot couples which should be referred to a fertility specialist as early as possible. So which patient to be immediately referred? Immediately. Patient आला आणि त्याला लगेच पाठवायचे. अजूस्पर्मियाचं पेशंट आहे. AMH लेस देन 2 आहे. पेल्विक पॅथॉलॉजी आहे पेशंटला. ओव्हरियन ॲडनेक्झल मास आहे. फायब्रॉइड आहे. किंवा सस्पेक्टेड टर्नर सिंड्रोम किंवा काही जेनेटिक abnormality वाटते. Then these patients should be immediately referred so that the patients get proper treatment and the patient and the treating doctor gets rewarded like that. Thank you very much for the patience.
Thank you so much, sir, for this lecture in very simple words and effective visuals. Now I request our chairperson, Dr. Paura, and Dr. Geeta Rao Hazare to felicitate our guest speaker with the memento.
I am very happy to share the dais with Dr. Shyam Singh Paura because we are the products of Shaskri Vidyaniketan Aurangabad. We are the alumni and we stayed there for 6 years together in the boarding school. So I am very happy, Doctor, today.
Now I request a guest speaker to felicitate our both chairpersons. Sir. Now it's time to choose our next lucky draw given by Dr. Pushpak Chirmade, Cancer Care, Vashi, Thane and Panvel. I request Dr. Satya Thakre. Thank you. Now we'll proceed to our next lecture. It's very true. While researching a disease, we learn new things, and that makes the treatment more effective. It is a continuous process of learning and understanding. It is important that diagnosis and treatment keep improving continuously. And with the same, our next lecture is Cancer and Recent Advances, Precision Oncology and Beyond by Dr. Pushpak Chirmade. I request Chairperson, Senior Practitioner and Past President of RMA, Dr. Ramesh Patel, and Senior KMA Member, Dr. B.G. Lad, to escort our guest speaker. I request a chairperson to welcome our speaker with bouquet. Thank you, sir. आणि येस, आतापर्यंत तुम्हाला सगळा क्रम पाठ झालेला असेल. आपण लकी ड्रॉ काढणार आहोत. मुंबई कॅन्सर केअर सेंटर पनवेल वाशी यांच्याकडून हा लकी ड्रॉ आहे.
डॉक्टर अनिल यादव. डॉक्टर अनिल यादव.
डॉक्टर अनिल यादव. नेक्स्ट सर.
डॉक्टर राहुल पाटिल.
डॉक्टर राहुल पाटिल. दिस इज द लास्ट.
डॉक्टर सिद्धार्थ, रजिस्ट्रेशन नंबर 285.
आहे.
कॉंग्रॅच्युलेशन्स.
Thank you, sir. Now I introduce our guest speaker, Dr. Pushpak Chirmade, MBBS, MD Medicine, DM Medical and Oncology and Hemato-Oncology, ECMO, Consultant Adult and Pediatric Oncology in Molecular Oncology, Sydney Canal Cancer Institute, USA, ISMO Certified Medical Oncologist, Certified in Immuno-Oncology and Precision Oncology, Harvard Medical School, Gold Medalist in MD Internal Medicine, Expert in Chemotherapy, Targeted Therapy, Hormonal Therapy and Immunotherapy. And now we go through our topic, Cancer and Recent Advances, Precision Oncology and Beyond.
Thank you so much. Thank you. Can you load my slide presentation please? Yeah. नमस्कार Raicon. 2026
सगळे जागे आहेत का? लेट्स हॅव अ रेज ऑफ हँड्स. सगळ्यांना जागा करूया. हाय, हाऊ इज द जोश? नक्की का? ऐकू नाही येते मला. हाय, ओके, चालेल. सो लेट स्टार्ट विथ अ लेक्चर. रमेश सरांनी मला सांगितलं की पटकन आपण करूया. सो व्हॉट आय एम डिस्कसिंग टुडे इज ॲडव्हान्सेस इन कॅन्सर ट्रीटमेंट, द एरा ऑफ प्रिसिजन ऑन्कॉलॉजी, इम्युनो ऑन्कॉलॉजी अँड बियॉन्ड, म्हणजे एरा ऑफ AI, पण मी ते ब्रीफमध्ये घेईन. सो दिस इज मी, दिस इज PCC कॅन्सर सेंटर. आय विल स्किप द व्हिडिओ, लेट्स मूव्ह अहेड. ओके, सो 10 वर्षा अगोदर एक न्यूज वीक म्हणून मॅगझिन आहे, ठीक आहे. त्याच्यामध्ये एक लेख पब्लिश झालेला. इट्स अन एडिटोरियल अँड दॅट एडिटोरियल वॉज की कॅन्सरला आपण डिफीट का करू शकत नाही आहे. द क्वेश्चन दे सेड इज दॅट कॅन्सर आपण सर्जरी करतो, किमो देतो, रेडिएशन करतो, पण तरी वारंवार परत येतो, राईट. सो व्हॉट आर वी मिसिंग? So are we missing something? Are we not understanding the problem so that we cannot solve it? So their focus was, let's understand the problem so that we can get to the root cause and defeat cancer. So depending upon this, the next 10 decades or 10 years, that is 1 decade, was dedicated towards researching why we are having cancer. So तुमच्या डेली प्रॅक्टिसमध्ये तुम्ही अनुभवलं असेल की कॅन्सरचं प्रमाण वाढत चाललंय. Am I right or wrong? Does everybody agree with me? Right. So आतापर्यंत आपल्याला माहीत होतं की डायबिटीज, BP, हार्ट डिसीज हे सर्वात मेन विलन्स आहेत जे इंडियन पॉप्युलेशनला प्लेग करतात. बट कॅन्सर इज नाव फार आउटपेसिंग ऑल दीज कॉमन कंप्लेंट्स. Probably by the next decade, cancer would be the number 1 cause of morbidity and mortality in India. And we are seeing those effects even now. The air is polluted, the food that we eat is contaminated, there is an epidemic of obesity, and this is all that is leading to cancer. So, as primary care physicians, as the first line of defense for our patients, we should be aware about cancer, early detection, and what are the recent advances so that we can guide our patients better and they can be given the proper treatment at the right time. इंडियामध्ये का प्रॉब्लेम आहे? इंडियामध्ये प्रॉब्लेम आहे कारण इंडियामध्ये तब्बल 13 लाख ते 15 लाख नवीन केसेस ऑफ कॅन्सर आर डिटेक्टेड एव्हरी इयर. And out of this, almost 50%, that is 8 lakh patients, die because of cancer. At any given point of time, almost 30 lakh patients are suffering from cancer. So cancer is going to be the new frontier for healthcare to win or battle at. So कॅन्सरला आपल्याला लाईटली घ्यायचं नाही आहे. आपण समजा इंडियात बघितलं तर कोणते कॉमन कॅन्सर्स आहेत. सो ओव्हरऑल आपण समजा दोन्ही जेंडर्स कन्सिडर केले तर ब्रेस्ट कॅन्सर इज द नंबर 1 कॅन्सर दॅट plagues our Indian population, followed by oral cavity cancer and lung cancer. आत्तापर्यंत आपण जी ट्रीटमेंट वापरत होतो तेव्हा नेहमी आपण कॅन्सरला ऑर्गन स्पेसिफिक असं आयडेंटिफाय करतो. एखाद्याला ब्रेस्ट कॅन्सर झाला आहे, एखाद्याला लंग कॅन्सर झालेला आहे, एखाद्याला कोलॉन किंवा आतड्यांचा कॅन्सर झालेला आहे. बट नाव वी आर मुव्हिंग इन टू द एरा ऑफ प्रिसिजन ऑन्कॉलॉजी. याचा अर्थ काय की जरी ऑर्गन कोणताही असू दे, पण समजा जेनेटिक बदल असतील, काही म्युटेशन झालेले असतील ज्याच्यामुळे कॅन्सर डेव्हलप होतोय, तर ह्या पेशंट्सला आपण पर्टिक्युलर ट्रीटमेंट जेणेकरून टार्गेट थेरपी किंवा देऊ शकतो सो दॅट वी कॅन इम्प्रूव्ह द आउटकम्स ऑफ दीज पेशंट्स. सो आता समजा आपण एक एक्झाम्पल घेऊया. एखादा व्यक्ती आहे ज्याला स्टेज 3 कोलॉन कॅन्सर आहे. तर अशा व्यक्तीला आपल्याला सेम ट्रीटमेंट द्यायची असते आणि त्यानंतर आपण काय बघतो की काही पेशंट्समध्ये खूप छान रिस्पॉन्स आला आहे, काहींमध्ये तेवढा फायदा झाला नाही आणि काहींना ॲक्च्युली ट्रीटमेंटचा आला आहे, काहींमध्ये तेवढा फायदा झाला नाही आणि काहींना ॲक्च्युली ट्रीटमेंटचा दुष्परिणाम झालेला आहे की साईड इफेक्ट झालेला आहे. सो वी हॅव अ हेट्रोजिनस आउटकम्स दॅट वी आर हॅव्हिंग ॲट द करंट ट्रीटमेंट दॅट वी यूज. पण आता आपण काय करतो, द एरा ऑफ करंट पर्सनलाइज्ड डायग्नोस्टिक्स और प्रिसिजन ऑन्कॉलॉजी, दिस सेम ग्रुप इज better classified by certain genetic tests known as next generation sequencing into subgroups. आणि मग ह्या ग्रुप वाईज त्यांना ट्रीटमेंट दिली जाते. ह्याला म्हणतात प्रिसिजन और पर्सनलाइज्ड ऑन्कॉलॉजी. एक उदाहरणार्थ आपल्या रुटीन प्रॅक्टिसचं आपण घेऊया. आपल्याला एखाद्या पेशंटला युरिन इन्फेक्शन आहे हे समजा आपल्याला सस्पेक्टेड असेल तर आपण कोणत्या 2 टेस्ट त्या पेशंटला रेकमेंड करतो? एनीबडी? विच 2 टेस्ट आर रेकमेंडेड टू दिस पेशंट इफ यू आर सस्पेक्टिंग अ युरिन इन्फेक्शन? Urine microscopy and culture sensitivity, right? So we tell urine microscopy or routine because we want to confirm our suspicion that the patient is suffering from urine infection. And why do we tell the culture to be done? We tell it because we want to identify the organism and which best medicine will suit to cure this UTI. Now, if we apply the similar principles to cancer also, okay, so if I have a suspicion of cancer in a patient and this patient, I have to confirm whether he has the cancer, I do a biopsy. But can I do something like a culture sensitivity in these patients? So that exactly is where the molecular oncology fits in. So I am trying to identify the core basic principles by which I can treat the disease better so as to optimize my outcome and reduce side effects for this patient. So this is what we call as precision oncology. So आपल्याला ही महाभारतातली गोष्ट माहिती आहे. द्रोणाचार्य पांडवांना शिकवत होते. तेव्हा द्रोणाचार्यांनी अर्जुनाला विचारलं की तुला बेटा काय दिसतंय? तर तो म्हणतो मला फक्त पक्षाचा डोळा दिसतोय. राईट? ओनली द टार्गेट. So I will call us oncologists as the modern day Arjuns. We look only at the targets that can be targeted in a tumor, the mutations that can give us benefit. And this is known as the agnostic indications for many medicines that we use nowadays in oncology, where instead of focusing on the organ, we focus on the mutations that are present in the organ so that we can optimize our treatments. These include medicines from immunotherapy to something known as the latest antibody drug conjugates, which we use depending upon the receptor status. So, as doctors, we are always intrigued by our patients. आताही मी बघतो बरेच जण मोबाईलवर असतात. मोस्टली पेशंटबद्दल त्यांची डिस्कशन चालू असतात, क्लिनिकमध्ये काही इन्स्ट्रक्शन्स देत असतात. सो लेट्स गो टू फ्यू केसेस टू अंडरस्टँड दिस कन्सेप्ट्स अ लिटिल बेटर. ओके, so this is a first case. This is a CA lung case. This is an actual case of mine. We had treated this patient, or she is under treatment since last few years, about 5 to 6 years. So this is a lady. She was comfortable at rest. She was hailing from Alibag. तिकडे लोकली त्यांनी आधी ट्रीटमेंट सुरू केलेली आणि नंतर आमच्याकडे ते रेफर झालेले. This patient presented with air entry which was absent on the right side. There was no pallor, no palpable nodes, and the X-ray on outside showed a large pleural effusion. So this was the patient's X-ray. So any differential diagnosis for the current X-ray? Any guy? Any of the doctors here? समजा असा X-ray तुमच्या क्लिनिकला आला तर काय वाटेल, काय असू शकतं पेशंटला? Anybody? पेशंटचे कंप्लेंट सांगतो परत. वेट लॉस, चेस्ट पेन, कफ since few months, and this is the X-ray that presents to you. Cox, okay, Cox. और एक CA lung, okay. Anything other than that? Pneumonia, maybe pneumonic effusion, right? So basically our thought process goes always directly to Cox because we have been trained that way, right? But probably in the next 10 years this is going to change. आता काय होतंय, कॉक्सचं प्रमाण कमी होतंय आणि कॅन्सरचं प्रमाण वाढतंय. तर जेव्हा पण तुमच्याकडे असा एक्सरे आला तर डेफिनेटली डोंट नेग्लेक्ट टू हॅव अ डिफरन्शियल डायग्नोसिस ऑफ कॅन्सर ॲट द बॅक ऑफ युअर माइंड अँड इव्हॅल्युएट द पेशंट इन दॅट वे. सो वी डीड अ प्लुरल, सो शी अंडरवेंट अ प्लुरल फ्लुइड अनालिसिस ऑर अ लोकल प्लेस, अँड त्याच्यामध्ये आपल्याला काय दिसलं की इट वॉज अन एक्झुडेटिव्ह टाईप ऑफ इफ्युजन. So this effusion had almost 4.3 gram per deciliter of proteins, but the ADA was equivocal, AFB were not seen, and the pleural fluid cytology was also negative. आता ह्याच्यामध्ये काय करावं? सो पेशंटचं आपण प्लुरल फ्लुइड टॅपिंग केली, पेशंटला बरंही वाटलं आणि डायग्नोसिसमध्ये आपल्याला एवढं काही कन्क्लुसिव्हली कळलं नाही कारण TBच्या टेस्टही निगेटिव्ह होत्या आणि मॅलिग्नन्सीच्याही निगेटिव्ह होत्या. सो अ टेक होम पॉईंट ॲट दिस जंक्चर, that pleural fluid analysis for a malignancy, one sample has a sensitivity of only 60%. So you may miss out 40% of the samples or the positive cases. So in such a situation, always a second tapping, if the patient becomes symptomatic in future, is always warranted, which increases the sensitivity of pleural fluid analysis for cancer to about 75 to 80%. Considered as that it is not cancer. Okay, you have not picked it up. It still can be cancer. The predictive value of this report is very less. So moving ahead, this lady, as we thought, was started on something for Cox because these symptoms and the constellation perfectly fit the mold of tuberculosis. So the patient received a 4-drug AKT with oral prednisolone. आधी आजींना prednisolone खाऊन खूप छान वाटलं, बरं वाटलं. स्टिरॉइडमुळे आल्हाद आला पेशंटला. ठीक आहे. She received 3 months of Cox treatment, and then this is her X-ray. Okay, this was her initial X-ray and this is her new X-ray. So what has happened? वाढलेला आहे. So pleural fluid has increased. The pleural fluid has almost right side ची आता white out झालेली आहे, and in this juncture the patient came to us at our Vashi center. This patient was literally wheelchair bound. She could not complete a single sentence and she was breathless as she spoke. माझं नाव. So that was how breathless she was, NYHA class 4 type of breathlessness. We did a CT scan, we found there was a hilar mass. The hilar mass also had a bronchus cutoff sign, which is a telltale indicator that we should do a bronchoscopic biopsy in this patient, which we underwent, and the patient underwent a bronchoscopic biopsy. You can see the mass here. A biopsy was taken, and later a diagnosis was made that it is an adenocarcinoma of the lung with malignant pleural effusion. The second pleural tapping of this patient was positive for malignant cells, and it was a stage 4 disease. So at this moment, there are two tests that are always important in patients where you are suspecting cancer. One is the type of cancer, that is the biopsy, and second is the extent of tumor, and that's why you require a PET scan. So we completed the staging workup of the patient, and at this juncture, the patient was classified as a stage 4 disease with pleural fluid, with pleural plaques, with a lung mass, but no distant mets, thoracic only disease. Now, any additional investigations at this moment? Yes. So here we go for the molecular analysis, and we did something known as a molecular panel, a limited molecular panel of EGFR, AL cross and PDL1. Nowadays we go for broad testing, and these panels are known as NGS panels. Normally they cost in the range of about 40 to 50 lakhs. I will be very glad to tell you that at PCC Center we have a subsidized opportunity of the patients to undergo these NGS panels at a meager cost of 10,000 rupees, where almost 15 genes along with immunotherapy markers are done through our trust support. So this was the report of this patient, and luckily for this Ajji, she was positive for something known as a EGFR exon 19 mutation. Now what is this mutation? So in targeted therapy or cancer mutations, there is a concept known as driver mutation. So imagine we all are sitting in a bus. ओके, आपण कुठेतरी फिरायला जात आहोत आणि ही बस कुठे जाणार आहे ह्याचा कंट्रोल कोणाच्या हातात आहे? ड्रायव्हरच्या हातात आहे, राईट? सो इन कॅन्सर देर आर सर्टन सच म्युटेशन्स विच कॅन टेल हाऊ फास्ट द ट्यूमर शुड ग्रो, वेअर द ट्यूमर शुड स्प्रेड, अँड हाऊ अग्रेसिव्ह द ट्यूमर इट इज, अँड दीज आर नोन ॲज द ड्रायव्हर म्युटेशन्स. And by this molecular test, we identified a driver mutation in this lady, and this was known as EGFR. आता ह्याचं महत्त्व काय? बिकॉज वी हॅव सर्टन मेडिसिन्स विच कॅन टार्गेट दिस EGFR म्युटेशन. नाव दिस EGFR म्युटेशन वॉज टार्गेटेड बाय अ टॅबलेट नोन ॲज अर्लोटिनिब. सो बऱ्याच वेळेस स्टेज 4चा आजार म्हणजे आपल्याला काय वाटतं की आता पेशंट लास्ट स्टेजला आलेला आहे, आता आजार पसरलेला आहे, आता हा काही क्षणांचा किंवा काही दिवसांचाच आपल्यासोबत असणार आहे पेशंट, पण हे आता बदललेलं आहे, राईट? सो माय प्रोफेसर्स ऑल्सो यूज टू टेल मी कि बेटा स्टेज 4 CA लंग में दो ही ऑप्शन है, एक तो घर पे जाके सेवा करो पेशेंट का, या फिर कीमोथेरेपी दो. इफ यू डू बेस्ट सपोर्टिव केयर, रफली 6 to 8 months इज द लाइफ स्पैन. इफ यू डू कीमोथेरेपी, मैक्सिमम 1 year. But now I will be very glad to tell you that this lady was started on this tablet, one single tablet per day in her stage 4 lung cancer. In 2018, this patient within 1 month had relief from her pleural effusion. She who was wheelchair bound, unable to talk, was now walking, right? So this is the beauty of targeted therapy. When you have driver mutations, you can identify them and target them. There is a concept known as oncogene addiction. म्हणजे काय की एखादं ड्रायव्हर म्युटेशन समजा कॅन्सरला वाढायला मदत करते आणि सडनली तुम्ही त्याचा इन्फ्लुएन्स बंद केला तर तो कॅन्सर एकदम कमी होऊन जातो. And this is what we see with most of the targeted therapies. So 1 month of erlotinib, you can see that the pleural effusion has reduced by almost 70%. You will be glad to hear that this lady is still with us. She is taking treatment. She is on 3rd generation TKI known as osimertinib. Later on, after erlotinib, she had brain metastasis. She received radiation for same. And after that, we started osimertinib, that is a 3rd generation tyrosine kinase inhibitor for this lady. And she is doing very well on that. Luckily, she was also enrolled in something known as a patient assistance program for osimertinib that was provided by our center, where after few purchases, she can get the medicine lifelong free. And she is currently on free supply of osimertinib by AstraZeneca, which is a 3rd generation tyrosine kinase inhibitor. So this is how their oncology is changing. Now, 3rd or 4th stage of cancer does not mean a death sentence. So there are always options, and I would like all of you, being the primary physicians being the first line of defense for our patients, that if you have a patient with stage 4 or advanced cancers, never discount them that this is now the end period. Always tell them that there might be a hope, there might be a new treatment over the horizon which they can take advantage of. So these are few of my other cases where we have large masses shrinking down by the use of targeted therapy. These are all molecular targeted therapies. The first case is an ALK positive tumor, then is a ROS positive tumor, and then it was a MET amplification tumor. So with proper sequencing of medicines, with proper utilization of all the resources that we have, where the options for patients gave a median survival of only 1 year to 1.5 years, we have exactly in these also is the most or the first. Now moving ahead to something known as immunotherapy. So I will first go to the concept of immunotherapy. So till now we always had the 3 pillars of cancer treatment. One was cancer surgery, chemotherapy, radiation, and now you have the 4th pillar, that is precision oncology. Now in precision oncology, one is the precision oncology. Now in precision oncology, one is the targeted therapy, that is identifying driver mutations and tackling them, and the other aspect of it is immunotherapy. Now what exactly is immunotherapy? आतापर्यंत आपण सर्व कॅर्सिनोजन्सला एक्सपोज होत असतो. आपण जी हवा ब्रीथ करतो त्याच्यामध्ये एवढं पोल्युशन असतं. आपल्याला आतापर्यंत कॅन्सर का झालेला नाही? आपल्याला कॅन्सर झालेला नाही कारण आपल्या बॉडीमध्ये इम्यून सर्वेलन्स नावाची एक प्रक्रिया असते. त्याच्यामध्ये समजा सेल्स खराब झाले, म्युटेट झाले, तर बॉडी विल ट्राय टू करेक्ट दिस सेल्स. त्याला म्हणतात DNA रिपेअर मेकॅनिझम्स, or there would be certain mechanisms to kill the defective cells, and this is known as the apoptosis, जे आपण pathology cells, and this is known as the apoptosis, जे आपण pathology मध्ये वाचलेलं असेल, right? So either you have DNA repair or apoptosis. Now पण हे कळायला की हा सेल खराब झालेला आहे, की हा सेल म्युटेट झालेला आहे, हे काम कोण करणार? हे काम आपले इम्यून सेल्स करतात, ज्याला आपण टी सेल्स म्हणतो. ओके, सो आपल्या शरीरामध्ये काही असे सेल्स फिरत असतात ज्याला आम्ही डेंड्रायटिक सेल्स म्हणतो, जे सेल्स असतात जे बॉडीमधनं ब्लडमध्ये इकडे तिकडे जात असतात आणि आयडेंटिफाय करायचा प्रयत्न करतात की काही नवीन अँटीजन, न्यू अँटीजन त्यांना मिळतंय का. नाउ न्यू अँटीजन कॅन बी बॅक्टेरिया, कॅन बी अ व्हायरस और कॅन बी अ पॅरासाइट, so that after identification they can trigger an immune response against this antigen. Okay, so let's go to this cartoon. You have a dendritic cell, antigen presenting cell. What is it telling to the T cell? T cell is your soldier cell. He is saying that hey, wake up, I found something suspicious, go check it out. The T cell बिचारा म्हणतो okay, I will go check it out. मग T cell त्याची इमॅजिन अ सोल्जर, तो गस्त मारायला जातोय आता, राईट. पूर्ण बॉडीमध्ये फिरणार शोधत की हा सिग्नल जो मला डेंड्रायटिक सेलनी दिलेला आहे हा अजून कुठे सापडतोय का, राईट. अँड वन्स ही फाइंड्स दिस सेल, व्हॉट इट विल डू? इट विल ट्राय टू किल इट. सो नाउ कॅन्सर सेल्स आर व्हेरी क्लेवर. व्हॉट डू द कॅन्सर सेल्स डू? कॅन्सर सेल्स फाइंड मेकॅनिझम्स टू स्टे अवे और स्टे हिडन फ्रॉम दिस टी सेल्स. येतंय लक्षात? म्हणजे टी सेल आपल्याला अटॅक करायला येणार, आयडेंटिफाय करणार, तर कॅन्सर सेल काय करतात? ते खूप हुशार असतात. ते आपल्या स्वतःला टी सेलपासून लपवण्याचे मेकॅनिझम शोधत असतात, किंवा जरी टी सेलने आयडेंटिफाय केलं तर त्याला कन्फ्यूज करण्याचे मेकॅनिझम शोधत असतात, जेणेकरून ते सर्वाईव्ह होतील. तर असंच एक मेकॅनिझम आहे PD1 PDL1 इंटरॅक्शन. सो दिस इज द बेसिस ऑफ इम्युनोथेरपी इन कॅन्सर. सो टी सेलवरती PD1 नावाचं एक बटन इमॅजिन करा, स्विच आहे. समजा टी सेलवरती तो स्विच ऑन आहे तर टी सेल ॲक्टिव्ह आहे, आणि समजा टी सेलचा हा स्विच ऑफ झाला तर द टी सेल इज इनॲक्टिवेटेड. ओके, कळतंय? सो टी सेलवरती एक बटन आहे ऑन ऑफ सारखं. समजा तो ऑन असेल तर टी सेल काम करेल, ऑफ असेल तर टी सेल काम करणार नाही, राईट. समजा आता ह्या कॅन्सर सेलने हे शोधलं की कशाने मी त्या टी सेलचं बटन ऑफ करू शकतो, राईट. सो द टी सेल विल गेट इनॲक्टिवेटेड अँड इट विल नॉट अटॅक द कॅन्सर. And in turn what will happen? The cancer will survive, it will grow, it will spread. Correct? So this is known as immune evasion. This is known as immune evasion. आता हे जे कॅन्सर सेल वापरतात त्याला म्हणतात PDL1. PDL1 एक्सप्रेशन ऑन द कॅन्सर सेल जितकं जास्त तितकं आम्हाला कळतं की द कॅन्सर सेल इज युझिंग धिस मेकॅनिझम टू अवॉइड इट सेल्फ फ्रॉम द इम्युन सिस्टम. ठीक आहे, हे आपण बायोप्सीच्या सॅम्पल्सवर चेक करू शकतो. The biggest part of this is that we can check the PDL1 expression on the biopsy samples that we take from the tumor. If the expression is high, we are very sure that the cancer is using this mechanism to evade the immune system. So what can we do? So what we do is either we protect the T cell. So जे T cellचं जे बटन आहे त्याला आपण प्रोटेक्ट करतोय by giving an external covering like an helmet, so that even if the cancer cell acts on the T cell is not inactivated and it is able to kill the cancer cell, right? Or we do something known as a PD-L1 checkpoint blockade, where जे कॅन्सरचं जे वेपन आहे त्याला आपण इनएफेक्टिव्ह करतो आहोत. सो इनव्हेरिएबली एंड रिझल्ट काय आहे? द टी सेल इज प्रिझर्व्ड अँड इट इज एबल टू अटॅक द कॅन्सर सेल्स. सो हे सोप्या भाषेमध्ये आपण बघितलं की इम्युनोथेरपी कॅन्सरमध्ये कशी काम करते, राईट? ह्याचा अर्थच काय की बऱ्याच वेळेस इम्युनोथेरपीमध्ये इम्युनिटी वाढते, इम्युनवर्धक औषधी असतात असं बिलकुल नाही आहे. इम्यून सिस्टम आपली जितकी इफेक्टिव्ह आहे तितकीच इफेक्टिव्ह असते. कॅन्सर सेल्स ज्या लपलेल्या आहेत त्यांना आपण अनहाईड करतोय किंवा इम्यून सिस्टमला दाखवून देतोय. मिस्टर इंडिया पिक्चर बघितलाय का सगळ्यांनी? लाल रंगाच्या चष्म्यामध्ये कोण दिसतं, राईट? तर आपण टी सेल्सला हा असा लाल रंगाचा चष्मा दिलेला आहे की लपलेले म्हणजे हिडन मिस्टर इंडियाज आपल्याला दिसतील, राईट? सो युअर इम्यून सिस्टम इज द सेम. नो इम्यून. का मी हे सांगतोय? कारण बऱ्याच वेळेस डॉक्टरांमध्येही कन्फ्युजन आहे आणि पेशंटमध्ये तर खूपच कन्फ्युजन आहे. 2-3 महिने अगोदरची गोष्ट आहे. एक पेशंट आलेले UP-मधनं ब्लॅडर कॅन्सरचे. ते म्हणाले आम्ही इम्युनोथेरपी घेतोय. डिटेलमध्ये खोलात जेव्हा विचारलं पेशंटला तर बॅगमधनं त्याने च्यवनप्राशची बॉटली काढली आणि म्हणे हे इम्युनोथेरपी चाललेली आहे. सो दिस इज हाऊ कन्फ्युजन इन्क्रीजेस अँड पीपल मे गेट मिसगाइडेड, राईट? सो इन सिम्पल वर्ड्स दिस इज हाऊ इम्युनोथेरपी वर्क्स. So these are few of our cases that we have done in the last few years. I will just quickly go through them. So this is a patient, male patient with GE junction tumor, liver metastasis, adenocarcinoma. There was a driver mutation that is HER2 positive as well as immunotherapy marker which was on a higher side. So ह्या पेशंटला काय दिलं? किमो, टार्गेटेड आणि इम्युनो ट्रिपल कॉम्बिनेशन दिलं. पेशंट वॉज अ व्हेरी फिट पेशंट and you can see that these are the previous scans of the patient. Liver mets, there is a large GE junction stomach mass. After 6 cycles, you can see that the patient is a complete metabolic CR. The PET scan is completely clear. हे जे ब्लॅक आणि येलो डॉट्स दिसत आहेत हे ॲक्च्युली आजार आहे. हा पूर्ण ऑलमोस्ट स्कॅनमध्ये अनडिटेक्टेबल झालेला आहे. सो दिस इज द ब्युटी ऑफ इम्युनोथेरपी. नाउ अगेन दिस वॉज अ लंग कॅन्सर पेशंट, एक्सटेन्सिव्ह बोन मेट्स. एकही हाड असं नव्हतं बॉडीमध्ये ज्याच्यात आजार पसरलेला नव्हता. अगेन वी इव्हॅल्युएटेड TPS स्कोर वॉज 88%. 2 minutes. TPS score was 88%. Patient was treated with chemo with immunotherapy. After 4 cycles of 3 months, you can see this is the initial scan of the patient. All the bones are literally studded with mets. And after that, after pembrolizumab 6 cycles, the patient is almost in complete metabolic remission. And there are many such cases that we have done over the period of time. Head neck cancer, you can see beautiful results. Very early responders. Within a month's time, the disease reduces by almost 70 to 80%, only 20-30% disease. And the beauty of immunotherapy is that it is like a training ground for your body's immune cells. एकदा बॉडीच्या इम्युन सेल्सला हे कळलं की आपण कॅन्सरला कसं अटॅक करायचं आहे, कसं आयडेंटिफाय करायचं आहे, तर लॉंग ड्युरेशन ऑफ रिस्पॉन्सेस आर अटेंड बाय गिविंग इम्युनोथेरपी. So this is a liver cancer case. What is the future? So there are a number of immune methods which are now being identified. 2-3 इम्युनोथेरपीजला कंबाईन करून देणे किंवा इम्युनोथेरपी विथ किमोथेरपी देणे किंवा इम्युनोथेरपी टार्गेट थेरपी देणे, ह्याने काय होतं आहे की किमोथेरपीचा डोस आम्ही लिमिटेड ठेवू शकतो आहे आणि तरी जे रेजिमेन आम्ही देतो आहे ते इफेक्टिवली पेशंटला टॉलरेट होतं अँड इट गिव्स बेस्ट रिझल्ट्स. दिस इज अगेन अ केस ऑफ अ पर्सन. What we discussed in the cartoon is actually such a detailed and an intricate play of events that happens in the body. There is something known as CAR T cell therapy that is upcoming, where you genetically engineer T cells so that they can attack the cancer cells. लॅबमध्ये त्यांना असं इंजिनियर करतो आपण की ते जेनेटिकली आपल्या कॅन्सर सेल्सला अटॅक करतील. So till now we only had 3 pillars of cancer treatment which directly attack the cancer cells. Now you have immuno-oncology which indirectly through your immune system attacks the cancer cells. All sides have 2 coins, okay? So side effects, early detection is very key in these targeted therapies and immunotherapy. So a well-trained person is very important to administer these therapies because these can be deadly. Patients can have hepatitis, colonitis, but early identification and timely treatment prevents most of them. Age is not a barrier for these therapies. I have treated a 90-year-old gentleman with this slide. Taking this small opportunity and a big thank you to the Raicon 2026 team. Introducing you to PCC Cancer Care Clinics and Daycare Centers. We are placed at Vashi, Thane and Panvel. A state-of-the-art infrastructure. Can you just load the presentation again? A state-of-the-art infrastructure where we have beautiful non-hospital-like environment-like setting so that the patient is not bogged down by coming repeatedly to the hospital. We have the state-of-the-art scalp cooling technology where the patients can take that advantage of no hair fall during chemotherapy. केस गळण्यापासून जी भीती असते ती थांबवू शकतो आपण स्कॅल्प कुलिंगद्वारे. आपल्या इथे अफोर्डेबल आणि ॲक्सेसिबल कॅन्सर ट्रीटमेंट आपण प्रोव्हाइड करतो विच इज ऑलमोस्ट 30% ऑफ द कॉस्ट ऑफ द बिग कॉर्पोरेट हॉस्पिटल्स अँड द मोस्ट अप टू द मार्क ॲज कम्पेअर्ड टू द इंटरनॅशनल गाईडलाईन्स. वी डू हिमॅटॉन्कॉलॉजी, रेडिएशन, सर्जरी, बोन मॅरो ट्रान्सप्लांट्स, chemotherapy, targeted therapy, immunotherapy, and now we are also ventured into CAR T-cell therapy. Scalp cooling, first time in Navi Mumbai we introduced. We are growing over the years, and this is the last slide. You can take the photo of this. It's the most important slide for me. Thank you all of you. Thank you for the patient listening, and thank you Raicon, and a wonderful effort here for this conference. Thank you.
Thank you, sir. थँक्यू सर. कॅन्सर झालाच तर आताचे सगळे बियॉन्ड ॲडव्हान्स सगळे मेडिसिन आणि सगळं ऐकल्यानंतर असं वाटलं की निश्चित त्याच्यासाठी उपाय आहेत. यानंतर मी आपले चेअरपर्सन यांना विनंती करते की त्यांनी डॉक्टर पुष्पक चिरमाडे यांना फेलिसिटेट करावं मोमेंटो देऊन. पुष्पक चिरमाडे कॅन्सर केअर पनवेल, वाशी, ठाणे यांनी आपले मेन्स क्रिकेट स्पॉन्सर केले होते तर त्यांच्यासाठी एकदा जोरदार टाळ्या होऊन जाऊन देत. त्यानंतर मी गेस्ट स्पीकरना विनंती करते की आपले आजचे चेअरपर्सन यांचा त्यांनी सन्मान करावा.
एक महत्त्वाचा क्वेश्चन त्यांना विचारतो. फॉर पॉसिटी ऑफ टाईम आय विल आन्सर इन शॉर्ट. विच आर द कॅन्सर विथ द बेस्ट रिझल्ट्स अँड वर्स्ट रिझल्ट्स इन 3 group of patients: pediatric, adult male, adult female.
Okay. So, adult male I'll start with. The best cancers probably are the prostate cancers. They are very common and they are hormone dependent. Sir एकदम अटेंटिव्हली लेक्चर ऐकत होते, त्याचं फळ मिळालं.
यापुढची सूत्र मी डॉक्टर कुणाल राठोड यांच्याकडे सुपूर्द करते.
नमस्कार. आपलं पुढचं लेक्चर खूप इंटरेस्टिंग आहे. टॉपिक आहे हाऊ टू मेक हॉस्पिटल प्रॉफिटेबल. सगळ्यांचा जिव्हाळ्याचा प्रश्न आहे हा. आपले स्पीकर आहेत राज भट्टाचार्य. मी चेअरपर्सन डॉक्टर गिरीश गायकवाड आणि डॉक्टर कुमार ओसवाल यांना विनंती करतो, प्लीज एस्कॉर्ट आवर गेस्ट स्पीकर. मी चेअरपर्सन यांना विनंती करतो की त्यांनी गेस्ट स्पीकरचं स्वागत करायचं आहे. राज भट्टाचार्य, CEO हॉस्पिटल बिझनेस लाईफनिटी हेल्थ लिमिटेड, 27+ years of experience in hospital expansion, operation and healthcare growth. He is healthcare postgraduate from the prestigious Indian Institute of Social Welfare in Business Management and also research fellow healthcare delivery from Milliman University, Chicago, USA. founding team member and former COO of Vasan Eye Care, first CEO of Dr. Agrawal's Eye Hospital, led rupees 100 processes at large non-metro corporate hospital, manage healthcare PE investment with ICICI Venture. या लेक्चरचा फर्स्ट लकी ड्रॉ आहे MOC मुंबई ऑन्को केअर सेंटर.
Dr. Ganesh Salunke, organizing chairman.
Dr. Ganesh Salunke.
Dr. Manyal Didi, 533.
Because this involves the other aspects of healthcare and medical science is the economics part, which is very, very important nowadays, becoming very much relevant with the presence of newer technologies, changing demographics, and the most importantly, the insurance-based nature of the entire practice. So any medical professional just out of college or in their post-graduation or anywhere, it is becoming all the more relevant concepts of medical science economics. There is a economics, financials behind the medical practice, which is very much relevant to remain relevant and to stay focused and to grow in the ever-changing medical practice. So today we are going to focus on very basic aspects on how to keep an eye on your economics part of your medical science. So I from White Lotus International Hospital, which is in Kalamboli, coming up with a background of last 30 years, I have been in healthcare industry in different capacities. And this is my latest venture. So this is a hospital which we are operating last 1 year. This hospital has been operational, and we all know this is a 450 bedded hospital with advanced, is a very advanced facility, very large facility in Navi Mumbai. And nevertheless, of course, in line with today's technology based, AI based medical science delivery, it has got all the state-of-the-art equipment, including state-of-the-art cath labs. We have MRI 3 Tesla, various other medical gadgets and equipment which are definitely now becoming very much relevant and basic in entire medical practice. So there are various activities which we focus when we launched the hospital, started with a soft launch. We focused on cardiology and cardiac surgery as the main specialty, and then slowly venturing into medical gastro, surgical gastro, orthopedics, nephrology with a dialysis center inside the hospital, then neurology, neurosurgery, oncology, medical oncology, surgical oncology and everything. So on and so forth. We have plans to introduce radiation oncology also in near future. Definitely this is one of the state-of-the-art and definitely futuristic hospital which is going to cater to this area of Raigad also and everywhere nearby Mumbai. So going forward straight to the current topic of how to make your hospital profitable, I would like to rechange this name into how to make any medical setup for that to remain, stay relevant rather than profitable, if the profitable is a word, if we want to use this word, but definitely how to stay relevant in today's medical practice. You need to have financially viable setup. Whether we have a 10-bed hospital, 20-bed hospital, or a diagnostic center, or any kind of setup, there are certain basic economics which we cannot undermine, and neither we can shy away. Gone are the days 20 years back when hospitals and healthcare establishments were only seen for public service and improvement of societal quality of health. But now definitely with emerging trends, emerging medical technology and everything, hospitals are becoming much more relevant. They are getting publicly listed. They are raising funds from the capital markets and getting into multiple centers, not only in one center but getting into different cities, different towns, tier 2 towns, tier 3 towns are becoming focus. Earlier it was only for urbanization, urban medical traffic used to be catered, but now it is also getting into tier 2, tier 3 towns as well. And apart from the organized players, there are multiple hundreds, thousands and lakhs of hospitals which and medical establishments which thrives in large metros as well as in tier 2 towns, tier 3 towns, which all need to be profitable, which all need to stay relevant and need to make financial sense as well, apart from delivering quality health care. So it is very, very important, and I believe it should be a part of the entire medical curriculum where some basis of economics, some basis of financials should also be inculcated in today's modern medical graduates. So coming to this, I would like to keep it very simple for all of your understanding. I know most of you or may not be from management background, so I would avoid any management jargons in this, but try to keep it very simple, crisp. So what are the matrices? There are certain critical matrices which we should keep in mind whilst running your setup. Whether it's a setup means may not be a hospital, it can be a small diagnostic center to a large radiology center or a 20-bedded hospital or a emergency care, whatever is the practice size or shape. There are certain things which remain same. One is we identify these are the OPD footfalls and admissions and discharges. The data regarding OPD footfall, admission, discharges are very basic things which need to be kept and monitored on a daily basis. Then the second part, we always talk about it's a 400-bed hospital, it's a 100-bed hospital, 200-bed hospital. What is bed? What is a hospital bed and how do we calculate hospital bed? When the Bombay Nursing Home establishments give us this license, they mention the number of beds. This is a 500-bedded hospital, 300-bedded hospital. From a financial point of view, it is very important to understand what is a hospital bed. Hospital bed, when we recognize in terms of a hospital which is running for profit, they have these established beds which actually generate some kind of revenue. Now if I say this hospital is a 300-bedded hospital, but there are 50 dialysis beds, 20 emergency beds, then there are 10 other post-operative beds, and then rest of the beds are all in the ward and ICU. So what we say, these 70-80 beds which are in emergency, dialysis or in post-operative, pre-operative wards and all, they are actually not beds. They are not revenue beds. So finally your number of beds remains 230 out of 300. So you have to understand there is a clear distinction between which bed is generating revenue for you and which bed is not generating revenue for you. That means the bed which is where the patient is going to stay overnight and passing class at 12 midnight, those beds are considered as completely revenue bed. And most of the time I have seen there is some kind of confusion regarding calculating the number of beds in a hospital. I entered my previous organization, 300 bedded cardiac hospital. I asked how many beds you have in this hospital. Someone said 300, someone said 245, someone said 50, 250, someone said 275. Starting from CEO to the operations manager to the medical director, everybody has their own understanding of what is a revenue bed and what is a hospital bed. So I think that is very, very basic. We never think in that way, which bed is actually we count for generating revenue. Because why I am saying this and emphasizing on this, because understanding those beds are very important to understand the more advanced matrices which will be coming and discussing going forward in this. Third is OPD and IPD volumes. OPD and IPD volume is the number of footfall in OPD and IPD and the matrices around that. Then we have these IPD matrices. The patient, after getting admitted in the hospital, what are the matrices which are important to monitor to keep it profitable. So here we are discussing some of the very common IPD matrices. First one is the bed occupancy rate. It's a very loosely used word, that is occupancy. What is the occupancy of the hospital? Occupancy of the hospital and occupied beds, these are two different things. Number of beds occupied in a hospital and occupancy rate is very, very different, because number of beds, they might say, okay, today there are 40 patients in the hospital inside the ward or 50 patients in the ward. But what is the total occupancy rate is again divided by the denominator, the availability of the number of revenue beds. So if we divide the number of the number of occupied beds divided by the number of revenue beds, then we get the actual occupancy rate of those beds, minus your emergency beds which are lying, the beds which are lying in your pre-operative ward, post-operative ward and dialysis and so on and so forth. There are so many daycare beds and all. We are not considering them while calculating the occupancy rate of the hospital. So it's very, very important to keep in mind. Otherwise, whatever is the final value, to understand the valuable nature of each of your beds becomes very, very difficult. Second thing is average length of stay. Average length of stay, the way it sounds is very, very simple, but it's not so simple, because average length of stay actually determines the efficiency of your hospital, the setup which you are running. The average length of stay should be between 3.5 to 4. That is the average length of stay which you look at. But average length of stay calculation, I visit lot of universities, lot of postgraduate students everywhere. There is a common confusion regarding how do you calculate average length of stay. It's not so simple, but definitely understanding of average length of stay and working on it going to increase the profitability of your hospital. I will tell you how. Because average length of stay actually reduces your cost, because if the patient is staying in the bed unnecessarily, once the treatment is also over, or the treatment is taking some prolonged time in decision making, or there is a late discharge due to TPA approvals and all, this creates some inefficiency in the system and the average length of stay increases. So there are various initiatives to create this efficiency in average length of stay. Average length of stay is nothing. It is the total number of occupied bed days. That means total number of occupancy of the hospital in the entire month or entire period. That is the occupied bed days divided by number of discharges during that period. So these are the two metrics which are very, very critical to analyze your hospital's profitability, to analyze your setup's profitability. So you have to understand the total occupied bed days divided by number of discharges within a particular period of time. Third one, just now I used the word occupied bed days. Occupied bed days is not same as the occupancy rate. Occupied bed days is completely different thing. Occupied bed days is your occupancy on a particular day on a cumulative manner. Suppose your occupancy from first it is 30 out of 100 beds, next day it is 40, 50, 60. You add up all this and then determine the number of days, multiply with that. Then you get your occupied bed days. So these occupied bed days divided by the number of discharges happened during this period is going to give you the average length of stay. And keep on measuring this average length of stay month on month, year on year to understand whether there is an improvement. Now this average length of stay is not only for the entire hospital, it can be for a particular specialty also. We have seen from specialty to specialty like urology, neurosurgery is a very lucrative. Why it's a very lucrative specialty? Because the average length of stay stays between 2 to 3 days, whereas the neurosurgery average length of stay can be 7 days. Or for a cardiac surgery, where bypass surgery, the average length of stay is now 8 to 9 days. So that actually changes the entire economics of running your hospital, running your setup profitably. So you have to understand what kind of specialty mix you are going to have, what kind of admissions are happening under which specialty. Based on that, you have to determine whether this hospital is, how much profitable this hospital is going to be. Next one is the bed turnover rate. It is very, very important to have multiple admissions or discharges happening for a particular bed. So that is bed turnover rate. Then we have this, based on this previous, whatever we discussed, occupancy rate, average length of stay, occupied bed days, we have today's cornerstone of running any hospital is average revenue per occupied bed. Average revenue per occupied bed per day, ARPOB. This is the cornerstone, it has become cornerstone of hospital management since last 20 years, since Fortis, Max and all these larger players entered this business. They created this matrix. These matrices were not earlier available, but these were created over the period of time since the healthcare industry has grown in the last 20 years. So average revenue per occupied bed is nothing. It is how much this particular bed is valuable. What is the valuability of this bed? How much each of your bed is giving you return every day on a daily basis. So currently if you look at any hospital like Apollo Hospital as a group level, they have a 60,000 rupees ARPOB. That means average revenue per occupied bed per day for a single bed at Apollo group churns out 60,000 rupees, whether this bed is occupied or vacant. So that is your ARPOB, which is very, very important to understand. On a group level, this is the matrix for them. Definitely there will be hospitals which are 30,000, 35,000, 40,000. So this matrix, again, this matrix depends on your two things. One is your total revenue of the hospital. Total revenue of the hospital is the numerator in this case. Total revenue, at times people get confused that how do you calculate the revenue? Revenue is both IPD, OPD, every. Total revenue of the hospital you take in the numerator, and in the denominator you take your occupied bed days. How many days of the month, how many beds were occupied? So occupied bed days, which is your number 2 here, occupied bed days, that is your denominator, and revenue, total revenue of the hospital is your numerator, which gives you average revenue per occupied bed per day. And with this matrix, you can calculate what kind of revenue, what kind of budget you can achieve based on these calculations. So when you start now, this April month is coming, a new financial year starting. You can start doing your budgeting from now. How my next year, entire financial year is going to look like from a financial point of view. Suppose I want to acquire a new equipment. I want to invest 1 crore in capital equipment investment because I need to upgrade my setup. I need a particular machine. I need a particular technology to be in. For doing that, it's very important in the month of January to March, you spend some time in these exercises and understand how you allocate your budget, in what are the areas, and what kind of ARPOB you are going to get for the next financial year. Now ARPOB, average revenue per occupied bed per day, is not only for the hospital, it is also for the specialty. For a specialty like cardiology, cardiac surgery, your ARPOB can be very high because the stay is also high, but at the same time it gives a higher revenue. So ARPOB becomes very relevant for specialty wise also. Again, average revenue per occupied bed day is relevant from the payer perspective also. You can have a very different average revenue ARPOB for a CGHS patient or a scheme patient like MJPJY. At the same time, you can have a very different kind of ARPOB for a cash patient. So, in the month of January, February, March, you decide how many cash patients you are going to have, how many scheme patients you are going to have, how many insurance patients you are going to have, and you are going to have different kinds of ARPOB for each of these kind of patients. So, enter mix. Suppose you have 30% of scheme patient, 30% of insurance patient, and 40% of cash patient. The entire mix is going to decide what is the revenue, and that revenue is very much predictable. If your calculation is predictable, you know, okay, this is my revenue. This is what is my achievable perspective of my total business, if we take this hospital as a business. So definitely it's very important to understand and do this exercise in a more meticulous manner without any confusion. So if you have your basics, how many beds I have, how many revenue beds, how many non-revenue beds, all these things are clear. Then we do the exercise, you are going to come up with the right kind of number, and your financial plan is going to stay at where you want to be. It's very important that it doesn't go haywire at the beginning of the year if these basic matrices are very, very clear. So going from forward, these are the dashboards and matrices which definitely need to be seen to keep the hospital running, to keep the hospital predictable, revenue predictable, and also the cost predictable. So one of the most important thing which we have seen while investing in various hospitals, I was the investor with various hospitals when I was with ICICI Venture as a private equity company which invests in early stage hospitals to build them big, make them bigger. I was involved with Shayadri Hospital, Pune, in 2008-2009 when we invested in around 60 CR in their early growth stage. Today Shayadri is acquired by Manipal Hospitals. So where we started, we have seen there is no MIS discipline. HMIS discipline is very, very important, which is at a daily basis. MTD is month till date. Then LMTD, comparing with their last month's data is also very important. Then YTD is year till date. And LYTD is last year till date. So these are some of the things which might look very basic, but it has got immense impact on your profitability and the way you manage your system, the way you manage your revenue. So every month, sit with your accountant or sit with your manager or whoever it is and find out what is your MIS looks like, what is your daily basis, what are the aspects which you are going to see, monitor in your daily basis. At the end of the day, next day you can sit and see the daily MIS and also compare with MTD. MTD means suppose till 10th, you are looking at the MIS on the 10th of the month. That should include all the data from 1st to 10th. That is MTD. And YTD is, suppose you are doing it in the year, suppose you are doing on 1st of July. That means 3 months data should be there, April, May, June. The financial year of April, 3 months have gone. So all the 3 months data is clubbed together and seen as a YTD data. So YTD data is very, very important when you are looking at the yearly budget, annual budget of the organization. So how it is doing compared to what you projected. So YTD versus budget is very, very important. That's why it is called YTD. These are some of the very basic terms, but definitely must be used when you are developing the MIS. And then is LYTD. What was the situation of my financials, of my volumes last year compared to this year? So LYTD, last year till date, what was the status? So that is the comparison which you must be making. Whenever you are making a MIS, please understand and remember, I have seen many organizations, they do not keep the previous period data. It has to be always compared with the previous period data, and a data seen in isolation actually takes you nowhere. So always compare the data with your previous period. Suppose this week data you are taking must be compared with your last week data or last month data. So that's very important from a MIS point of view, and please analyze the MIS on a monthly basis whenever possible. Second thing is the operational dashboard. Operational dashboards are very, very important to understand the efficiency of your entire organization, how it is running. And TAT is a very loosely word and very much used word, overused word, that is turnaround time. Turnaround time of your reports, turnaround time of your any activity, whichever is coming to you and you need to service those, you must count and must monitor the time taken to do that job. Now, OPD waiting time. OPD waiting time is an immense impact on hospital profitability, efficiency and everything. So OPD waiting time is very much important, and in this also there need to be some benchmark depending on what kind of OPD you are running, whether it is a specialty OPD, super specialty OPD, what kind of benchmark and all, and what is the whether there is an improvement in OPD waiting time or not. Second is discharge time. Discharge time itself is a very huge subject, because discharge time is a very much important aspect of hospital management, and this is a large aspect of the entire hospital's proficiency, efficiency, and finally leading to profitability. Tell me how. This is because of discharge time, actually your length of stay can vary, because at times we cannot discharge a patient because the patient is from insurance or TP or something like that. And in this situation, what happens? The length of stay increases, the patient is staying inside the room, but the patient is not getting billed because all of his services are already over. So discharge time becomes very much important. At the same time, also it creates agony and restlessness inside the patient. Even after a very good treatment, every services are very good. At the time of discharge, there is a lot of chaos, there is a lot of confusion, because the bills are not ready, or the discharge summary is getting changed multiple times. There is coordination issue between various inter-departments, pharmacy returns are not going on time. All these things are actually impacting your discharge time.
Sir, pardon me, sir.
So it's very, very...
We are short of time, sir, please.
Okay. Shall I just conclude this with a... Just 2 minutes. So equipment utilization and radiology, pathology, OT are cath labs. This is also very, very important matrix, which is, understanding of this utilization of every equipment. These are all revenue generating equipment, and utilization must be monitored on a daily basis. So finally, I just like to give us very small, this is a very, very important slide, and I don't want to miss this even for the paucity of time. So I'll just quickly take you through. We always loosely say MIS, PNL. PNL is profit and loss account, and MIS is management information system. So MIS actually shows the efficiency of the hospital. MIS focuses on operating volumes and revenue, and MIS is a daily and weekly basis you should be monitored. But PNL is actually also takes care of your cost part. So PNL gives you the profitability of the hospital. PNL shows the cost. All this time in my entire lecture I have not focused on the cost part of it. So cost is actually captured in your PNL, monthly PNL, and then PNL is actually monitored on a monthly, quarterly and annual basis. So these are some of the things which are very basic things. It's very difficult to give the entire snapshot so quickly, but definitely I hope you got some insight into how to run a hospital more efficiently. I would say efficiently than profitably, because if the hospital is efficient, definitely that setup is going to be profitable as well. Thank you very much.
थँक यू सर. चेअरपर्सनला मी विनंती करतो की आजच्या स्पीकरचा त्यांनी मोमेंटो देऊन सत्कार करायचा आहे. स्पीकरना मी विनंती करतो की त्यांनी चेअरपर्सनचा सन्मान करायचा आहे मोमेंटो देऊन. नेक्स्ट लकी ड्रॉ आहे PCC तर्फे पुष्पक चिरमाडे कॅन्सर सेंटर.
गौतमी राय. गौतमी राय.
गौतमी
RAYE.
राटे. नाही. डॉक्टर गौतमी.
डॉक्टर रसिका म्हात्रे. डॉक्टर रसिका.
डॉक्टर रसिका म्हात्रे.
नाही. डॉक्टर एहसान शेख. डॉक्टर एहसान शेख.
थँक्यू सर.
थँक्यू व्हेरी मच.
ओके थँक्यू सर. पुढचं लेक्चर आहे, टॉपिक आहे ब्रेन हेल्थ सम फ्युअल फॉर थॉट्स. स्पीकर आहेत डॉक्टर सुमित पवार. मी चेअरपर्सन डॉक्टर राज कल्याणी आणि डॉक्टर गणेश साळुंके यांना विनंती करतो की त्यांनी आजच्या स्पीकरना व्यासपीठावर घेऊन यायचं आहे. वेलकम सर. चेअरपर्सनना मी विनंती करतो की त्यांनी आजच्या स्पीकरचं बुके देऊन स्वागत करायचं आहे. डॉक्टर सुमित पवार MBBS DNB न्यूरोसर्जरी, कन्सल्टंट न्यूरोसर्जन अँड स्पाइन सर्जन ॲट अपोलो हॉस्पिटल नवी मुंबई, ट्रेन ॲट KEM लीलावती अँड हिंदूजा हॉस्पिटल. 14 वर्षांहून अधिक प्रॅक्टिसमध्ये 7,500 प्लस ब्रेन अँड स्पाइन सर्जरी यशस्वीरित्या केलेले आहेत. एक्सपर्ट इन minimally invasive and endoscopy spine surgery including awake spine procedures, special interest in spine disorders, brain tumors, pediatric neurosurgery and trauma, 37 plus research publications, international faculty and fellowship program mentor. या पहिले एक लकी ड्रॉ होईल MOC कॅन्सर सेंटर. माइक. डॉक्टर दीपक टक्के. डॉक्टर दीपक टक्के. डॉक्टर शशिकांत भुजबळे 506. डॉक्टर शशिकांत. डॉक्टर शीतल 264. नाही. ओके सर.
Thank you, Raigad Medical Association, for this opportunity to speak about this very interesting topic, food for thought. आपल्याला सर्वांना माहिती आहे की whenever patient has any cardiac issues or any other issues, we all know की what is supposed to be done. तळलेलं खाऊ नका, फॅटी पदार्थ खाऊ नका, सगळं कल्पना असते. What is to be done when you are suffering from any brain issues? आता अर्थात स्ट्रोक झाला किंवा हायपरटेन्सिव्ह ब्लीड झालं की वी हॅव व्हेरी स्टँडर्ड वॉट एव्हर यू फॉलो फॉर एनी कार्डियक इलनेसेस, सेम तुम्ही ब्रेनसाठी फॉलो करा. मीठ कमी खा, पापड कमी खा, आज जे आपण खाल्लं सगळ्यांनी ते कमी खा, आणि दॅट वर्क्स टू अन एक्सटेंट. बट देर इज नो पर्टिक्युलर आन्सर दॅट वी हॅव टू प्रिव्हेंट न्यूरोडिजेनरेटिव्ह disorders like Alzheimer's, Parkinson's, dementia, which is coming up with a very, very rapid pace and taking over our lives. So we did some study and patient used to ask me की सर आईला पण अल्झायमर्स आहे, तिला पण एकदा बघून घ्या, खाण्यासाठी काय करायचं? ऑल सर कॉमन आन्सर असं ग्रीन लिफी व्हेजिटेबल खा, ॲट द मोस्ट अक्रोड खा, त्याच्या पुढे पलीकडे आम्हालाही काही माहिती नाही. So we went into depth of this topic. Let us research whether our day-to-day food habits can really change the brain health or not. So current epidemiological research supports that nutrition is capable of normalizing and attenuating many of the molecular and structural changes with the brain aging. The fundamental shift in the perspective is required, and that is the only way we can ensure that the brain health in geriatric population will remain good. Data reveals the signs of cognitive deterioration can be detected in adults as young as in their 20s, and rate of decline often accelerates significantly in the years immediately preceding to the diagnosis of mild cognitive impairment or dementia. So that is why we are going to discuss today's topic in several headings. First, why we need to study what we are studying, how it affects our health, the food that can actually change our brain health, and how to different food groups and different diets that can actually impact our life, our brain health, and our longevity. So here we are going to look at the introduction. There is a global prevalence of age-related dementia and cognitive impairment and neurodegenerative disorders. Multifactorial etiology is known, sharing common risk factors, like I said, with cardiovascular diseases. But apart from this, there are separate issues as well. Nutritional status is a key modifiable determinant of cognitive trajectory. So we have to formulate a lifelong preventative strategy. How to normalize and attenuate the molecular and structural changes of the brain aging, how to detect the signs of cognitive deterioration in young adults who are as early as in their 20s, and what nutritional interventions need to be taken. So three aspects need to be looked into this. First is providing the brain with essential structural lipids, essential regulatory molecules, and providing a nice stability in which the brain, neurons, muscles can thrive. You have to target the chronic systemic inflammation and reduce the long-term oxidative stress, and promote the neuronal integrity, promote neurogenesis and synaptic reliances. So dietary factors are key modulators of inflammation. You must have read when Vidya Balan made the statement that I am having an anti-inflammatory diet. Patients come and ask us, what is exactly anti-inflammatory diet? I actually had to Google what she is speaking about. Chronic inflammation, systemic inflammation, it does compromise the blood-brain barrier. God has given a fantastic blood-brain barrier which avoids the toxins from entering the brain. Our chronic inflammatory status breaks down this blood-brain barrier, and that leads to the interplay of the interleukins and TNF alphas and the CRPs to cross the blood-brain barrier and damage the brain. So high consumption of processed food, refined carbohydrates, and saturated fat are linked with the elevation of these markers. So second thing is insulin resistance. Impaired neuronal insulin signaling is linked to cognitive impairment and Alzheimer's disease. The induction of insulin resistance, endoplasmic reticulum stress, and mitochondrial dysfunction within the neural cells is going to be again affecting our brain health. The westernized diet, which are rich in saturated fatty acids, they cause this dyshomeostasis. We all know that always whenever we have a patient with any stroke or any cardiac issue, we do a homocysteine level. We need to understand that the saturated fatty acids, they induce this resistance of insulin. Insulin is very important in proteostasis. It clears away the protein accumulation in the brain. The pathological phosphorylation of tau protein, which is linked to Alzheimer's disease, it clears out that as well. And if we have insulin resistance in our body due to metabolic issues, due to excessive adipose tissue, this will lead to bigger problems in the brain health as well. Now, we come to what are the nutrients that are essential to heal, help, promote the brain health. Number one, all of us know, is omega-3 fatty acid, the DHAs and EPA. They are long chain polyunsaturated fatty acids, the PUFAs. They are fantastic for cognitive longevity. They have a role in neurogenesis, neuronal signaling, as well as neuroprotection. The brain plasticity, that is what you require for constant learning, that is very essential in our fields as well, not just for counseling your patients, but for your own selves. The DHAs and the EPA is very, very important for us for continued brain plasticity. Second is the B vitamin complex, the folate, the B12 and the B6 multivitamin. They have a role in methylation and they reduce the homocysteine levels which can damage the brain and thereby protect the neurovascular system. The synergistic action of B12 and omega-3 fatty acid, they act on the brain-derived neurotrophic factors, the BDNF. We are going to read about this a lot in the further. A good dietary sources include the green leafy vegetables, legumes, and meat, fish, and other dairy products, other animal products. Then we have some fat-soluble multivitamins like vitamin D, E, and K. Vitamin D, all of us know that vitamin D is low in surprisingly most of the Indian population. Whenever we do a test of vitamin D, 15 के नीचे आएगा नहीं तो 15 के आसपास आएगा. For some reason, patients have depression, irritability, body pain, joint pain, listlessness, and all the symptoms which cannot be really contributed to anything per se are due to vitamin D deficiency. Also for brain health, the most important dietary source over here remains the fatty fish. Fatty fish, when I say fatty fish, it means the salmon or mackerel or tuna. Fish liver, mushrooms, and fortified products. Vitamin E is very essential antioxidant. It is lipid soluble. It is found in asparagus, avocados, nuts, seeds, and spinach and vegetable oils. And vitamin K, again, is very, very essential, a fat soluble vitamin. Very essential for brain development and brain damage prevention. Choline is a precursor for many brain cell membrane structures and as well as acetylcholine, the neurotransmitter. You may find that in egg yolks, soy, beef, or liver. Flavonoids and anthocyanins. These are found in your berries, strawberries, blueberries. All these berries contain high amount of flavonoids and anthocyanins. They are extremely essential to prevent brain decay and brain aging. They will actually improve your brain health if you are having in a good quantity. And of course the carotenoids, the luteins and xanthins, they have very high neuroaffinity and they prevent in neuronal dysfunction and neuronal cell death. Turmeric. This was a very surprise for me as well. All our ancestors have kept on telling us कि शादी करेगा तो भी हल्दी लगाओ. We marinate the bride and the groom with literally turmeric. Whenever after your marriage you have haldi kunku and the turmeric, all our food products, all curries they have high amount of turmeric. Today there are extensive research going on about the role of turmeric in preventing brain damage in the brain health. It actually has a proof that high consumption of curcumin, that is the active ingredient in the turmeric, in populations like India may contribute to lower prevalence of Alzheimer's disease observed in that country. It's very essential for us to understand this. So what we have studied so far is that omega-3 fatty acids are essential. They have DHA, EPA and ALA. They are found in your fatty fish, walnut, salmon, mackerel, tuna. The B complex vitamins, the B6, B9 and B12. Please take a photograph of this page. This is a very good summary for you to explain to your patients and to explain what to eat, what not to eat. You have the leafy greens, meat, fish and legumes from which you can get the vitamin B12, the B6 and B9. Antioxidants, which are important to remove the reactive oxidant stress. They are found in your berries, they are found in turmeric, leafy greens and eggs. And vitamin D, of course, can be found in nice, good sunlight or animal products like mushrooms or fatty fish or fortified products. Now, how do you combine all this and what do you give to the patient? So, we know that oily fish and seafood, I'm reversing the pattern right now. I'm hitting same thing again and again to explain, we should know what to give to a patient. There is a dose-response relationship. This study has shown that reduction of up to 30% of brain-related dementia or other neurodegenerative disorders if you have more than 150 gram of fish products a day. This is very important for us to understand. leafy greens are very essential. They are the foundational element of your neuroprotective diet. They are rich in vitamin K, lutein, folate, and beta carotenes. Kale, spinach, collards, and broccoli are the newer are counter products from outside India, and they are also very good in consumption to get the vitamin K and other luteins. Eating these products with olive oil or avocados will improve the bioavailability of vitamin K and lutein. So also combination is important. The berries and fruiting vegetables, they have the pigments are the ones that confer the neuroprotective benefits. They have anthocyanins and flavonoids. They do improve the memory. Nuts, seeds, and healthy fat, we all know. Walnut are particularly important for people who are pure vegetarian, because that is the only nut that has significant amount of plant-based omega-3 fatty acid. Avocados are very good because they have high amount of polyunsaturated fatty acids. Whole grain and legume, they form the base of your high fiber content that are very essential for your gut flora and controlling your sugar peaks, controlling your insulin levels. So they will help in balancing out the sugars. So now we have this Mediterranean diet. It's called DASH, Dietary Approaches to Stop Hypertension. It's a very standard old known diet for all of us. There is a new interplay called Mediterranean Dash Intervention for Neurodegenerative Delay, MIND diet. This diet that helps in controlling or preventing cognitive dysfunction. It is standardized, proven that this will delay your brain damage. It will be healthy for your brain. 10 good things, 5 bad things. 10 good things are whole grains, green leafy vegetables, and the quantity, how much you should be having per day or per week, also described over here. This has properly, statistically proven to prevent brain damage. Nuts, beans, berries, poultry, seafood. This is a vegetarian based diet. Like you can see, the poultry and seafood are literally 2 and 1 servings per week. The rest of the servings totally are based on whole grain, unpolished, not refined, with the husk. Green leafies are 6 to 7 per week. Wine up to 1 glass per day if you drink alcohol. And these are 5 not so brain healthy food products. So you should control the amount of butters, red meat, whole fat cheese, pastries and any kind of sweets, and fried and fast food. Essentially, just exactly what our parents were trying to tell us is what I feel. In short, if I have to summarize this lecture in one sentence, eat what your grandfather used to eat, you will be healthy. Nothing special, nothing fancy. These are few diet options that are just very, I think, I tried to search for what is a good diet options, and they were just too difficult for even me to overthink. But still, you can have oats with fresh berries. You can have the herbed quinoa salads. They are very, very good and very healthy. Please, in your OPD clinic, keep some nuts and berries when you're hungry. It is absolutely okay to have nuts and berries when you are hungry, to keep on snacking frequently within the daily limits of your calories. Completely ditch your butter and go for olive oil. Olive oil has one side effect: it cannot be used for frying. All our Raigad food, all our Konkani food, all our Mumbai food is based on frying, shallow frying or deep frying. For that, you may consider to use the coconut oil. Avoid the groundnut oils, and these have very high amount of damage potential for your heart, brain, and otherwise. So this is again a short. Your main food, the base of the pyramid, the base of your food must be whole wheat cereals, breads, potatoes, pasta, rice. It should be whole. It should not be polished one. Green leafies, other vegetables, and olive oil, that forms your base. You may add once or twice a week berries, nuts, fish, beans, and poultry. Limit your intake of cheese, unhealthy fats, red meat, fried food, and desserts. So that's my essential endpoint of the entire article. Of course, I have some slides more about the gut flora and how that will improve your, like I said, it will control the sugar spikes, it will improve the insulin sensitivity, and it will control the way you are absorbing the nutrients. If I have to give one fixed summary to the entire thing, my summary would be this. focus on these kind of foods, forward these to your patient groups, and stay healthy, and you'll remember this lecture for a longer period than otherwise what you would have remembered. Thank you so much.
थँक्यू सर. मी चेअरपर्सनना विनंती करतो की त्यांनी गेस्ट स्पीकर यांचा सन्मान करायचा आहे. स्पीकर्सना विनंती आहे की त्यांनी चेअरपर्सन सन्मान करायचा आहे. पुढचा लकी ड्रॉ आहे PCC तर्फे. लकी ड्रॉ डॉक्टर कुमार ओसवाल. डॉक्टर सिद्धेश मेहता. Thank you, sir. Next session continued by Dr. Kamini.
Good afternoon, everyone. Thank you, Dr. Kunal, for the seamless handover. I appreciate your coordination. I request Chairperson Dr. Girish Gune sir and Co-Chairperson Dr. Bhavesh Oswal sir to please accompany our guest speaker Dr. Sanjeev Kalkekar sir to dais. I request Chairperson Dr. Girish Gune sir to please welcome our speaker by offering a bouquet on behalf of RMA Raicon 2025-26. Before we move to the session, we will now have lucky draw sponsored by MOC Cancer Care Research Center, Panvel and Vashi. I request our guest speaker to do the honor and take out one lucky winner from the box. Dr. Purva Jain. Nagesh, Dr. Nagesh Chitte. Dr. Nagesh Chitte. Congratulations, Dr. Nagesh Chitte, sir. Scientific session by Dr. Sanjeev Kumar Kalkekar sir. Dr. Sanjeev Kumar Kalkekar sir is a senior consultant interventional cardiologist at Apollo Hospital, Navi Mumbai. Sir is having experience of 15 plus year with 18,000 plus cardiac procedure. His expertise in angioplasty, structural heart intervention like TAVI and Mitra clips, only leadless pacemaker, only national leadless pacemaker for Western India. Sir will be speaking on updates in cardiology. I request sir to please start the lecture. Thank you.
First of all, I just request the army body to please call all the people which can come inside. I have seen a lot of attendances outside than inside. We have outstanding members. Can I start? Hello, yeah. The lecture taken by the Sumit was one of the greatest lecture. I don't know, neurosurgeon can take such a lecture on diet. First time I am seeing something. Nice, Sumit. So mine is a simple work, update in cardiology. Those who are sleeping, for them, this is a welcome song. Please wake up. I think this is not working. That's okay. So, thank you for my nice introduction. My specialization is complex angioplasty. I am a proctor for the leadless pacemaker. Yeah, you can play, not to worry. Leadless pacemaker. Then I am independent operator for the TAVI, an expert for the Watchman device, and proctor for RDN also. So, this is the hospital where I have come from. One of the greatest hospital, the first JH hospital in Navi Mumbai, having all the sorts of treatment here under one roof. Now, the angioplasty, when you think of angioplasty, basically one wire, one balloon and one stent, that is thought. So, we see that there is a block in this tank, we go there, put a wire, put a balloon and put a stent, that's done the angioplasty. But what is complex angioplasty? That is the question. Now, suppose you have one patient coming towards you and the one cardiologist has done his angiography and he told that you have 80% blockage and you require an angioplasty. And patient comes towards you and आप पूछता है सर उन्होंने तो बताया मगर आपका भरोसा था हम पे ऊपर हम बता दो आपको क्या करना है. You send this patient to your favorite cardiologist. Now this cardiologist block is 60%. Now problem is that both the cardiologists are good, not money oriented. Both are good, but one cardiologist feel it is 80%, another is it is 60%, and 70% is the cut-off line for doing angioplasty. So if it is 80%, angioplasty should be done. If it is 60%, it should not be done. Now what should you do? हाँ, क्या करना चाहिए, किसका सुनना चाहिए? जब आदमी पे भरोसा नहीं रहा तो मशीन पे भरोसा रखना चाहिए. So the first is the FFR. So whenever there is a 70% or borderline lesion, we use the help of the FFR. FFR is fractional flow reserve. What you do, we pass one wire across the block, and with the help of this wire, we check the pressure distal to the blockage and proximal to the blockage, and depending upon that, we can tell the patient that yes, your block is significant or your block is not significant. Due to this, what has happened? The right person should get right treatment. A person without significant blockage should not undergo angioplasty or surgery, or a person with a significant blockage should go medical management treatment. That is the fractional flow reserve FFR. Now another is the imaging guided angioplasty. Now till the time whatever doing angiography, everything is vision. So I say this is 70% blockage. I say this is the nice artery open. I say that every cardiologist say that I feel. But sometimes feeling is not right always. No? Okay, I feel that I am Modi, it cannot happen. So sometimes we require something different. So the जसं दिसतं तसं नसतं एक चिंती. So when you are putting a stent, we always require to be precise the artery, whether the artery is 3.5 millimeter or 3.75 millimeter, and we can fight for years, 2 hours. No, I feel it is 3.5 millimeter. Another cardiologist say it is a 3.75 millimeter. If you undersize the stent, it can get closed. If you oversize the stent, it can cause trauma or perforation. So what is used in such patient? We have used like imaging guided angioplasty. So what we do? We pass here like cameras inside the heart arteries. We pass this wire and we can see the imaging of this heart arteries. Now, can you see what will be this? This is not histology. It looks better than the histology. This is OCT image, optical coherence images. So where we can see exactly what is the size of artery. We can see this is 3.5 millimeter, 4.4 millimeter artery. We can see. Now just think, you are in the, what do we have in the Khopoli? We are in that Mr. India's game, and we are just saying you are in the coronary arteries. And I will show how the coronary arteries look inside the stent. Just see this thing. Can you play this image for me? Yeah. Now this is a wire, this is the coronary artery, exact coronary artery, and the white looking is the stent. So I can tell that this stent is absolutely open because it is looking white. If it is looking black, red somewhere, it means that that part of stent is not open up. I can go again and open up that stent. So this is the image guided angioplasty. So image guided angioplasty could be with the IVUS or it could be with the OCT, optical coherence tomography. So one can give the precise detection of the size of the stent, length of the stent, and one can detect the small dissection also. So this is the OCT, optical coherence tomography. So whenever doing an angiography, CT angiography is looking like this thing, the resolution is like this. Your angiography may give resolution like that. IVUS may give that, and OCT may give that like. So whenever needed, the optical coherence tomography, the imaging guided angioplasty score far better than the routine angioplasty. Next one is CTO. Suppose a block is fresh block, we can open easily. But if the block is artery is blocked for more than 3 months, then it called as a chronic total occlusion. Whenever there is CTO, artery opening chances are very less. The standard rate is 70%, but with our expedition, we can go till 85%. And opening this vessel is very difficult. Another is left main bifurcation. Just 5 days back, one of the patient come with STEMI elevation, anterior MI, we done the angiography. Angio was left main 90% distal critical. Now ideally this patient should go for a surgery because if there is main artery involved, there is a bifurcation, L section. If I put one stent here, another artery can block. If I put stent here, another artery can block. So, but in an emergency, we cannot send this patient for surgery. Surgery will take at least 4 hours. Patient may not be stand that much time. So we need to do emergency angioplasty. That angioplasty is called the left main bifurcation angioplasty. The technique that we put a stent main artery, open up that stent, put another stent, and do the kissing balloon there. So these techniques are available. We are doing routinely. This is the complex angioplasty. What is anemia of cardiologist? Can anybody tell? What is anemia of cardiologist? Cardiac surgeon? No. Calcium is anemia of cardiologist. Whenever there is calcium blockage inside the heart rate, we can open up the balloon. Balloon gate ruptures. So in such patients, usually if the patient has a high calcium load, we have to send this patient for the surgery. But with newer technique called as special balloons, rotational atherectomy, rota, what you say, or orbital atherectomy, it is like drill machine. We can just drill the coronary arteries and artery, the calcium can be ablated there. Or the new balloon like lithotripsy. You know the lithotripsy in the renal stone. Similar lithotripsy balloons are available for coronaries. We use this balloon inside the coronary arteries, give the shocks and the artery gets opened up because calcium is broken. So all this come in the coronary angioplasty. So this is first part of my lecture is over. I had just taken 5 cases for you. Now this is second part. A 76 female, mother of a doctor from Khargar, diabetes, hypertension, presented with breathlessness. BME was done in 2003, balloon mitral valvotomy. Mitral valve replacement are done in 2012, and this valve get closed. Mitral valve replacement are done in the 2014. Now she present with the mitral valve restenosis. 78-year female, 3 times already cardiac surgery has been done. Now the option for her was again removing that valve and putting another valve. She was hardly 45 kg. Doing third surgery in such age is very difficult, very high risk. Age was the problem. Post-surgical 2 times surgery was problem. Refused by the patient, refused by the relative, refused by the surgeon also. I think 78 में क्या करना है? But ये महासाब थे तो उन्होंने 78 में भी बहुत कुछ किया था. I thought I should not do things. So what should be the therapy in such patient? Yes, anybody? क्या करना चाहिए? माइट्रल वॉल रिप्लेसमेंट हुआ है, वो वॉल अभी छोटा हो गया है, अभी उसका ट्रीटमेंट करना है एंड पेशेंट डजंट वांट टू डू सर्जरी. बलून करेंगे तो वेरी गुड चॉइस. इफ यू डू द बलून, वॉल विल ओपन बट इट विल कॉज माइट्रल वॉल regurgitation. So new technique is called as a TMVR. TMVR is transcatheter mitral wall replacement. So you know the TAVI or TAVR. सो तावी में हम क्या करते हैं, एओर्टिक वॉल जहां पे रहता है वहां पे हम जाते हैं, नया वॉल डालते हैं. टुडे ओनली आई हैड डन द फर्स्ट केस ऑफ तावी विथ रेजिलिया वॉल. तावी विच एओर्टिक वॉल स्टेनोसिस में जो वॉल रिप्लेस करते दैट इज अ तावी. Until now the wall which you put tavi wall there like life is like 8 to 10 years, but the new wall which is called as a Raigad wall, the tissue technique is a dry tissue. All the walls are wet. This is the dry tissue wall. His life is like 15 to 25 years. So that was the first case done in Navi Mumbai. So this is the TMVR. So this is the transcatheter mitral wall replacement. So earlier wall is this wall. I go from here, put another wall inside that, and this wall will open up. What should be the route? कैसे जाना पड़ेगा हमें? Yes, anybody? Femoral vein or femoral artery? Femoral vein से IVC के बाद RA के बाद RV. अपने तो लेफ्ट साइड जाना है. RA के बाद अभी LA तो रास्ता है ना, बंद है उधर रास्ता, तो क्या करना पड़ेगा? We have to open up that left atrium. Atrial septum has to be open up. Septostomy हमें करना पड़ेगा. Then enter on the left atrium, then enter to the LV, and then put the wall there. That is a TMV, mitral wall replacement. So you got it. So whenever there is a restenosis of the mitral wall, TMV is the. So this was one of the rare case. That's why these photos are there. I learn all this TAVI technique and TMR technique at Cleveland Clinic, USA. Now this is another patient. 2 patients already done. Third case. This is a Kenyan lead. I gone for Kenya by Apollo for OPD, international OPD. She was 83 year, very active female. She has a hypertension and develop atrial fibrillation. So whenever patient has a atrial fibrillation, there are chances of clot formation in the left atrium appendage. And this clot can go inside the LA, then LV, and they can just shower anywhere. So it can paralysis, can cause abdominal pain, can cause heart attack, anything. So she developed stroke due to the atrial fibrillation. So doctor at Kenya started warfarin, which was a right therapy for that lady. But alas, the problem was due to warfarin, she developed brain bleeding, hematoma. So he has to stop the things. He told कि दवा दे मगर खराब problem आ रहा है, बंद कर देता. But after stopping the medicine, she again developed infarct. So he thought I should give newer one. So he gave rivaroxaban. But after giving rivaroxaban, she developed bleeding. So she had 2 strokes and 2 times bleeding. Now with that, she was still good. Now what to do in such patient? This is a catch-22 syndrome. Giving medicine was problematic. Non-giving medicine was also problematic. What should be done? I told जहां से प्रॉब्लम है उसे क्लोज करो, ना रहेगा बास ना रहेगा बांसुरी. तो दैट इज कॉल्ड एज अ लेफ्ट एट्रियल क्लोजर डिवाइस. सो देयर इज अ डिवाइस व्हिच वी प्लेस अक्रॉस द लेफ्ट एट्रियल अपेंडेज, एंड वंस यू पुट दिस डिवाइस, व्हाटएवर क्लॉट दे आर फॉर्म, दे विल नॉट कम इनसाइड द ब्लड स्ट्रीम, एंड वंस दे आर नॉट कमिंग इनसाइड द ब्लड स्ट्रीम, we need not to give any medicine also. Sir, bleeding stop and your stroke also stop. So this is a Watchman device. Can you see? So it looks like similar. This was the second case of all across in Mumbai. So this is the lady which I will just show her photo. Then I will proceed for the next image. So this was the lady which is there. So Watchman device is like maybe chowkidar to prevent the clot. Now this is a MD physician, one of the greatest hospitals owner. He is a 74-year-old male physician, presented with giddiness, has a complete heart block. So what will he require? ECG has complete heart block. He will require. Earlier pacemakers were not rate responsive, but now they increase the heartbeat as per the requirement. Earlier pacemaker you are not able to do MRI, but this pacemaker like you can do MRI. But this patient request what I don't want to inform to my wife. You should complete this everything within 4 or 5 hours only. I am not going to stay in the hospital because my wife is suffering from malignancy. Now if I do a pacemaker, I need to do surgery and then this. All things, at least patient requires 3 days straight. So I did certain wonder for this. And this is called as a leadless pacemaker. A pacemaker can be implanted directly into the heart. Like earlier stent, we can put a stent direct inside the heart. So like similarly, pacemaker also can be implanted directly inside the heart. So this is leadless pacemaker. So these are indicated if there is a problem with the normal conventional pacemaker. If some patient doesn't want any kind of surgery, if a female patient doesn't want any scar or chest, RA, then RA to RV, we directly implant this leadless pacemaker into the right ventricle. So this is a single chamber leadless pacemaker. And now recently, last 1 month only, we have come up with the dual chamber pacemaker, and I am very happy to tell you that I was the first person to do this dual chamber pacemaker across Mumbai. So the patient is not there because he was a doctor, doesn't want to show his face. So the benefit is that it is a fast, no surgery required, there is no scar, no bump, just closer to your heart. Now last slide, 4.52 minutes. Now controlling BP without medicines, art of blood pressure control with interventional procedures. Now hypertension is the single largest contributor to death. 1 in 3 adults have hypertension. Problem with the hypertension is that 35% of the patient are untreated, 30% of the patient are controlled, and 35% of people are only treated and controlled. If you reduce the blood pressure, renal denervation is a technique where we pass the radiofrequency catheters. Renal denervation is a technique where we pass the radiofrequency catheters inside the renal arteries, and renal nerves are over the renal arteries. So we pass this catheter, ablate these renal arteries so that renal nerves will get damaged, and once this renal nerve damages, the signaling stops, and once the signaling is stopped, the blood pressure gets controlled. How the technique is? See the technique. So these are the catheters which are passed across the from the femoral artery into the renal arteries, and we pass the catheters. Then we give the electrophysiology energy, and with that part we ablate these renal nerves. So RDN is effective if a BP remains uncontrolled with medicines. If a patient doesn't want to take medicine, or if there are side effects due to the medicines, guidelines are there. For this patient, patient was on dialysis. This was the first case across India where we had done RDN in a patient with an ongoing dialysis. Blood pressure dropped to 70 milligram, and she doesn't require any medicine after 2 months. So from 7 to 8 medicines, she come down to no medicine. So RDN is one of the effective therapy whenever blood pressure doesn't gain control with the medicine, or if the patient has non-compliant, or if the patient doesn't want to take medicine. So if you have a severe aortic stenosis, we have a therapy like TAVI or TAVR. If you have a severe mitral stenosis, we have therapy like BME. If you have a severe mitral regurgitation, we have therapy called as a mitra clip. If you have severe MS in a bioprosthetic valve, we have TMVR. If you have severe tricuspid regurgitation, we have a trick valve. If you have resistant hypertension, we have RDN. If you have heart block, we have leadless pacemaker. We have complex seed, we have complex angioplasty. So you name the therapy, everything is available with expertise hand. Thank you. Questions are welcome. At least cost to pucho. TAVI takes near about 18 to 25 lakhs depending upon wall. RDN takes 8 lakhs. Lakh device takes 8 to 9 lakhs. So all the procedure between 10 to 30 lakhs. It is costly. So take home message is take your enough insurance.
Thank you, sir, for such an insightful session. I request Chairperson Dr. Girish Gune sir and Co-Chairperson Dr. Bhavesh Oswal sir to please felicitate our guest speaker on behalf of Raicon 2526. Now I request our guest speaker to please felicitate our chairpersons.
Good, sir.
Now it's time of our next lucky draw, sponsored by Dr. Pushpak Chirmad Sir Care, Vashi, Thane and Panvel. I request our guest speaker to do the honor and take out one lucky draw winner name.
प्रसाद जगदाळे.
प्रसाद जगदाळे.
डॉक्टर रवींद्र.
Dr. Ravindra. Dr. Ravindra is here. Congrats. Thank you, sir. Sir almost covered all the recent updates in cardiology. So, thank you. Let's move to our next scientific session. I request Dr. Saurabh Phadke sir and co-chairperson Dr. Pramila Oswal ma'am to please accompany our guest speaker to dais, Dr. Neeta Nair ma'am. I request Chairperson Dr. Saurabh Phadke sir and Dr. Pramila Oswal ma'am to please welcome our speaker by offering a bouquet on behalf of RMA Raicon 2526. Before we move to the session, we will now have lucky draw sponsored by MOC Cancer Care and Research Center, Vashi and Panvel. I request our guest speaker to do the honor and take out one lucky winner from the box. Dr. Amruta Patil is here. Dr. Sunil Dhawle. Dr. Sunil Dhawle. Dr. Mukesh Oswal. Dr. Mukesh Singh. No. Thank you, ma'am. We now move on to our scientific session by Dr. Neeta Nair, ma'am. Dr. Neeta Nair, ma'am, is lead consultant in breast surgery at Apollo Cancer Center, Navi Mumbai. Over 20 plus year experience, clinical experience in breast cancer management. Trained at Grand Medical College, Hinduja Hospital and Tata Memorial Hospital. Renowned for expertise in breast cancer surgery and oncoplastic breast surgery. Ma'am will be speaking on topic from early detection to treatment of breast cancer management, what's new. I request ma'am please start the lecture. Thank you.
Thank you very much. Thank you to the entire team of Raicon for this opportunity. We've had a lot of different talks from the morning today. Breast cancer is something you all hear about. Everybody knows the basics, everyone hears the basics very routinely. I want to take you through something slightly different for you to understand what's new in our treatment and how and why we've changed our treatments. Breast cancer continues to be the most common cancer among women in the world. Unfortunately, the difference for us in India is more women die of cancer in India because we detect them late. 40 to 50% of our women still present in advanced stages, and that's where we need all our physicians to come together to create awareness. We've always talked about traditional risk factors, non-modifiable like age, gender, family history, early menarche, late menopause. We've talked about non-modifiable or modifiable risk factors, which is intake of hormones, lifestyle. We keep saying obesity is a risk factor. We need to talk to our women about exercise. We've heard so much when we had our neurosurgeon talk about diet. Diet is an extremely important component even for cancer. But are we actually missing something in the current day? And I'm going to tell you that we've realized that sleep and chronic stress have become some of the most important factors for all cancers, including breast cancer, because it changes the way your immune response to any illness is. So it weakens our immune system, it causes a lot of hormone imbalance, and we need to teach our women to change the way they deal with their life, not just related to weight, but also related to the stress that we're all taking. And stress can be very simple and you don't realize it, but chronic stress, both physical and emotional, plays a role on the kind of diseases that we get. So the solutions we have are very simple. Choose to find some exercise, yoga, meditation, hobbies. Find something that helps you adapt to stress in your life. So when I was part of Tata Memorial Hospital, we did a landmark study, and this was the first done in the world, where we looked at the role of yoga on breast cancer women beyond just quality of life, and we tried to look at any impact on disease-free survival for these women. This was something that I was very proud to have run this study and published it later. And what we found was that yoga appeared to lower fatigue. You talk to any woman who's been through breast cancer, even after she recovers, she will always tell you, I used to be here when my energy level, even after treatment, I always came back here. They never go back to normal, and that is what is chronic cancer fatigue. And women need to be able to deal with that effectively. It changes the way we respond to emotional and physical stressors. It changes the way they have side effects. It reduces the appetite loss, and they have less symptoms which are physical. So we've started inculcating, and in my practice now, all women inculcate a small amount of yoga into their daily routine, and we encourage this even for women who are just healthy individuals. Do some sort of meditation or yoga to reduce the kind of stress you face every day. Something else that we always talk about as a risk factor is family history. So when we talk of family history, most of us think of the BRCA gene. You say BRCA1, BRCA2, if your patient has this genetic mutation, they have higher risk. Why we say that is, if you look at the routine population, you have about a 39% risk related to, or let's say you have a routine population, 1 in 22 women in urban India have a lifetime risk of developing cancer. That's higher than what we'd expect, but it's not as high as the West, which is 1 in 8 women. The difference is when your patient is BRCA positive, that risk jumps to 60 to 80%. And if she carries BRCA2, it even has a very high risk of ovarian cancer. How we have changed the way we look at mutations is now we don't just test for BRCA1 and 2. We test for almost about 22 different penetrant genes, and we look at high, intermediate as well as low penetrance, and we offer options to these women based on that. Someone who has an intermediate or low penetrance, we can talk to them just about surveillance, chemo prevention. Surveillance would mean they do mammograms and MRIs every 6 months. Chemo prevention would be you put them on tamoxifen or raloxifene. These are healthy carriers. These are women who carry the gene, do not have cancer, and they can be put on surveillance or chemo prevention. High penetrance genes like BRCA1 and 2, even PALB2, though it's an intermediate penetrance gene, is offered prophylactic surgery because of how high the risk is of developing cancer. And that would be both breast as well as ovarian prophylactic surgery. So we've traditionally talked about whom do we test for all these signs and symptoms. So we look at testing for hereditary breast cancers, any woman who presents under the age of 40, so young women with breast cancer. Used to be triple negative, less than 50. Women with family history, women who've had ovarian cancer, any male breast cancer in the family you must test, and any male who presents with breast cancer must be tested. What's changed for us is now for triple negative, irrespective of age, we test for mutations, because we're looking at multiple penetrant genes, and we've also found a higher incidence across older women with triple negative breast cancer. So all of that vaccine against breast cancer, like cervical. So what we do is early detection. Early detection comes from screening. Screening, what we understand, is mammography. Do a mammogram once a year from the age of 40 to 74. That is screening. Screening can also mean clinical breast examination. Screening is also actually self-breast examination. So self-breast examination didn't stand the test of the studies. So when you look at statistically, it was not beneficial. But what it definitely helps us do with women is make them more aware. So we encourage self-breast examination as a process that we want our women to be aware of what changes they see in their breast. Every woman who comes to you over the age of 40, you must talk to them with whatever their illness is. They come for fever, they come for a cold, a cough. Talk to them about cervical and breast health. And self-breast examination is part of that breast health, and they deserve that much from you. Often I tell most of our physicians, put up a poster in your clinic, especially for the women who are physicians in the room. Talk to the women that you have coming in for various illnesses. Create more awareness, and that's what's going to help us change the way our women present with breast cancer and let them come in earlier. We also have data from large studies which talked about clinical breast examination. So clinical breast examination is where a clinician who's well trained, or the study also looked at healthcare workers who were 12th pass but well trained by physicians, doing clinical breast examination on an annual basis. What this does is it allows us to pick up smaller lesions, because most women, even if you talk to them about self-breast examination, may not understand what they're looking for. So if they have an annual examination by y'all, you will pick up a change or something different. And of course, the benefit has always been seen in slightly older women. Mammography continues to be the standard of care for screening. It has a 30% reduction in mortality or risk of death from breast cancer in women over 50, though it does come with a little bit of overdiagnosis. And what do I mean by overdiagnosis is you'll pick up small lesions that, like a low-grade DCIS, which is pre-invasive, picks up a lot of noise which we cannot find a radiological correlate for. So if I have a scan that comes up with a hotspot on thermoscan, but I have no radiological correlate on mammo, ultrasound or MRI, I suddenly have told a patient, you have something. I don't know what that something is. See it. You have created anxiety in a normal, healthy individual with an imaging technique that has not been validated for screening. So I would tell you that use these with very extreme caution in your practice, and the only standard of care for screening continues to be a mammogram, and we recommend annual mammograms between the age of 40 to 74, or an annual clinical breast examination and monthly self-breast examinations for routine women to continue to do to awareness. Our women are going to still develop cancers and come to you with lumps in the breast or symptoms or findings of cancer. How we treat breast cancer starts with a triple test for diagnosis. Age appropriate and a biopsy which proves the cancer. We used to earlier treat breast cancer by early and advanced stage. We used to say early cancers, operate first, give the chemo later. Locally advanced cancers, because they are very large, all over the place, we are unable to operate them easily. We give neoadjuvant, downsize the tumor, then offer surgery, radiation, targeted therapy. Our process of thinking has changed. So it's not just stage and the woman's age. Bound to chemotherapy, we understand prognosis. Is this a good tumor or a poor prognostic tumor? And for a triple negative or a HER2 positive poor prognostic tumor, we will add more chemotherapy or change the targeted therapy after, improve the disease. With all of this, our biggest less treatments with better quality of life and excellent survival outcomes. So because I'm a surgeon, you're going to see a lot more surgical with my talk, but we've seen a paradigm shift in the change of breast cancer surgery. We no longer offer radical mastectomies to standard care. Modified radical mastectomy continues to be a choice, but our entire effort is to offer our women breast conserving surgery wherever feasible. Breast conserving surgery is extremely safe. It just requires radiation in almost all patients, but is an extremely safe option which we have from numerous long-term data sets. The only problem we have is that in India, only 42% of our patients receive this procedure. Part of it comes from the surgeon's training or expertise. Part of it comes from a patient's fear. And I think as a community of healthcare, we need to work together to let our patients understand breast conservation is safe to do. We also now, because we continue to see large tumors, do breast conserving surgeries post chemotherapy. So you'll have women with large tumors. We place a clip in the center of the tumor. Post chemotherapy, when it responds, we are able to identify the clip and operate smaller areas, offer better conservation. Conservation doesn't just come with saving the breast. It's not that you saved it, recreated a flat mound there. Conservation comes from good cosmesis, and that you will only find with specialized work. The difference why we tell you that Apollo Hospital stands out for us is each of us as surgeons practices one subsite. We are all surgical oncologists, we are trained surgical oncologists, but we each practice one subsite and bring that excellence to our patients. Breast conserving surgeries can be done well with scars on the tumor. For younger women like this 30-year-old, we hide the scar, like here we've kept it around the areola, and she's not going to follow that her life with a scar that is visible to her, and she's not going to remember that for the rest of her life. We also do a lot of perforator flaps now to recreate the breast, absolutely safe to do, excellent cosmesis. With women with very large breasts or large tumors, we try and reduce the size of the breast to give them better cosmesis. We even do reconstructions with the latissimus dorsi flap. We can recreate the whole breast in many of these women. This is a young 29-year-old that I had operated when I just joined Apollo. She had a large 12 centimeter malignant phylloids in the lateral aspect of the breast. This lady got married 6 months ago and is doing very well. She had a large tumor that would have otherwise meant a mastectomy, and she actually came to me because someone had offered her a mastectomy for that 12 centimeter mass. We wide excised it and recreated her breast using that LD that she has. Traditionally, whenever we have to do a mastectomy, because in some cases there's going to be more than one tumor in the area, there's going to be multiple lesions or microcalcification in the breast, and we still have to do a mastectomy, we try and offer reconstruction. And we used to try and offer reconstruction more often with an autologous flap, which is the patient's own body tissue, but we do use an implant sometimes when they don't have adequate tissue. Whenever we did an implant earlier, we had to cover it with something, and all we had was the LD flap from the back. So this is one of my older patients. She's a 31-year-old, had extensive DCIS. We've reconstructed her breast using an implant, and we've covered that breast using an LD. So this is what she looks like on follow-up. She still comes, she comes from UP for follow-up. We've moved towards doing what is breast reconstruction and mastectomies using robotic surgery. And the difference I'll show you is if you see this young girl, you can still see all the scars on the breast. So she still lives with that scar. She's 34 right now. She still lives with that scar on her breast. This lady, you cannot see the scar anymore. And that's the benefit of robotic breast surgery for us. The scar size is about 4 centimeters. It's placed off the breast, and we're able to offer this now. We've done our 4th case at Apollo last month, and we've started moving towards offering this for a lot of prophylactic breast surgery for BRCA positive patients and some women with early breast cancers. Here now the advantage also is we have access to something called an ADM or a mesh. These are artificial matrices that allow us to cover the implant, and we don't need to take the back fat or the muscle anymore, and we're able to do ADMs and tie loops with this. Reconstruction with the patient's body still continues to be our primary choice if they have adequate donor space, so we do try and work with that. Second part of breast surgery continues to be staging of the axilla. Traditionally, we always did a complete clearance, but our women did struggle with lymphedema. And that is very difficult once it sets in. You can try everything. Tell them that, do your exercises, make sure you don't get any infections on that hand. Once it sets in, it's extremely difficult for the patient and very cumbersome for them to handle. So sentinel node biopsy with blue dye or ICG continues to be our standard of care for a node negative population. We even do it now post neoadjuvant chemotherapy. Wherever we are offering a complete dissection, we try and do lymphovascular anastomosis so that we can supplement the lymphatic supply and reduce the risk of lymphedema. Some of the other modalities of therapy, and you've heard a lot of our medical oncologists in the morning also, but with radiation, again, we've de-escalated to reducing the dose. Earlier, we used to do 5 weeks. Now, standard is 3 weeks every day except Saturday, Sunday. We've moved down to once a week for 5 weeks. I have 2 slides left. We've also moved towards proton-based radiation therapy for very high-risk women with left-sided disease. Chemotherapy, you heard both Dr. Chirmade and Dr. Parker talk about how one size doesn't fit all, a lot of immuno-oncology, but we now de-escalate in ER/PR positive women with the use of molecular profiling like Oncotype DX. Scalp cooling allows us to reduce the kind of morbidity our patients have. Hormone and targeted therapy, we have a lot more options in terms of drugs available to offer. Immunotherapy in breast cancer is a big move forward, especially in triple negative breast cancers. So the approach today in 2026, therapy rather than just stage based and focusing on reduction in mortality without a reduction in survival. What we can offer to all our women is to stay healthy and fit, add exercise, add something that allows you to reduce your stress so as to be able to reduce your risk of. I bring you greetings from Apollo Hospital and our entire oncology team. Thank you.
Thank you so much, ma'am, for such a wonderful and engaging session. Ma'am comprehensively covered all clinical aspect and psychological aspect regarding breast cancer management. Now I request Chairperson Dr. Saurabh Padke sir and Co-Chairperson Dr. Pramila Oswal ma'am to please felicitate our guest speaker on behalf of Raicon 2526. Now I request our guest speaker to please felicitate our chairpersons. Time for our next lucky draw sponsored by Dr. Pushpak Chirmade Cancer Care, Vashi, Thane and Panvel. I request our guest speaker to do the honor. Congratulations, sir.
Now I request Dr. Dhake sir and Dr. Fadke sir to please welcome Dr. Khwaja sir, Dr. Kayaskar sir, Dr. Kasturi ma'am, Dr. Rahul sir, Dr. Saurabh Ghosh, love on behalf of Raicon 2026. Thank you, sir. Now it is time for the lucky draw. I will request the dignitaries to please pick up a lucky draw coupon which is sponsored by Mumbai Oncology Center. Thank you, sir. Now a brief introduction of our guest speakers. Dr. Khwaja Raziuddin, sir. He is MD DM Oncology, Specialty Medical and Radiation Oncologist. Sir is postgraduate from prestigious Tata Memorial Hospital, completed his DM from medical oncology from MS Ramaya Medical College. He is highly skilled cancer specialist in dual training in radiation and medical oncology, a rare combination that offers him a truly integrated cancer care. His expertise are spanning chemotherapy, immunotherapy, targeted therapy and bone marrow transplantation. He is experienced in managing cancer in all age groups, including pediatric hematology, malignancies, solid tumors. Sir has strong academic foundation with public research in radiotherapy and immunotherapy outcomes, practicing in Vashi and Panvel. Thank you, sir. And second speaker? Yes. Our second guest speaker is Dr. Pritam Kayaskar, sir. He is MD Internal Medicine, DM Medical and Pediatric Hemato-Oncology. Sir is trained at Gujarat Cancer Research Institute, Ahmedabad. He is gold medalist in DM Medical Oncology. His expertise is in solid tumors and hematological cancers with experience in bone marrow transplants. A short introduction of our panelist, Dr. Kasturi Barua ma'am. She is a medical oncologist. Dr. Saurabh Phadke sir, he is a surgical oncologist. Dr. Rahul Chavan sir, he is also a surgical oncologist. Dr. Saurabh Goswami sir, he is a radiation oncologist. Now I request our guest speaker to please enlighten us with their lecture. Thank you, sir.
Good afternoon, everyone. I am Dr. Raziuddin Khwaja, Medical Oncology, practicing at Mumbai Oncocare, Panvel and Vashi. From morning we have heard about oncology regarding immunotherapy, various types of advanced surgeries, various types of latest targeted therapies. But we do tend to forget there is cost and financial toxicity associated with the treatment. Oncologist once and after the surgery, most of the treatment is being done by medical oncologist at the time of adjuvant or the metastatic setting. So medical oncologist on day-to-day life basis, for the same patient, we have to see them again and again for the same issue, that is the cost. So my topic is cost in cancer treatment. Is there a way out for the needy? We practice both, as you might be knowing, we practice immunotherapy, latest antibody drug conjugate therapies, latest oral targeted therapies, but so few patients are such that they are not able to afford even the basic chemotherapy. So at Mumbai Oncocare Panvel, we have facilities for them too. So why cost effectiveness matters in oncocare? Tumor, you should know that tumor isn't the only thing growing uncontrollably. It is also the cost for the treatment associated with the tumor which is growing uncontrollably. 60-70% cancer care in India is out of pocket. Financial toxicity leads to treatment abandonment, dose compromise and poor outcomes. So what is cost effectiveness? It is measured as cost per life year gained or cost per quality of life adjusted life year. Basically WHO has some thresholds for it. Cost effective is if it is 1 to 3 times GDP per capita, and highly cost effective is if it is treatment is less than 1 times the GDP per capita, and non-cost effective is if it is more than 3 times the GDP per capita. So where does this cost come from? The breakup, mostly it is in oncology, it is basically with the drugs 40 to 60%. Rest are the investigations, imaging. Investigations can be the latest PET scans, hospitalization and ICU care, supportive care, logistics and indirect costs also, which we tend to forget, the travel and wage loss, because patient loses the job for as also the attender who is who travels with the patient. What can be done to make treatment feasible? So we at MOC are regularly creating community awareness and running successful screening programs so that we can get an early diagnosis and we can help the patients to limit the treatment. Also the daycare basis treatment in terms of chemotherapy. The patient gets admitted on the same day and gets discharged by the same day, and that is what it is being practiced at all of the centers of Mumbai Oncocare. Also, we try to avoid prolonged hospital stays, ICU stays by giving optimal treatment, optimal dosages for chemotherapy and immunotherapy, also use of biosimilars and if possible generics. So if you see, if a person comes, this cartoon is self-explanatory. If he sees a private hospital, then he fears whether he can step inside. But at Mumbai Oncocare Center, which is at one of the branch at Panvel, we have some of the facilities for which treatment is possible to such category of patients as well. So, so we have simplified the journey for all the cancer patients. We have all the kind of help which we can give to them in terms of cancer care. Like most of the almost all the cashless facilities are available. Almost all the corporate health schemes are available. But the addition of MGPGY and PMGY Yojana is also available at the Panvel Center. So one of the example I wanted to share with you, we got a patient, 50-year-old female. She had no known comorbidities and no family history of breast cancer. She had underwent modified radical mastectomy in July 2022 at some hospital, and her stage was stage 3. Then followed by her also, if you can see that she had a HER2 positive disease, but unfortunately because of the cost associated with the Herceptin, she couldn't receive at that period of time, and she had received adjuvant chemotherapy as per protocol at some elsewhere hospital in Mumbai, followed by the radiation to the chest wall. But unfortunately, patient presented with in July 2025 this year with multiple episodes of vomiting, severe pain in abdomen, icterus, itching, hepatomegaly, body ache, with liver functions deranged, completely deranged, and transaminitis and direct bilirubin of around 3. So and she has done a PET scan. PET scan was suggestive of a 14 centimeter huge mass in the liver and multiple mets in liver, vertebra, and other lymph nodes in the mediastinum as well as the abdomen. So you can appreciate the amount of burden of disease in this case. So what we did, patient didn't have the money to even do the biopsy, and patient wanted and she had not much of the time to to delay the treatment. So patient was started on targeted therapy, basically Herceptin with paclitaxel at low doses, and she received around 12 cycles of weekly chemotherapy. So and then you can see the scan. She achieved near complete metabolic response by simple Herceptin, which is trastuzumab, and lower dose of weekly paclitaxel. So in this case, the government cashless insurance scheme helped this patient recover. And so that was the goodwill we got from the patient. And patients' attendants were relatives were very happy with the services which we provided. Also, you should see. You can see this. We are running preventive oncology services, screening for cervix, breast cancer, and other services like for PSA and oral examinations, so that we can detect the cancer as early as possible and help the community to get treated. So takeaways, cancer care, yes, can be affordable. Cost reduction is not equal to compromise. Rational oncology, evidence-based is ethical oncology, and also there is a way out for the needy. Thank you.
Hello. I request Dr. Pritam Karaskar sir to please enlighten us with their lecture.
Hi, good evening all, and with permission of my panelist and the chairperson, I'd like to start the presentation. Slightly different topic. All of us understand and see a lot of cancer patients and their journey. So there are three aspects to it which I am going to discuss. One is euthanasia, and the last part is there is also a lot of misunderstanding in terms of when cancer happens, is it the end of the road, and do those patients actually live a better life or not. So these are few things which my panelist will enlighten me with few questions. Three topics. So I'll come to my panelist. What is euthanasia? If you can, any of you can just pick up the mic and enlighten us.
Hello, hello, Dr. Pritam. Dr. Saurabh here. So basically, euthanasia means mercy killing. In India, we generally don't have that active role in euthanasia. Basically, it is divided into subcategories like an active euthanasia and a passive euthanasia, in which active means where doctor and panel has to decide whether to give.
Yeah, we will come to that, Dr. Saurabh. We'll come to that. So we are basically discussing about mercy killing, right?
Yeah.
Very, I would say a difficult topic to discuss, but sometimes, unfortunately, the family is in a position where they cannot see the patient in pain. The patient himself cannot bear the sufferings, and there is no way out. This situation unfortunately happens to few patients of cancer where we are also not able to help them out other than painkillers. That is the time when the relatives comes to us and ask us, is there a possibility of giving a smooth passage? This is a very difficult but a common question asked by the relatives in a very difficult situation, and to this we have no answer. Legally there is no way we can do it. So that is the reason we are discussing. This is something which patients do ask, the relatives per se. I'll come to my panelists before going to the details of euthanasia. Now that we know what is mercy killing, you all of us must be experiencing this kind of scenarios. Unfortunately, I would like to one by one ask all five of you, what are your thoughts on euthanasia? We'll go to the legal part later, but as a doctor, what do you feel when you are in such situation? Yeah, we can begin one by one, yes.
I feel it is a difficult scenario with for the patient's relatives and the doctor when end of lines of treatment and end of therapy is there, and the patient is in ICU, and we have to decide for euthanasia. Basically, if we know that if there is no further lines of treatment available with the patient, and if we are just giving more pain and suffering, then just passive euthanasia can be discussed with the patient's relatives, and if they are willing, then you can proceed with their wishes.
So you agree on passive euthanasia? Got it. Rahul sir?
Yes, and a doctor, whether when we are not going to do anything fruitful for the patient, then there is a certain point where we have to decide. Now this is the time when either to sending patient home, either not offering the treatment. That is also a kind of that we are denying of from the lot of the patients are coming to Tata Hospital or to our hospitals, where we said that no, this is the line where we have to decide that treatment is important or taking patient home is important. So euthanasia is a kind of a term which is very difficult to understand from family to or as a doctor perspective. But I'll say in my personal, as an empathetically, I'll say yes, definitely at a certain point we have to decide with the consent of the family that we have to withdraw the treatment. That's a kind of an euthanasia which I understand in my practice.
Got it. So you also agree with passive euthanasia?
Yeah.
Yes.
There is one thing which Dr. Gavandev speaks in his book Being Mortal, and he has emphasized in Doctors on Death Row as a fantastic article in the New Yorker, is that once you let this cat out of the bag of active euthanasia, there is nothing which can put it back in. It creates fundamental changes in the psyche of the healthcare provider and the patient. That is one. Second is that patient autonomy. We should have extended dialogues, not with the family, but with the patient himself or herself. That is new to us in our cultures, but the patient himself or herself, and let them decide at till what point they want care. And I completely agree with all my colleagues here that withholding treatment, I won't term it as a euthanasia, but it will be mercy to a patient who is at the end of the road. But at the end, patient is king, and if the patient says, no, I want whatever is done, then that's it.
Got it, I think. So the message is, if the patient is aligned and is into the conversation since beginning, then it would be more easier and practical and more legal also, rather than at the end when the patient is on a ventilatory support, not understanding anything, and the relatives are taking a call. That is the scenario which all of us here follow, right? So maybe if at all it has to happen, your opinion is it has to start from the day one when it is diagnosed as a stage 4 with the palliative care, right? Perfect. I think that is very well placed. Dr. Kasturi, your opinion on this?
Sir, I also feel this is a very challenging question. But also I would like to highlight that oncology as a community, that we have seen a paradigm shift in what we can offer. So right now we can offer advanced palliative care. We do have options of oral metronomic chemotherapies. We have designated high-end radiological techniques as well. For example, ablation, stereotaxy. Yeah. So in the realm of all these advancements, to take a call on euthanasia is really difficult. As a physician as well as a family member also, as I'm also family member to many of my family members who are dealing with this. So since we don't have evidence also to back this up, I still am not very sure about how to say yes or no for euthanasia as of now.
So we have a panel of 5, 3 are in favor of passive euthanasia, 1 is in favor of regulating the whole process of counseling from day 1, and then if it is feasible, practical by legal aspect, then consider it, and Dr. Kasturi is still not convinced about euthanasia. So basically we are discussing euthanasia for patients who are all exhausted with all options. We are not, these patients are some patients which even as a medical oncologist I may not be able to help, right? You see patients with subacute intestinal obstruction where there is no remedy. You see them on 3 months just coming with a Ryle's tube and you can't help them. So I'll just narrate you a scenario which I faced around 6 years back. There was a lady, she was 56-year-old. 56-year-old, she was Sarpanch in some region of Palghar, and she was a 4th stage CORE in subacute obstruction. Admitted almost 3, 4, 5 times for 5, 6 days. This time her admission was for 1 month. She is not eating, right? Blood pressure and everything is fine. There is a Ryle tube and she is on TPN. She cannot move. So for 1 month she was admitted. Tired, exhausted. She had one daughter. They got her engagement done in the hospital within that 30 days. One night, her husband, he is like 58 around, he comes at 10:30 in the PM, just after I was finishing OPD and trying to go home. He comes to the OPD with a bag of few injections from somewhere, and he says, "Can you give this to my wife?" I said, "What is it?" She's already admitted, you don't need to give me some injections. Just, sir, if you can give it, it will really help her. She is there since 30 days and I cannot see this. And he was in tears. He kept something on my desk and I opened it. There were 10 injections of KCL. This is what I experienced. I said, "Boss, this is not possible. Please take it back." He says, "I cannot see her. I have been living with her for last 30 years, a happy married life, and seeing her in the hospital is very, very painful to me." This was an eye-opener for me, where I felt the pain is much beyond what the patient is going through, not only for the patient but the relatives and the whole family. So that is the context from where euthanasia is coming into discussion. We'll move to the next part. As our panelists discussed, there are two types of euthanasia. One is active and one is passive. Active is giving something, administering some lethal injection, which is illegal in the country at present. You cannot give anything to a patient to cause death to the patient. This is absolutely illegal. I'll just reiterate that. Next part is passive euthanasia. What is passive euthanasia? There is a patient in a vegetative state. He is not surviving. He is not coming out. Neither he is dying. You are legally, there is a legal option to stop treatment and let the life take its own course. That is passive euthanasia. You cannot administer anything. If the patient is on a ventilator support, you cannot remove the ventilator. You can just hold back. Is it that simple to administer? No. Is it that simple to administer? If somebody asks, no, it's not there. And from where it has come, if any of our panelists can just brief. Rahul, so you were just discussing, from where has passive euthanasia come into picture? In 2011, there was a sister, all of us must be knowing, she was in KEM hospital and she suffered for many years, and from there in 2011 the first recognized passive euthanasia came into picture, and then there is a right to die with dignity, and there is a Supreme Court order in 2023. So this is about passive euthanasia. So anybody of the panel can guide me, if somebody wishes for passive euthanasia, some relative, what is the procedure? Can we just hold it, or is there a procedure required?
Yes, there is an official procedure required for, as a primary and secondary medical board, at least the doctors who are having more than 5 years experience and who are certified. So we need to obtain consent and we need to do all the official protocols.
Yes, so there is an official process to even withhold basic life support from a patient. It is just not a consent given by the relatives. There has to be a proper, if somebody questions you, we as a doctor later on, that whether you have taken the proper procedure, and if you have not done it, it is legally wrong. So there has to be a board in the hospital, then there is an outside board, and then there is an advocate, then there is an attorney who certifies it. This has to be done in 48 hours. So this process has to be followed for passive euthanasia, and that's it. A judicial magistrate is something which is required. So this is the actual process for passive euthanasia. Now I think let's move from the difficult topic. I have only 5 minutes left with me. Let us move to diet in cancer now. So we have done with euthanasia. I'll just conclude. Presently euthanasia stands for passive part only. There is no active euthanasia in the country, and for the passive euthanasia also there is a legal process. Let's move to the diet part. So all five of my panelists, your patients must be asking you, sugar खाओ कि नहीं, दूध पीऊँ कि नहीं, मटन खा सकता हूँ क्या, रेड मीट खाऊंगा तो कोलोन कैंसर होगा क्या, सैटरडे को बियर पी सकता हूँ क्या? Yes. So what are your suggestions one by one? Any specific recommendation you give to your patients for diet? Somebody who is on cancer treatment.
If patient is on cancer treatment, usually I don't tell them to change the diet, whatever they are having, but they should have that food at home cooked food basically.
Home cooked.
And the diet should be rich in protein. Also, should be like fruits if she is
Anything
having
specific
peeled.
you don't want to give?
We don't want to give red meat to avoid, and with like some citrus fruits because it can cause
Acidity. Okay. So gastritis, citrus food for gastritis, red meat you feel should be avoided. Rest, everything home cooked and good amount of fruits and vegetables.
Yes, which is peeled, basically skin peeled.
Skin peeled. That is because they are on chemotherapy. Yes. Rahul sir, your thoughts when somebody asks you, kya khao, kya nahi khao?
So, like patient from breast cancer, colorectal cancer, I usually avoid them to avoid high calorie food, especially sugar containing, those who can cause spike in the insulin level and promotes the insulin resistance, as insulin has a trophic effect on cancer cells. So, and obviously as a healthy food, I advise them high fiber diet and green leafy vegetables along with the fruits.
So you are saying you don't advise them high sugars?
Yes,
but can they drink tea with sugar?
Definitely they can drink.
So high calorie food is what you don't recommend them.
Yes.
So that there is no high spikes in insulin level. That is what you are saying.
Yes.
Perfect. Yes, Dr. Saurabh.
Yeah, lots of misconception are there regarding sugar, regarding dairy products. So patient itself coming with lot of ideas, getting those knowledge through online things are available nowadays. So they are coming up, sir, can we have milk? We read somewhere that milk is causing these kind of things, so we can avoid that, or sugars, or lot of different things which they come up with, the weirdest things. So that's what I explain them. It's not about the things which you are going through. Yeah, home cooked, simple food, you can have everything. From oncology perspective, I generally don't give any kind of an advice to stop these things. A normal meal, a normal home cooked balanced diet is good enough for them. So that's what we generally advise for all the patients.
Perfect. So normal diet is what you advise. Everything is okay. No specific recommendation. Perfect.
I don't think there is an answer which one size fits for all. We have to take a look at the patient's nutritional status per se and then decide. But as a general guideline, I would of course no alcohol, no tobacco, high protein, sufficient calories, fresh, home cooked.
Any suggestion on tobacco, alcohol? 30, 40, 60? No?
No alcohol.
No alcohol,
No
right?
alcohol.
So people come with ki nahi sir 2 आठवड्यात एकदा 60 चालेल. No alcohol, right? Perfect. So Dr. Kasturi.
Sir, I'll ask essentially for number one, detailed nutritional evaluation at the offset, then followed by guidelines, which I would suggest rather. So we should have optimal calorie intake for the patient with high protein, that is about 1 to 1.5 gram per kg, that we should suggest to the patient. And this protein should be basically more of plant-based, lean meat. And then I would suggest rather to avoid red meat. And if at all they wish to have it, it should be less than 500 grams a week, is what the guidelines recommend.
So I think there is a clear message from the panelists that everything prepared at home is good for all cancer patients. There are no specific do and don'ts unless it is in limited, like she said, if it is meat, 500 grams in a week is okay, right? And no amount of alcohol and tobacco is permitted for any of us. Leave it cancer patients, for any of us. So I'll just take 30 seconds to complete this part. Sugar feeds cancer, this is a myth. Yes, high amount of calories are not good because you put on weight. Weight causes lot of, I would say, estrogen production in breast cancer patients, that is obesity, so we don't recommend it. But sugar does not feed cancer, sugar feeds all cells, so some amount of sugar is okay. Alkaline diet and alkaline water. I'll just take 30 seconds, very sorry. Alkaline diet, alkaline water, you will see a lot of people telling Virat Kohli is drinking alkaline water, we should all drink it and become healthy as him. It is not practically possible for us to change the pH of our blood by drinking water. Even if I eat half kgs of salt, I cannot change my pH to alkaline. So this water is basically good for washing vegetables as utensils at your place if you have already brought the machine. If you have not brought the machine, so don't buy 100 rupees of alkaline bottles. They are of waste, they don't cause any benefit to anybody. Lastly, superfoods, keto diet. Last one liner, anybody recommends keto diet to your patients? So no specific recommendation for keto diet. That's it, I'll just finish here. I will not go to the last part. Journey on chemotherapy, I would say presently, On chemotherapy, I'll give an example. I'm treating a lady, she's 68-year-old. She is a past RBI manager, and she is a breast cancer patient since last 6 years, metastatic breast cancer. She is on oral therapy. She has 2 children in US, and both of them had kids 2 years back. She on therapy has visited US thrice in last 3 years. This is a kind of quality of life patients are experiencing on therapy. A metastatic breast cancer, 68-year-old, going to US thrice in last 3 years itself says that she has a good quality of life. So these are myths that once the cancer happens, it is end of the road. It is not like that. There are very good options available, and there are good panelists like we have who are treating them and giving them a good quality of life. Thank you very much. Thank you, Raicon, for giving us this opportunity, and very sorry I overshot by 2-3 minutes. Very sorry, already we are running late. Thank you all my panelists, thank you chairpersons, and thank you audience for patiently listening. Thank you very much.
Thank you our guest speakers and panelists for such a wonderful lecture and panel discussion. Now I request our chairperson, Dr. Dhake sir, to felicitate Dr. Khwaja sir and Dr. Karaskar sir on behalf of Raicon. And I request our chairperson, Dr. Phadke sir, to felicitate our panelists on behalf of Raicon. And I request our guest speakers to felicitate our chairperson as well. Dr. Khwaja sir and Dr. Karaskar sir, please. Thank you, sir. Now it's time for a lucky draw, which is sponsored by Hegde and Hegde. So I request to bring the bowl. Dr. Dinkar Patil. Is he present in the hall? Second, next slide. Huh? इनका अलग. Dr. Swapnali Deshmukh. Dr. Swapnali Deshmukh. She is also not present. Dr. Sheetal Bhagat. Dr. Sheetal Bhagat. उद्या त्यांचं वेगळं आहे. उद्या त्यांचं अजून एक काढून घे. हां नाही या वेगळं. डॉक्टर प्रदीप बाबरे उलण नहीं है. सो व्हाट वी डू स्टॉप करने का. Yes. Okay, thank you. Okay, thank you all, guest speakers, chairpersons. Thank you all for a wonderful lecture. Thank you.
थँक्यू सर. आजचं आपलं लास्ट लेक्चर आहे. सेकंड लास्ट, नंतर आपले चीफ गेस्ट यांचं लास्ट लेक्चर असेल. डॉक्टर पवन ओझा सर स्पीकर आहेत. टॉपिक आहे डेंजरस डिझिनेस. चेअरपर्सन डॉक्टर अभिजित भोसले, डॉक्टर भगवान कराळे यांना मी विनंती करतो की त्यांनी स्पीकरला स्टेजवर घेऊन यायचं आहे. डॉक्टर पवन ओझा. चेअरपर्सनना मी विनंती करतो की त्यांनी आजच्या स्पीकरचं स्वागत करायचं आहे बुके देऊन. डॉक्टर पवन ओझा, डिरेक्टर न्यूरोसायन्स मेडिकवर हॉस्पिटल नवी मुंबई, फेलोशिप इन स्ट्रोक युनिव्हर्सिटी ऑफ कॅल्गरी कॅनडा, असोसिएट प्रोफेसर ग्रांट मेडिकल कॉलेज मुंबई, प्रेसिडेंट मुंबई स्ट्रोक सोसायटी, EC मेंबर इंडियन स्ट्रोक सोसायटी, special interest in stroke, vertigo, headache, non-invasive brain stimulation, 25 plus publication in national and international journals, awards J.N. Tata International Scholarship, gold medal in DM Neurology. लेक्चर सुरू होण्याआधी आजचा फर्स्ट लकी ड्रॉ आहे MOC हॉस्पिटलतर्फे. Winner is Dr. Alka Chavan. Next. Dr. Suhas Shitut. Sir, please come on stage.
RMA would like to felicitate MMC observer Dr. Bhagwan Birmule sir. Sir is here. I request our president Dr. Ashutosh Kulkarni to please do the honors. Sir, dash. Sir is nominated as observer for the Raicon 2026. First pediatric surgeon in Raigad district. Sir,
I am thoroughly impressed with the figure of delegates which I went through. I had to literally spend 1.5 hours signing the papers. So all my lumbrical muscles have got strengthened, and 400 or 600 figure, it's beyond my imagination. So I congratulate the organizing committee, especially Karjat Medical Association, Ashutosh Kulkarni, and Gangola is my best friend, and for making this number to rise. I think next year also it will rise again. All the best. Thank you, sir. Thank you.
Good evening, everyone. I thank the organizers of Raicon. I think it is a very successful conference as I see here, because towards the end of the day, there are quite a few people who are still up and eager to listen. So we are not discussing any uncommon problem. This problem, either we have faced it sometime, or one of our friends or relatives have faced it sometimes, and we have been forced in that situation to help that person, whether it is as a part of a friendly advice, a consultation, or an emergency response. So the job here is to apprise you of such a situation as which one needs to be handled completely differently. Most of us, or even the pharmacist, has a prescription for anyone who has vertigo or dizziness, right? Roughly about 10% of us would have faced vertigo. If not 10, at least 5. So can I have a show of hands of who has never faced vertigo? So this is a wrong question. So I should have said who has faced vertigo, right? The idea is that at least in this hall, if there are 100 people, then at least 5 to 10 will raise their hands, right? The question is not that. The question is, amongst those people who have faced vertigo or who have never faced vertigo, are we prepared to handle a situation and know for sure that this is going to be a dangerous vertigo and not the simple one that we know of, right? So what are the thoughts? How do we understand? How do we prepare ourselves for that situation? This whole talk of about 25 to 30 minutes is to sensitize you on that topic, right? So there are basically 4 types of vertigo that the patients complain. Of course there are many others. Even for epilepsy also people will say chakkar aata hai, chakkar eto hai. But generally when they mean a real chakkar, then it is of 4 types. So first is the true vertigo, by which we mean that there is a sense of rotation. So you can also move the finger and tell them, is it like this? That is the one which we are discussing today. Then the second will be something like a fainting. So you can move your hand like this and say fainting. Then there will be a person who will say chakkar means imbalance. So you can say imbalance, like as if something in a boat, like that is an unsteadiness feeling. And then last one is something called as a kuch kuch hota hai, right? So we are not interested in all the 3 other types of vertigo. Today we want, if a patient presents with that chakkar which is rotational, can it fool us? Can it be not the normal chakkar? Can it be a dangerous giddiness? So having understood the question, then how do we divide these patients? So first is a patient जिसको चक्कर आता है और चला जाता है, फिर आता है चला जाता है. That is called recurrent. So that should be your first question, that इसके पहले कभी चक्कर आया क्या, right? Then this is called as a recurrent. Now this is unlikely to be the dangerous vertigo unless this आता है जाता है has lasted for more than 3 months. If this recurrent vertigo continues for more than 3 months, you are sure that this cannot be a vertebrobasilar insufficiency, because if the dog keeps on barking for 3 months but doesn't bite you, then I think you need not be scared of the dog, right? We all ignore them. Now there will be another situation where this is the first time that chakkar has come, right? and that is a bad chakkar. So we call it as a acute vertigo or a acute vestibular syndrome. Now, what is it like? What is the localization of this giddiness? So as we know that it can start from the inner ear and it can go up to the brain, right? This whole localization. So if only the ear is involved, maybe it is some inflammation, some infection, which is like a viral or something like that, or even ischemic. So that can be, peripheral episode, but severe one coming for the first time. So these are labyrinthitis, vestibular neuritis, or a Ramsay-Hunt syndrome. But there can also be a situation that the brainstem may be affected. Right? So that brainstem being affected is the real problem. And we should be able to identify that situation. Right? So, आधे इधर जाओ, आधे उधर जाओ. Right? आधे means recurrent and acute. So जो आधे इधर आ गए जिनको acute है, that we are interested in. उसमें भी आधा आधा करना है. So roughly about 25% of patients who present with acute vestibular syndrome after the age of 50, they are going to be having a vertebro-basilar insufficiency or a stroke. Right? And the problem is that in that situation within first few hours, the MRI is not as good as you. The MRI will pick up the stroke in 24 hours or later sometimes. But you will pick up the stroke earlier. I will tell you how. Right? So we know recurrent vertigo, it can be associated with hearing loss or it may not be associated with hearing loss. So our job becomes very easy. बार बार चक्कर आता है, सीटी की आवाज़ आती, सुनाई भी नहीं देता. Right? So automatically we think that this is ENT. Right? But the situation may not be so. So if you see something in red, then that can be a transient ischemic attack, which is called as a artery, anterior inferior cerebellar artery. So remember that when there is a recurrent vertigo with ऐकाला येत नाही, ऐका artery involved आहे. Right? Do you get the mnemonic? ऐकाला येत नाही, TIA, ऐका artery. And when ऐकाला येते, it is pica artery. Simple. Life becomes so simple, neurology is very so simple. Patients only will tell you, ऐकाला येत नाही म्हणजे ऐका artery is involved. Then, all of us are good history takers. You should not spend more than 2 minutes in taking history in these patients. So what all we need to know? We need to know how it started. It is like a rain. See, vertigo is like a rain. Either you get wet or you enjoy it. Right? If the vertigo is very severe, it is like tsunami. These patients can't stand, these patients can't walk, they have to be brought to the hospital. That is bad. So there are only two types of tsunamis that happen. One is called as a vestibular neuronitis. That means it is viral or it will be a stroke. You need to define that. If you are ever in doubt, refer the patient to a large hospital, they will decide. But let us not miss a chance, someone who is 50 years of age or over saying that this is viral, I am very confident. That becomes a problem. So here is a bit of anatomy. Look at that anatomy. So in the inner ear, you have this cochlea which is for hearing, and you have these semicircular canals on each side which are for balancing. In the side of the semicircular canal, there will be something called as a utricle and saccule. Now, these are two vatis. One vati is like this, another vati is like this, right? This vati is full of jelly. So remember the jelly custard, and on the top of that you have some dry fruits sprinkled on them. So these are your otoconia. Now remember, if the jelly is not good because of whatever reason, these dry fruits will come off very easily and then they will go and get stuck in the canal where they were not supposed to be. So from the utricle they have gone into the canal. Now canal had only water, and when you moved your head, only water was moving, and it was gently touching the hair cells of the cupola and creating a signal. So both the side signals are being created. Your inner ear is like this, two wings of the aeroplane, and your aeroplane goes up and down like this. So suppose now suddenly this aeroplane ka wing becomes like this, then there is a problem, or it becomes like this. So either one side becomes hyperactive or it becomes hypoactive. So the brain senses that, and while trying to correct that, now remember that a smart pilot is sitting inside. It will try to make a corrective circuit to make some adjustment. That is seen in the eyes as nystagmus. So when I am testing a patient of the ear with vertigo, actually I am not looking inside the ear. That is, the patient is also surprised that why you are looking in the eyes. Problem is somewhere else. So the eyes are the windows of the brain. So we will, all the forward test, we will be doing a video oculography to get a clue of which side wing is down, how the correction is happening, and based on the study of nystagmus, we can make out whether it is a central vertigo or peripheral vertigo. Now you all tell me, don't make it so complex. We are not used to all these things. So I will simplify things for you very much. I am going to skip some slides. So another thing is, when you have a recurrent vertigo, then you ask that what triggers it. Suppose, somebody says that, मैं सर झुकाता हूँ तो चक्कर आता है, सर उठाता हूँ तो चक्कर आता है. So there was a patient who told that, मंदिर में जाता हूँ, प्रणाम करता हूँ तो चक्कर आता है, उठ के घंटी बजाता हूँ तो चक्कर आता है. Very simple. It is a posterior canal which is aligned in the vertical direction, right? So you know that ऐसे ऐसे दोनों में चक्कर आ रहा है, मतलब posterior canal का है. Now there is another 85 years old male who says that सिर्फ नमाज पढ़ने के टाइम में चक्कर आता है, but उठने के टाइम में चक्कर नहीं आता है, right? Now is this also vertigo? Is this also positional vertigo? So you say that maybe it is positional vertigo, maybe not. So what happened is that this person had a acoustic nerve schwannoma. When he was bending the head forward, the acoustic nerve with that ball was being stretched, and the ball cannot rise up against the gravity. So when he was getting up, then the ball was not getting stretched. So the only vertigo came when he went down, not when he went up. So simple diagnosis. Then he said that इस कान से सुनाई भी नहीं देता है, right? 80 years old में सुनाई नहीं देता, but एक कान से सुनाई नहीं देता है, ENT वाले ना normal है. So we know that first case was benign positional vertigo, second case is not benign positional vertigo. So there will be a lot of these tests which we will skip. Few tests we will talk. So you look at the eyes of the patient. If you feel that the patient is having vertigo and the eyes are moving only in one direction, see, you look at the hand, show the hand, you say right में देखो, left में देखो. The eye is moving only in the right side, whether he is looking to the left side or whether it is looking to the right side. मतलब क्या हो रहा है, ये एरोप्लेन का विंग नीचे गया है, ऐसे जाता है, पायलट सीधा करता है, ऐसे जाता है, पायलट सीधा करता है. पायलट का प्रॉब्लम नहीं है, विंग का प्रॉब्लम है, राइट? यूनिडायरेक्शनल nystagmus is not usually because of the brain. Brain is intact, brain is trying to correct. Understood everyone? So brain, when there is a problem, the problem is of gaze holding. मतलब मैं देखना चाहता हूँ इधर लेकिन स्लिप हो जा रहा है. So it is usually a bidirectional, direction changing, bidirectional. So you see, इधर देखता है तो ऐसे आता है nystagmus, इधर देखता है तो ऐसे आता है. So bidirectional nystagmus is one sign. Another sign is when you see that इधर देखो तो भी डाउन बीटिंग nystagmus आ रहा है, उधर देखो तो भी डाउन बीटिंग nystagmus आ रहा है. So देखना चाहता है इधर और nystagmus अलग डायरेक्शन में आ रहा है. That is, so two clues for you: direction changing nystagmus and down beating nystagmus in an acute situation, not regular, right? Now one more test is there. I will give you a demo. So let's say that somebody has a vertigo. You want to make a right? If he is deviating, remember what is happening to the aeroplane. You give him a second trial, you tell him tum udhar chale gaye, you will see that he starts correcting to the other side because brain is calculating, मैं ज़्यादा इधर चला गया. So if you see first time में patient एक तरफ चला गया and in the second attempt the patient does better job or corrects to the other side, then that is a peripheral problem. Brain is fine. You can congratulate the patient. आपका brain अच्छा है, tension मत लो. Right? So there are some tests which we call as a head impulse test. So what happens when you see a patient who is having a one-sided nystagmus, nothing on the other side, you want to check whether the brain is functioning properly or not. So one we gave him two steps. The other time we said that we hold the head of the patient, show one finger and jerk the head. So ideally the eye should be centered, whether you jerk here or there, eye should be centered in the center. But what happens, on one side the eyes will be right there and on one side the eyes will come later. You will see that it came later. That is called as a head impulse test positive. This is the most important test. You can call it HIT, H-I-T. Today's most important point is head impulse test. You go home, you test it on your partner. Head impulse test. If you can't, you please Google it, you YouTube it, but you learn about this test. Okay. So this is checking gaze. इधर मेरी तरफ देखो. See that? This is the way you test it. मेरे नाक की तरफ देखो. And then one side will be jerky and other side will be bang in the center. Right. So there are a lot of these canals. When you ask the patient a history that जब सोता हूँ तो चक्कर आता है, उठता हूँ तो चक्कर आता है, that is posterior canal. There will be a patient who will say, when I turn to one side in the bed or the other side, then I get giddiness. That is lateral canal, that is horizontal canal. Only in these two situations you will be comfortable saying that this is BPPV, benign positional paroxysmal vertigo. Right? Only two times. One is when lying down he gets giddiness and sitting up it gets giddiness without doing any imaging, or turning in bed this side also chakkar, this side also chakkar. If the chakkar comes only on one side, only on one attempt, you are not comfortable unless you can correct it. So there will be a lot of all these things where we can say that this is a atypical positional vertigo. There are a lot of these investigations we keep on doing. Most of them we are using to study the eye movements so that we can guess what is the condition of the eyes or the brain. Now one test is called as a ENG. So this is a electronystagmogram. We put water inside the ear, hot, cold, and check the condition of the vestibular nerves. Then this is a balancing board. We can check the Romberg's test and all those things. Some patients, they don't have vertigo, they have only imbalance. Right? Then this lady is doing a Fukuda test. And this is a positional test that we do, positional test. I think I need to get these slides to full. So we do the positions and we test the patient and check which canal is affected. Right. So based on that, then positional vertigo we have discussed. But sometimes you can have a positional vertigo because of a tumor in the brain. It is touching the vestibular nerve. And you can have a positional, as we discussed that old man. And we don't want to see Apley's maneuver. You can please see how to correct it. First we will see how to diagnose it. Now sometimes what will happen, there is some patients of this relatively benign condition. You say benign position, naam mein hi benign hai. But some patients, they have very sudden movement of the otoconia inside the inner ear. And they are just walking suddenly or just bending to take something out of the fridge and suddenly fall off. Fall off means get injured. Recently saw one 45 years old lady who had a sudden fall and brief loss of consciousness. EG, MRI, everything is normal. People are saying that this is epilepsy. Actually, it is not epilepsy. Or VNG showed an atypical benign positional vertigo, and head-up tilt test showed autonomic dysfunction. So, sudden severe vertigo can precipitate autonomic dysfunction and syncope, right? And that is how they fall and they get injured. So, two problems together. Now, we need to separate central causes from peripheral causes. So, now we are going to talk about the central causes which are dangerous. We have discussed that in one situation the peripheral or the BPPV can be dangerous. Then suddenly if the otoconia move into the canal, then you can fall and get injured. But usually dangerous means that there is a central, and usually it is vascular. So vascular means TIA or stroke. So if you have an isolated vertigo, let's say that we have been taught that whenever there is a posterior circulation stroke, you will have lot of these brainstem signs. You will have dysphagia, dysarthria, imbalance, diplopia. But trust me, at least in 1/4 of the patients, you will not have anything else. You will have only vertigo. This person comes in, mala chakkar yete. And this person is able to walk also. And many of them get treated with beta histine. Many of them they get treated for positional vertigo and don't do well. In fact, they deteriorate over next 24 hours. So you can have this. So you please take picture of this. This is one more important slide. So to differentiate in the emergency room, let's say that in your clinic a patient comes and tells me that I am having vertigo and you want to know whether इसको घर भेजना है कि emergency room में भेजना है. So this is a slide. So first is that if there is a nystagmus which is strictly unilateral, इधर देखिए उधर देखिए, nystagmus एक ही साइड में जा रहा है. One. Second is you feel that after this nystagmus the head impulse you do and the head impulse test is abnormal on one side, right? So unidirectional nystagmus, abnormal head impulse test and no skew. Skew मतलब क्या? टेढ़ा दिखता है, मतलब ये आंखों का अलाइनमेंट चेंज हो गया. पर्सन में सी डबल, पर्सन में नॉट सी डबल. बट हाउ टू टेस्ट दैट वर्टिकल मिसअलाइनमेंट? दैट इज अ ब्रेनस्टेम साइन. So you cover one eye, this eye will come down. When you cover this eye would have gone up behind the hand, so it will come down. So it will be looking like a इधर हाथ लगा है, इधर हाथ लगा है, आँख ऊपर नीचे जा रहा है. That's like a seesaw movement. So in peripheral vertigo, in your clinic, you will have only one combination where you can send the patient home. That is unidirectional nystagmus, head impulse test abnormal and no skew. Please remember this. All other 8 combinations patient goes to hospital. Fortunately, all other 8 combinations happen only 25% of the time. 75% of the times you will see only one pattern, and that is unidirectional nystagmus, head impulse test abnormal and no skew, right? And then there are multitude of patients where these arteries can be involved, and we are in the lack of time, then we are not going to discuss. But small stroke in the medulla, this side, that side, see the basilarity is not even seen here. That can give rise to an imbalance or vertigo. Similarly, a patient who came with a infarct in the posterior circulation also came with giddiness. He was given IV TPA by this RMO and he improved very nicely. See the big infarct in the cerebellum. So this is a patient who could have been easily sent कि अरे तो थक गया सो जाओ करके, right? Then this patient complains. This is very interesting patient. I'll take 2 minutes to apprise you of this patient. This patient is still there in the hospital. 50 years old male. He has got episodic vertigo. He says, while I am walking, suddenly I feel very giddy. This has been happening for last 5 months now. And there is a one episode of fall and amnesia. He says, कान full लगते हैं एकदम. No cerebellar signs, only mild gaze evoked nystagmus. Head impulse test is negative. And no skew is there. So, this combination you remember? unilateral nystagmus, but head impulse test is negative. So this is a central vertigo. And mild downbeat nystagmus on. See, remember, see what you see here is a very large arachnoid cyst, which is almost compressing the cerebellum, and no cerebellar signs. So this can happen. Similarly, this 82 years old male, he has got a very tight vertebral artery stenosis. One side the vertebral is completely blocked and the other side the vertebral. So we stented him because there is a small brainstem infarct here. And he had nothing else, only vertigo. This is again one more 70 years old doctor who had only this tiny infarct and this vertebral artery is blocked from here. So sometimes these vertigos can be anterior also because of anterior circulation. And you can have this one prototype patient in your mind, this 82 years old male with one-sided hearing loss, one-sided vertigo, and vertigo used to coming only on bending down. So I'll stop here. Which patient to do imaging? The last, this box is very important. If you have neurological signs, like you look here, there, you find some neurological signs, thoda muh teda hai, thoda ataxia hai, or you have a older male or female more than 65, vascular risk factors, diabetes, hypertension, diabetes, all this, don't send them home. Okay? Or a progressive unilateral hearing. Now one more slide, you should take picture and put it in your clinic somewhere and ask them, if you can't stand like this girl, you are not going home. Right? A vertigo patient should still be able to stand. This is called as a standing algorithm. So we'll stop here, and I hope that you have a better balance like this, a bank balance also, but thank you.
थँक्यू सर. चेअरपर्सनना मी विनंती करतो की त्यांनी आजचे गेस्ट स्पीकर डॉक्टर पवन ओझा यांचं सत्कार करायचा आहे मोमेंटो देऊन. स्पीकरना विनंती आहे की त्यांनी चेअरपर्सन यांचा सत्कार करायचा आहे. या लेक्चरचा सेकंड लकी ड्रॉप PCC तर्फे आहे. डॉक्टर पुष्पक चिरमाडे, कॅन्सर केअर हॉस्पिटल. लकी ड्रॉप. डॉक्टर शीतल कराळे. डॉक्टर संजय 212. डॉक्टर संजय. डॉक्टर प्रतिभा मामुणकर, रजिस्ट्रेशन नंबर 550. अभिनंदन आणि मान्यवरांचे आभार. इनॉग्रेशनचा कार्यक्रम आपण थोड्याच वेळात चालू करत आहोत. 26th ॲन्युअल कॉन्फरन्सचा मोस्ट अवेटेड प्रोग्राम इनॉग्रेशन सेरेमनी थोड्याच वेळात चालू होत आहे. सर्व डेलिगेट्सना विनंती आहे की त्यांनी कॉन्फरन्स हॉलमध्ये यायचं आहे. आपण 5 मिनिटात इनॉग्रेशन प्रोग्राम सुरू करत आहोत. लॅपटॉप काढायचा आहे ना, लॅपटॉप कशाला पाहिजे आता.
ते पण काढू.
नमस्कार, एकत्र बोलूया. ओके.
नमस्कार, मी डॉक्टर शर्वाणी कुलकर्णी
आणि मी डॉक्टर कुणाल राठोड. रायगड मेडिकल असोसिएशनच्या रायकॉन 2026मध्ये आपल्या सर्वांचं हार्दिक हार्दिक स्वागत.
ओलिएंडर फार्म्सच्या या सुंदर वातावरणामध्ये RMAची 26वी कॉन्फरन्स पार पडते. 10 आणि 11 जानेवारी रोजी पार पडत असलेल्या या 2 दिवसीय चर्चासत्राची सुरुवात सकाळी आपण ज्ञानबुद्धीची देवता गणेशाच्या आशीर्वादाने करून सुरुवात केली आहे. आता आपण आपली वैद्यकाची देवता श्री धन्वंतरी यांचे पूजन करून आशीर्वाद घेऊया आणि दीपप्रज्वलन करून ज्ञानाच्या प्रकाशाकडे वाटचाल करूया. मी RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना विनंती करते की त्यांनी आपले आजचे प्रमुख पाहुणे माननीय श्री कुरुश दलाल यांना धन्वंतरी पूजनासाठी निमंत्रित करावे. यासोबतच मी RMA सेक्रेटरी डॉक्टर प्रशांत गांगल, RMA ट्रेजरर डॉक्टर कुमार ओसवाल, चीफ ऑर्गनायझिंग चेअरमन डॉक्टर गणेश साळुंके, एडिटर डॉक्टर दिलीप सावळे यांना विनंती करते की त्यांनीही श्री धन्वंतरींचे आशीर्वाद घ्यावेत.
देवांचे डॉक्टर आणि डॉक्टरांचे देव अशा भगवान धन्वंतरीची कृपादृष्टी आपल्या सर्वांवर सदैव राहो ही प्रार्थना करून आपण पुढील कार्यक्रम थोड्या वेळात सुरू करत आहोत.
शुभं करोति कल्याणम आरोग्यम धनसंपदा शत्रुबुद्धी विनाशाय दीपज्योती नमोस्तुते.
.
या ज्योतींच्या प्रकाशाने अज्ञानाचा अंधार दूर होऊ देत.
दीपज्योती नमोस्तुते, दिव्या दिव्या रे दीपत्कार, कानी कुंडल मोतीहार, दिव्याला पाहून नमस्कार, तिळाचे तेल कापसाची वात, दिवा तेवे देवा पाशी, उजेड पडे विष्णू पाशी, माझा नमस्कार सर्व देव देवतांपाशी. ये ग लक्ष्मी बैस ग बाजे, माझं घर तुला साजे, घरातली इडापिडा बाहेर जाऊ दे, बाहेरची लक्ष्मी घरात येऊ दे, घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती लाभू दे.
धन्यवाद सर. मी RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना विनंती करते की त्यांनी आपले आजचे पाहुणे डॉक्टर कुरुश दलाल यांना व्यासपीठावर येण्यासाठी निमंत्रित करावे. तसेच 20-25ची पदाधिकारी RMA सेक्रेटरी डॉक्टर प्रशांत, RMA ट्रेजरर डॉक्टर कुमार ओसवाल, चीफ ऑर्गनायझिंग चेअरमन डॉक्टर गणेश साळुंखे, ऑर्गनायझिंग चेअरमन डॉक्टर चव्हाण, ऑर्गनायझिंग चेअरमन डॉक्टर श्रीपाल जैन, ऑर्गनायझिंग चेअरमन डॉक्टर अमित ओसवाल, चीफ ऑर्गनायझिंग सेक्रेटरी डॉक्टर भावेश, ऑर्गनायझिंग सेक्रेटरी डॉक्टर महेश या सर्वांना स्थानापन्न होण्याची विनंती करते.
पास्ट प्रेसिडेंट RMA डॉक्टर निशिगंध आठवले येथे आलेले नाही आहेत. पास्ट RMA सेक्रेटरी डॉक्टर चांदोरकर यांना मी विनंती करतो की त्यांनी व्यासपीठावर यायचं आहे.
आपल्या आजच्या कार्यक्रमाचे सन्माननीय पाहुणे म्हणून आमदारांचं आगमन होत आहे. आपण 1-2 मिनिटं त्यांच्यासाठी वाट बघूया.
रायकॉन 2026च्या उद्घाटन समारंभाचे अध्यक्षपद स्वीकारण्याची विनंती मी RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना करतो. अध्यक्षपद स्वीकारावे. धन्यवाद.
चरकसूत्रस्थानात एक श्लोक आहे. शास्त्रम ज्योती प्रकाशार्थम दर्शनम बुद्धिरात्मना ताभ्याम भीषक सुयुक्तायाम चिकित्सन नापराध्यती. अर्थात शास्त्राचं ज्ञान हे प्रकाशासारखं आहे आणि ते ज्ञान आणि विवेकबुद्धी या दोघांचा समन्वय असला तर चिकित्सा करणारा कधीच चूक करत नाही.
Yes, doctors are lifelong students as medicine demands continuous learning, adaptation and skill development. आणि हीच ज्ञानाची तहान भागवण्यात रायकॉनचा सिंहाचा वाटा आहे.
ग्रंथ, टेक्स्टबुक्स यातनं मिळालेलं ज्ञान आपल्या आजचे सन्माननीय पाहुणे आमदार श्री महेंद्र थोरवे यांचं स्वागत आपण सगळ्यांनी करूया.
टाळ्यांच्या गजरात आमदार साहेबांचं स्वागत करायचं आहे.
वेळात वेळ काढून ते आपल्या डॉक्टरांच्या कार्यक्रमाला आजच्या चर्चासत्राला ते आले आहेत.
आमदार साहेबांना मी विनंती करतो की त्यांनी व्यासपीठावर स्थानापन्न व्हायचं आहे.
धन्यवाद. ग्रंथ, टेक्स्टबुक्स यातनं मिळालेलं ज्ञान, गुरूंचं मार्गदर्शन आणि आपला अनुभव या सगळ्यांचा उपयोग रुग्णाला बरं करण्यासाठी आपण करतो. यासाठी आपलं ज्ञान अद्ययावत करणं, उजाळा देणं आणि इतर समव्यावसायिकांचे अनुभव यांची देवाणघेवाण हाच मुख्य उद्देश घेऊन आपली ही 2 दिवसीय रायकॉन पार पडते आहे.
संपूर्ण रायगड जिल्ह्याचे प्रतिनिधित्व यावेळी कर्जत मेडिकल असोसिएशनकडे आहे. याचा आम्हा सर्व सभासदांना अतिशय अभिमान आहे. प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी आणि त्यांच्या संपूर्ण टीमच्या प्रयत्नांनी ही 26th ॲन्युअल कॉन्फरन्स मोठ्या दिमाखात सुरू आहे. रायकॉन 2026चे ऑर्गनायझिंग सेक्रेटरी डॉक्टर भावेश ओसवाल यांनी मान्यवरांचे स्वागत करावे अशी मी त्यांना विनंती करतो.
Respected Chief Guest, respected MLA Thorve Sahib, distinguished faculty, esteemed delegates, dear colleagues, ladies and gentlemen, a very good evening to one and all. It gives me immense pleasure and deep sense of pride to welcome you all to the annual medical conference of Raigad Medical Association. On behalf of organizing committee, I extend my warmest greetings and sincere thanks to each one of you for being a part of this academic gathering. We are truly honored to have with us today our esteemed chief guest and eminent speakers whose expertise and the experience will undoubtedly inspire us and guide us all. I also express my heartfelt gratitude to all the faculty members who have taken the time from their busy schedule to contribute to the scientific session. Organizing a conference of this scale is a collective effort. I would like to acknowledge the tireless work of the organizing committee, advisory members, volunteers, and the supporting staff, whose dedication and the teamwork have made this event possible. I also extend our sincere thanks to our sponsors and the partners for their valuable support. Once again, I warmly welcome you all and wish the conference a grand success. Thank you.
धन्यवाद डॉक्टर भावेश. यानंतर मी डॉक्टर RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना विनंती करते की आपले सन्माननीय प्रमुख पाहुणे माननीय आमदार श्री महेंद्र थोरवे यांचं पुष्पगुच्छ, शाल, श्रीफळ देऊन त्यांनी स्वागत करावं व त्यांना सन्मानित करावं. यानंतर मी पुन्हा एकदा RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना विनंती करते की त्यांनी आपले आजचे प्रमुख पाहुणे माननीय डॉक्टर श्री कुरुश दलाल यांचे पुष्पगुच्छ, शाल, श्रीफळ देऊन स्वागत करावे. व्यासपीठावर बसलेल्या सर्व पदाधिकाऱ्यांचं स्वागत करण्यासाठी मी डॉक्टर गणेश साळुंखे यांना निमंत्रित करते. पहिल्यांदा RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांचे स्वागत त्यांनी गुलाब पुष्प देऊन करावे. त्याचबरोबर डॉक्टर गणेश साळुंखे यांनी RMA सेक्रेटरी डॉक्टर प्रशांत गांगल यांचे गुलाब पुष्प देऊन स्वागत करावे. त्याचबरोबर RMA ट्रेजरर डॉक्टर कुमार ओसवाल यांचेही गुलाब पुष्प देऊन त्यांनी स्वागत करावे. RMAचे पास्ट सेक्रेटरी डॉक्टर चांदोरकर सर यांचेही डॉक्टर गणेश साळुंके यांनी गुलाब पुष्प देऊन स्वागत करावे.
धन्यवाद सर. चीफ ऑर्गनायझिंग सेक्रेटरी डॉक्टर भावेश ओसवाल यांना मी विनंती करतो की त्यांनी पुढील मान्यवरांचे स्वागत करावे. डॉक्टर गणेश साळुंके सर, चीफ ऑर्गनायझिंग चेअरमन. डॉक्टर श्रीपाल जैन, ऑर्गनायझिंग चेअरमन. डॉक्टर महेश शिरसाट, ऑर्गनायझिंग सेक्रेटरी. धन्यवाद सर. डॉक्टर महेश शिरसाट आणि डॉक्टर श्रीपाल जैन यांना मी विनंती करतो की त्यांनी पुढील मान्यवरांचे स्वागत करावे. RMA एडिटर डॉक्टर दिलीप सावळे सर. RMA एडिटर डॉक्टर दिलीप सावळे. तसेच रायगड मेडिकल असोसिएशनचे पास्ट प्रेसिडेंट डॉक्टर आदेश पाथरे यांचं देखील स्वागत गुलाबपुष्प देऊन करावं अशी मी विनंती करतो. डॉक्टर गंगोलिया सरांचं स्वागत करायचं आहे. डॉक्टर रमेश पटेल. डॉक्टर प्रमोद गांधी. डॉक्टर देवेंद्र जाधव. डॉक्टर राज कल्याणी. डॉक्टर तुषार गावंड. IMA प्रेसिडेंट डॉक्टर प्रेमचंद जैन. डॉक्टर रहाटविलकर. पास्ट RMA प्रेसिडेंट डॉक्टर रहाटविलकर. डॉक्टर विनायक पाटील. KMA प्रेसिडेंट डॉक्टर आशिष कर्वे. पास्ट ट्रेझरर डॉक्टर साबू. नीमा प्रेसिडेंट डॉक्टर डॉक्टर मिलिंद सोनावळे.
धन्यवाद. रायकॉन 2026चे चीफ ऑर्गनायझिंग चेअरमन डॉक्टर गणेश साळुंके यांनी प्रास्ताविक मांडावे अशी मी त्यांना विनंती करते.
Respected Chief Guest, Kurush Dalal Sir, Guest of Honor Shri Mahendra Thorve Sir, esteemed dignitaries of this dais, senior members of our association, my dear colleagues and friends, good evening and a very warm welcome to all of you. Myself Dr. Ganesh Salunke, Chief Organizing Chairman, Raicon 2026. Friends, it gives me immense pleasure and pride to stand before you today as the Chief Organizing Chairman of this annual conference of our Raigad Medical Association. Our gracious presence, your gracious presence has truly added value and dignity to this academic and professional gathering. Organizing a conference of this scale is never a one-man effort. It is a collective dream built with teamwork, dedication, and shared commitment to our profession. Today, as I look around this hall, I feel that every effort we put in our past months has been truly worthwhile. One of the biggest challenge in organizing any conference is source mobilization and fundraising. I am happy to say that we rose to this challenge with remarkable energy and unity. With transparency, sincerity, and persistent efforts, we are able to generate strong support from well-wishers, sponsors, and stakeholders. Many of them believe deeply in the ethical and academic mission of our medical fraternity. It is reflected the trust, goodwill, and respect our association commands in the district. It also demonstrated what we as doctors can achieve when we work together with a clear purpose and honest intent. I would like to place on record my heartfelt gratitude to all sponsors, patrons, contributors who extended their support generously. I also thank every member of the organizing committee who worked tirelessly, often behind the scene, to ensure the success of this conference. This conference is not a scientific event, it is a celebration of learning, friendship, and professional unity. Let us use this platform to exchange knowledge, strength, bond, and recommitment ourselves to ethical practice, compassionate patient care. I once again welcome you all, wish this conference grand success. May the deliberations over the next session be fruitful, inspiring, and memorable. Thank you, all of you, for your trust, support, and encouragement. Jai Hind, Jai Maharashtra.
धन्यवाद डॉक्टर गणेश. 1 एप्रिल 2025 मध्ये पदग्रहण समारंभानंतर हे सगळे उत्साही पदाधिकारी अनेक आघाड्यांवर एका ध्येयाने प्रेरित होऊन काम करतायत. आजची होणारी वार्षिक कॉन्फरन्स ही हिमनगाचा एक अष्टमांश वरचा तुकडा आहे, पण त्याच्या खाली जो हिमनगाचा भाग आहे त्या वेळामध्ये किती काम केलं आहे या सगळ्या कामाचा सेक्रेटरियल रिपोर्ट आपल्यासमोर सादर करण्यासाठी RMA सेक्रेटरी डॉक्टर प्रशांत गांगल यांना मी निमंत्रित करते.
Good evening, everybody. Respected dignitaries on the dais, respected past presidents, secretaries, EC members, office bearers, dear esteemed members, partners, and well-wishers. It is with great pleasure that I present this consolidated activity report for the year 2025 and 26. Over the past months, we have pursued our mission of professional growth, community services, and camaraderie across Raigad. The following pages capture the highlights of our endeavors from organizational meetings to educational activities, social awareness programs, health camps, and vibrant recreational activities. I hope this snapshot conveys the collective energy and dedication that define our beloved Raigad Medical Association. Starting with organizational meetings, following our installation ceremony held on April 13th at Karzat, we held our first EC meeting on June 15th. The second EC meeting was conducted on November 16th. In the interim, we have been consistently conducting cabinet meetings, Raicon organizing committee meetings, and taluka visits to ensure smooth progress of our activities. Coming to educational activities and zonal CMEs, in this tenure till now, we have successfully conducted 7 zonal CMEs, starting from Alibag on June 13th, then Pen on June 25th, then Panvel July 23rd, Uran September 12th, Srivardhan October 4th, Khopoli October 8th, and Mahad November 14th. We extend our heartfelt gratitude to our taluka associations and sponsors for their unwavering support in making these events a grand success. Apart from zonal CMEs, yesterday only we conducted an NRP and CPR workshop at this very venue. 40 doctors and nursing staff received training from a panel of experts from IAP. About social awareness programs and health checkup camps, Menstrual Hygiene Awareness Day was celebrated on May 28th with health checkup for women at Nasrapur village in Karzat Taluka. Tree plantation program was conducted on June 8th. We celebrated International Yoga Day by arranging an open to all yoga session at Karzat on 22nd. 2 health checkup camps were conducted for Warkari devotees. First one on June 22nd by Mahad and Pen Medical Associations, and another one on June 23rd by Karzat Medical Association in collaboration with RMA. Awareness programs for parents was held on June 27th at Karzat, targeting parents of school-going children. Blood donation and health checkup camp was organized on Doctor's Day, July 1st at Nerar. Another blood donation camp was conducted by Roha Taluka Medical Association in collaboration with RMA on July 13th at Dr. P.D. Bhoir's Hospital, Roha. Third blood donation camp and cancer detection camp was held at Karzat on Independence Day, August 15th. Another breast screening camp was successfully conducted at Srivardhan on October 7th. A health checkup camp for senior citizens was held in Karzat on December 30th. A total of 105 checkups were performed, and those needing further investigations were referred to Terna Hospital. We have been conducting regular weekly OPD every Tuesday at Humgao, a remote village in Karzat Taluka, since day 1, and we intend to continue this service in future also. Regarding recreational activities, we have had some exciting events throughout this year, starting from RMA Rainy Picnic and Medicinal Plants Excursion was carried out at Pali in association with Ayurved Vyaspith on August 3rd. We participated in Varsha Marathon at Posri, Karzat, organized in association with Light of Life Trust. Shri Dhanvantari Jayanti was celebrated in association with NIMA and Karzat Medical Association at Karzat on October 18th. RMA Lakshadweep Cruise Tour was conducted with record 110 members from October 27th to 31st, and it was truly an unforgettable and mesmerizing experience. We attended sports event hosted by Kharghar Doctors Association, and we enjoyed Navratri celebration arranged by DWAP. Now coming to RMA Sports, RMA Indoor Sports and WDPL was successfully conducted on 23rd November at Reliance Foundation School premises, Lodhivali. A record 8 women cricket teams participated this year and contested for Dr. Nishit Dhruv Memorial Trophy. One of the most awaited sports event, RMA DPL, took place on December 13th and 14th at Reliance Cricket Ground, Nagotne. A big thanks to our sports committee, our sports secretary and district sports admin committee for their tireless efforts. What a fabulous tournament it was. Congratulations to Team Mahad for winning the title. Moving on to the flagship event, Raicon 2026, a true jewel in the crown of RMA, and yes, it does come with a price tag. I can't thank enough to the tireless organizing team for their relentless efforts. We were blown away by the overwhelming support from across the Raigad district, which made it possible to host this conference at such a beautiful and serene venue. As we reflect on the activities conducted in this tenure, we are proud of the progress we made and the memories we have created. We look forward to continuing our efforts to serve the community and make a positive impact. Before I take your leave, I extend my heartfelt gratitude to our President, Dr. Ashutosh Kulkarni Sir, for believing in me for the post of RMA Secretary. This Herculean task wouldn't have been possible without his continuous support and encouragement. A million thanks to my dear friend and treasurer Dr. Kumar and Dr. Dilip for being by my side always. Thank you all our members, sponsors and partners for their unwavering support. Let's work together to make the upcoming year even more successful. Long live RMA. Thank you.
धन्यवाद डॉक्टर प्रशांत. यानंतर आपले एडिटर डॉक्टर दिलीप सावळे यांनी व्यासपीठावर आपली रायकॉनची स्मरणिका घेऊन यायचं आहे. विविध लेख, रिसर्च, माहिती अशा विविध सदरांनी सजलेली ही स्मरणिका आहे. आपले आजचे प्रमुख पाहुण्यांच्या हस्ते याचं विमोचन व्हावं अशी मी विनंती करते. धन्यवाद. निस्वार्थ भावाने एकत्र येऊन काम केल्याने हाती घेतलेलं कार्य सहज सफल होतं. एकीचं बळ सर्वांना माहीतच आहे. एका ध्येयाने, ध्यासाने, प्रेरणेने एकत्र येऊन वेगवेगळ्या स्वभावाची, वयाची माणसं ज्याच्यासाठी काम करतात ती संघटनाच उत्तुंग यश मिळवते. यावर्षीची आपल्या संघटनेची धुरा ज्यांनी यशस्वीरित्या सांभाळली आहे आणि सर्व पदाधिकाऱ्यांचं जे प्रतिनिधित्व करतायत ते RMA प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना मी विनंती करते की त्यांनी आपलं मनोगत मांडावं.
थँक्यू व्हेरी मच. नमस्कार. रायकॉन 2026मध्ये आपलं सगळ्यांचं सहर्ष स्वागत. आज आपलं भाग्य म्हणजे व्यासपीठावरती कार्यसम्राट आपले कर्जतचे लाडके आमदार श्री महेंद्र थोरवे साहेब आपल्याबरोबर आहेत. एका विनंतीलाच काल गेलो, त्यांना विनंती केली आणि साहेब आपल्याबरोबर आज आलेत. आम्ही साहेब तुमच्या कार्याचं एक प्रतीक म्हणून आपल्या विठ्ठलाची मूर्ती या स्टेजवरच्या बॅकड्रॉपला लावलेली आहे. तर धन्यवाद साहेब. आणि तसंच कुरुश दलाल सर, त्यांचे तुम्ही यूट्यूबवरती व्हिडिओ बघाल तेव्हा तुमची त्यांची विद्वत्ता कळेल. अतिशय सुंदर त्यांचं ओरेशन होणार आहे पुढचं, नक्की सगळ्यांनी ऐका. त्यांनी पण मला माझ्या एका शब्दावरती मान देऊन ते आज इथे आलेत, तर त्यांचे पण मी त्यांना धन्यवाद मानतो. एप्रिल 2026मध्ये आमच्याकडे रायकॉन 2026चं यजमानपद आलं. यावर्षी मला रायगड जिल्ह्यातील सर्वोच्च पदाचा मान भूषवण्याचा संधी मिळाली. या संघटनेच्या सर्वोच्चपदी माझ्यासारखा सर्वसामान्य सभासद येऊ शकतो हे रायगड मेडिकल असोसिएशनच्या मध्ये असलेल्या सशक्त लोकशाहीचं आणि परस्पर स्नेहभावाचं प्रतीक आहे. त्याशिवाय होणार नाही. आणि हा माझ्यासाठी माझ्या आयुष्यातला मोठा महत्त्वाचा टप्पा आहे. आपल्या सहकार्याने वर्षभर आम्ही विविध उपक्रम केले, सेक्रेटरी साहेबांनी सांगितलं, आणि एकंदर प्रतिसाद बघितला तर तो सगळेच कार्यक्रम आमचा यशस्वी झाले असं मला वाटतंय. तुमचं पण तेच मत असेल. याच्यात जो भरभरून प्रतिसाद मिळाला तो तुमच्या सर्वांचा आणि महत्त्वाचं म्हणजे माझ्या कर्जत मेडिकल असोसिएशनच्या टीमचा. इतके कष्ट केलेत या लोकांनी, काय विचारू नका. म्हणजे अगदी आपले हे चेअरमन साहेब आहेत, सगळे ऑर्गनायझिंग चेअरमन आहेत, आमचे चीफ ॲडवायझर जैन सर आहेत की ज्यांच्यामुळे आम्हाला हा व्हेन्यू मिळाला. आम्हाला प्रमोद गांधी सरांनी सुचवलं की अरे बघ तुझं जेवणाची आठवण काढतील नंतर आणि तू हा व्हेन्यू सिलेक्ट कर. म्हटलं सर एवढा सॉल्टसारखा मेनू घ्यायचा म्हणजे केवढा खर्च आहे. आम्ही जैन सरांना म्हटलो सर अशी अशी कल्पना आहे आमची, अरे चल करूया आपण. अक्षरशः मला आता रडू येतं. साहेबांनी दोन 2025मध्ये काही तांत्रिक कारणांमुळे आमच्याकडे हे प्रेसिडेंट पद येईल की नाही असं वाटत होतं. काय इलेक्शन वगैरे असे प्रकार झाले, पण नंतर खरोखरच ते सगळं आलं. पण हे प्लॅनिंग जमणार की नाही असं आम्ही चौघजणं बसायचो, मी, प्रशांत, कुमार आणि दिलीप. आपण हे करू शकतो की नाही. पण ह्या सगळ्यांचा प्रतिसाद मिळाला, सगळे आमच्या मागे उभे राहिले आणि म्हणूनच हे सगळं झालं आहे. आपले आता मी 2005 साली डॉक्टर फडकेंचे अध्यक्ष होते तेव्हा मी स्पोर्ट्स सुरू केले. पण आता हे स्पोर्ट्सचं एवढं प्रकरण मोठं झालं आहे की विचारू नका. म्हणजे या कॉन्फरन्सचं टेन्शन नाही तेवढं मला स्पोर्ट्सचं टेन्शन होतं. पण माझा मित्र राजेश शिंदे आणि हे सगळे स्पोर्ट्स ॲडमिन कमिटीचे घनश्याम सर आहेत, हे सचिन नाईक सर आहेत, हे सगळे एवढे खंबीरपणे माझ्या मागे उभे राहिले आणि ते स्पोर्ट्स माझं अतिशय छान निर्विघ्नपणे पार पडलं. धन्यवाद साहेब, तुमच्यामुळे झालं आहे सगळं. आणि असंच ही गोष्टी आहेत, ह्या सगळ्या कशामुळे होतात तर आपल्या एकजुटीमुळे होतात. हे जे परस्परम भावयंता श्रेया ही जी टॅगलाईन आहे ती माझ्या आईने लिहिली आहे. त्याचाच अर्थ असा आहे की आज आई आलेली आहे, ते एकजुटीने तुम्ही काम केलं, कुठल्याही तुमचा निस्वार्थपणे तुम्ही काम केलं, हे नक्की यशस्वीपणे पार पडेल आणि असं भव्य दिव्य काम तुम्ही करू शकाल. त्याच्यासाठी सगळ्यांचे पुन्हा एकदा मी तुम्हाला सगळ्यांना सलाम करतो आणि माझे 2 शब्द संपवतो. थँक्यू व्हेरी मच.
धन्यवाद सर. आजचे गेस्ट ऑफ ऑनर माननीय श्री आमदार महेंद्र थोरवे यांनी आपले मनोगत व्यक्त करावं अशी मी त्यांना विनंती करतो.
आजचा हा सुंदर असा नियोजन असलेला रायगड मेडिकल असोसिएशन रायकॉन 2026 या 2 दिवसीय कार्यशाळेचं आपण आयोजन माझ्या कर्जतमध्ये आज या ठिकाणी होत आहे. आजच्या कार्यक्रमासाठी प्रमुख पाहुणे म्हणून लाभलेले सन्माननीय डॉक्टर कुरुश दलालजी, सन्माननीय आमचे अध्यक्ष ज्यांनी आता आपलं मार्गदर्शन या ठिकाणी केले ते डॉक्टर आशुतोष कुलकर्णीजी, सचिव सन्माननीय डॉक्टर प्रशांत गांगलजी, खजिनदार डॉक्टर कुमार ओसवाल आणि या ठिकाणी उपस्थित असणारे आमचे म्हणजे सगळेच कर्जतचे आपण सगळे डॉक्टर्स व्यासपीठावर उपस्थित असणारे. आणि आज या कार्यशाळेला आपल्याला सगळ्यांना डॉक्टरांना मुळात असं मार्गदर्शन करण्यासाठी जे सिनियर डॉक्टर या ठिकाणी उपस्थित आहेत, सन्माननीय डॉक्टर गांधी सर आपण या ठिकाणी आवर्जून उपस्थित आहात, डॉक्टर पटेल सर आपण या ठिकाणी उपस्थित आहात, प्रेमचंद जैन डॉक्टर उपस्थित आणि आपण ऑल ओव्हर सगळेच सिनियर डॉक्टर्स या ठिकाणी आजच्या या कार्यशाळेला मार्गदर्शन करण्यासाठी उपस्थित आहेत. माझा सहकारी रोहित ओसवाल आणि आपण सर्व माझ्या मतदारसंघातील सगळे डॉक्टर्स, आपण सारेजण, नेरळ असेल, कर्जत असेल, या संपूर्ण रायगड जिल्ह्यातील रायगड असोसिएशनमध्ये असणारे सर्वच आपण डॉक्टर आज या रायगड कर्जत असोसिएशन मेडिकल असोसिएशनच्या या ठिकाणी आयोजन केलेलं आहे की रायकॉन 2026 ही संकल्पनाच खरं तर डॉक्टर साहेब फार प्रचंड समाधान देणारी आहे. मी मनापासून सगळ्या डॉक्टरांचं या ठिकाणी अभिनंदन करतो की माझ्या मतदारसंघामध्ये अशा पद्धतीचं आपण नियोजन खऱ्या अर्थाने या ठिकाणी करत आहात. गांधी सरांचं पनवेलपासून आपण संपूर्ण नवी मुंबई सगळीकडेच फार मोठं योगदान आहे. आणि डॉक्टर पटेलांबद्दल तर काय सांगावं, मी स्वतःच 20 ते 25 वर्षापूर्वी माझं स्वतःचं एक छोटंसं ऑपरेशन डॉक्टर पटेलांनी केलेलं आहे आणि त्यांच्या हॉस्पिटलला मी स्वतःही त्या ठिकाणी ॲडमिट होतो आणि त्यांना आज पाहिल्यानंतर आता बरंचसं एज झाले, कारण त्या गोष्टीला जवळजवळ 25 वर्ष झाली आणि 25 वर्षानंतर त्यांना मी या ठिकाणी पाहतोय, तर मनस्वी आनंद या ठिकाणी होत आहे. खरं तर ही संकल्पना फार छान आहे. मी अनेक या मतदारसंघाचा आमदार झाल्यानंतर कर्जत हा तसा ट्रायबल भाग आहे आणि ही पूर्वीपासूनची असणारी आमच्या राजकीय राज्यकर्त्यांची किंवा इथल्या स्थानिक लोकांची असणारी जी काही संकल्पना की बाबा आपण ट्रायबल भागात राहतोय आणि हा असणारा ट्रायबल भाग हा जर खऱ्या अर्थाने जर आपण मुंबईपासून फार जवळ असणारा हा मतदारसंघ कर्जत म्हणून आपण पाहतोय आणि ह्याला जर आपल्याला बदलायचं असेल तर नक्की काय केलं पाहिजे आणि याच उद्दिष्टाने या मतदारसंघाचा आमदार झाल्यानंतर प्रत्यक्ष पूर्णपणे एक महिनाभर संपूर्ण मतदारसंघाचा स्टडी केला गांधीसाहेब आणि मग डिसिजन आपण त्या ठिकाणी घेतलं. आमचे डॉक्टर जैन या ठिकाणी आहे, श्रीपाल माझा सहकारी या ठिकाणी, सगळेच जण मला हे नेहमी सहकार्य करत असतात आणि मग इन्फ्रास्ट्रक्चर हे आपल्या मतदारसंघाचं आपल्या परिसराचं जर व्यवस्थित असेल तर आपल्याला नव्याने चांगल्या डेव्हलपमेंट या ठिकाणी करता येतील. आणि मग आम्ही माझं उपजिल्हा रुग्णालय कर्जतला आहे, मी त्या ठिकाणी सुद्धा सगळ्या डॉक्टरांशी त्यावेळेस चर्चा केली आणि त्यानंतर सुद्धा की मुंबईपासून नवी मुंबईपासून पनवेलपर्यंत येणारे डॉक्टर्स इमर्जन्सी डॉक्टर्स म्हणून त्या ठिकाणी उपलब्ध आपण राहत होतात. आपण ज्यावेळेस आपण पाहिलं की लाईफलाईनसारखं हॉस्पिटल पनवेलकरांनी उभं केलं आणि एक कॉर्पोरेट लेवलचं हॉस्पिटल ज्यावेळेस त्या ठिकाणी उभं राहिलं आणि ते सुद्धा एक सोशल म्हणून आपण सगळे एकत्रपणे येऊन पनवेलकरांनी त्यावेळेस जी इच्छा आपण सगळ्यांनी त्या ठिकाणी व्यक्त केली. आमची सुद्धा कर्जतकरांची अशीच काहीतरी एक या बाबतीत इच्छा होती की कर्जतमध्ये अशा पद्धतीचं हॉस्पिटल त्या ठिकाणी यावं आणि या सगळ्यांसाठी आपल्याला सगळ्यांच्या माध्यमातून इमर्जन्सी डॉक्टर्स उपलब्ध व्हावेत. इमर्जन्सी केसेसला आपण त्या ठिकाणी आपल्याला हॉस्पिटल कशा पद्धतीने उभं करता येईल. डॉक्टर जैनने आता साहेबांनी नवीन हॉस्पिटल त्या ठिकाणी उभं राहत आहे. ही एक नव्याने संकल्पना त्यांनी अतिशय चांगल्या पद्धतीचं हॉस्पिटल त्या ठिकाणी तयार होत आहे आणि लवकरच ते जानेवारी ते फेब्रुवारीमध्ये माझ्या मते मार्चपर्यंत आपण त्या हॉस्पिटलचं ओपनिंग त्या ठिकाणी करणार आहोत. आणि अशा पद्धतीने कर्जतला सुद्धा आमची सगळ्यांची ही संकल्पना आहे की हे जे सगळे डॉक्टर्स आहेत ते माझ्या कर्जतमध्ये यावेत आणि म्हणून इन्फ्रास्ट्रक्चर कर्जतचं व्यवस्थित असावं की जेणेकरून आता आपण पाहतोय की हा चौक कर्जत रस्त्याला आपण जे आता आपण या ठिकाणी डेव्हलपमेंट केलेले आहेत किंवा हा रस्ता बांधलेला जवळजवळ 100 कोटी रुपये या रस्त्यासाठी आपण पहिल्या टर्मला मी आमदार झाल्यानंतर शिंदेसाहेबांच्या माध्यमातून या ठिकाणी सुरुवात केली आणि मग एक रेड कार्पेट आपण म्हणतो की डेव्हलपमेंटला आपण त्या ठिकाणी एक रेड कार्पेट दिलेलं आहे की या माझ्या कर्जतमध्ये आपण डेव्हलपमेंट करण्यासाठी आणि डेव्हलपमेंट करायचं असेल तर इन्फ्रास्ट्रक्चर प्रामुख्याने व्यवस्थित असलं पाहिजे आणि या उद्देशाने आपण या मतदारसंघाची नव्याने सगळी डेव्हलपमेंट करत असताना आज आपण या ठिकाणी पाहतोय की आपण कर्जत मेडिकल असोसिएशनच्या माध्यमातून रायगड मेडिकल असोसिएशन एकत्रपणे येऊन ही संकल्पना आपण साऱ्या डॉक्टरांनी कर्जतमध्ये जी काय व्यक्त केलेली आहे तुम्ही कुलकर्णी सर की आपल्या सगळ्या डॉक्टरांना या ठिकाणी अशा पद्धतीचं एक क्लायमेट त्या ठिकाणी तयार व्हावं की आपल्याला या ठिकाणी असणारे जे काही आपले रुग्ण आहेत त्यांना सेवा ही अशा पद्धतीची आपल्याला इमर्जन्सी सेवा देता यावी. कारण आपण आता पाहतोय की याच्या अगोदर डॉक्टरांकडे पाहण्याचा दृष्टिकोन जो समाजाचा जो होता तो फक्त आपण त्या ठिकाणी की डॉक्टर हा एक व्यावसायिक म्हणून आपल्याकडे पाहिलं जायचं आणि व्यावसायिक डॉक्टर म्हणून पाहत असताना ज्या वेळेस कोविडसारखं महाभयंकर संकट संपूर्ण जगामध्ये आलं आणि त्यानंतर खऱ्या अर्थाने डॉक्टरांनी आपल्या परिवारांची पर्वा न करता कोविडमध्ये दिलेलं योगदान संपूर्ण देशने जगसुद्धा विसरू शकत नाही. अशा पद्धतीचं कार्य डॉक्टरांच्या माध्यमातून कोविडमध्ये झालं आपण सगळ्यांनी पाहिलं आणि मग हे सगळं करत असताना त्यांनासुद्धा परिवार आहेत, त्यांनासुद्धा आईवडील आहेत, त्यांनासुद्धा मुलं आहेत आणि मग डॉक्टर म्हणून देत असणारी सेवा आणि डॉक्टर म्हणून समाजाची घेत असणारी जबाबदारी आपण किती थकलोत, आपण किती पेशंट आत्तापर्यंत पाहिलेत ह्याची पर्वा न करता 2 वाजता जेव्हा साबणे डॉक्टर डोळे पुसत उठे कर्जतला एखादं त्या ठिकाणी झालेलं हार्ट अटॅकचा पेशंट इमर्जन्सी येतो आणि त्यावेळेस डॉक्टर साबणेवर प्रेशर केलं जातं का तरी अजून तुम्ही उठत नाही. डॉक्टर तरी काय करणार अशी परिस्थिती कर्जतला त्या ठिकाणी आहे की लोकसंख्या मोठ्या प्रमाणात आहे आणि डॉक्टर्स अवेलेबल त्या ठिकाणी कमी प्रमाणात आहेत. वयस्कर असणारे डॉक्टर कशा पद्धतीने या ठिकाणी सामोरे जातील, या साऱ्या गोष्टी जर आपण अभ्यासात घेतल्या, आपण त्याचा जर विचार त्यापूर्वक केला आणि डॉक्टर हा खऱ्या अर्थाने आजची जी काय परिस्थिती आहे आणि जर आता युवा जनरेशन गांगलसारखे आपण सगळे डॉक्टर नव्याने सगळे जैन डॉक्टरांचे चिरंजीव तयार झाले, त्यांची सुनबाई ह्या सुद्धा गोल्ड मेडलिस्ट आहेत. हे असे डॉक्टर आज कर्जतमध्ये सारेजण आपण एकत्रपणे त्या ठिकाणी आलेले आहात आणि ह्या सगळ्यांच्या माध्यमातून आम्हाला कर्जतकरांना जी अपेक्षा आहे की आपण एक विजन ठेवून या कर्जतचं खऱ्या अर्थाने कर्जतच्या सर्वसामान्य जनतेला न्याय देण्याचं काम आपल्याला आरोग्य सेवेच्या माध्यमातून आपण साऱ्यांनी एकत्रपणे त्या ठिकाणी केलं गेलं पाहिजे. आणि हे सारं होत असताना सामाजिक असणारी जी आमची सगळ्यांची बांधिलकी आहे की आम्ही सुद्धा डॉक्टरांना तेवढ्याच पद्धतीची रिस्पेक्ट, तेवढाच त्यांचा सन्मान हा राखण्याचं काम सुद्धा आम्ही साऱ्यांनी त्या ठिकाणी खऱ्या अर्थाने जनतेने त्या ठिकाणी केलं गेलं पाहिजे. तेव्हाच खऱ्या अर्थाने त्यांना एक मॉरल सपोर्ट हा असतो की बाबा आम्ही एवढं सगळं त्या ठिकाणी करतोय, फक्त काय हे पैसे कमवण्यासाठी नाही, तर आमची सुद्धा समाजाप्रती असणारी ही बांधिलकी आहे आणि ही बांधिलकी आपण त्या ठिकाणी जपत असताना सुद्धा मात्र येणारा पेशंट त्या ठिकाणी चुकीच्या पद्धतीने आपण पाहत असतो की कधी एखाद्या वेळेस डॉक्टरांच्या सुद्धा हातात नसतं, त्यावेळेस डॉक्टर सांगतो आता देवाच्या हातात आहे, तुमची शेवटची दोरी देवाच्या हातात आहे. जेव्हा सांगितलं जातं तेव्हा मात्र मग आपण त्या ठिकाणी आपले सगळे वैद्यकीय उपचार त्या ठिकाणी संपले जातात, तेव्हा मात्र मग आपण देवाचा धावा घेत त्या ठिकाणी बसलेलो असतो. मग मात्र हीच संकल्पना घेऊन डॉक्टरांचा प्रयत्न करणार ते देवरूपी कार्य, डॉक्टरांची जी संकल्पना आहे अतिशय चांगल्या पद्धतीचा प्रयत्न प्रामाणिकपणे त्या ठिकाणी करत असतात आणि हे सर्वसामान्य आम्ही सगळ्यांनी त्या ठिकाणी समजून घेतलं पाहिजे. या भूमिकेशी मी त्या ठिकाणी समर्पित असतो ना, माझी ही भूमिका असते. आणि म्हणून आज हे सगळे डॉक्टर कर्जतमध्ये एकत्रपणे या ठिकाणी येत असताना कर्जतमध्ये सुद्धा आपण लाईफलाईन सारखं एखादं हॉस्पिटल, मी मागच्या वेळेला सुद्धा अध्यक्षांची चर्चा आपण त्या ठिकाणी केलेली होती, परंतु ही चर्चा फॉलोअप आपण त्या ठिकाणी घेतला पाहिजे. आपण अध्यक्ष साहेब सातत्याने फंड्स आपल्याकडे शासनाचे आहेत, ज्या ज्या गोष्टी लागेल आपण CSR उपलब्ध करून देऊ. आपल्याकडे बरेचसा मोठमोठे प्रोजेक्ट आपण या ठिकाणी करतोय. आता जवळजवळ टाटा प्रोजेक्ट 6,500 कोटीचा प्रोजेक्ट आहे, आपण 12,000 कोटीचे डॅमचे प्रोजेक्ट आणलेले आहेत. असे अनेक प्रोजेक्ट त्या ठिकाणी आपण नव्याने कर्जतमध्ये त्या ठिकाणी आलेले आहेत. ह्या साऱ्या डेव्हलपमेंट होत असताना याचा CSR जो आहे हा आपण त्या ठिकाणी वापरला गेला पाहिजे, आपण पुढाकार घेतला पाहिजे. आपल्या कर्जत मेडिकल असोसिएशननी एकत्रपणे येऊन जर आपण या ठिकाणी कर्जतलाच या ठिकाणी एखादं कॉर्पोरेट लेवलचं हॉस्पिटल आपण उभारलं तर सर्वसामान्यांना त्या ठिकाणी आपल्याला न्याय देता येईल. आणि म्हणून अनेक आयुष्यमान भारत योजना आहे, या योजनेचा गोरगरिबांना लाभ देता येईल. त्यानंतर महात्मा फुले जनआरोग्य योजना आहे, या योजनेचा लाभ सर्वसामान्यांना त्या ठिकाणी देता येईल. आपण सुशिक्षित आहात, आपण डॉक्टर आहात, आपण उच्च शिक्षित सगळे आहात, आपण शासनाच्या योजना सुद्धा सगळ्यांनी समजून घेतल्या पाहिजेत. आणि शासनाच्या योजना ह्या कागदापुरत्या मर्यादित न राहता त्या आपण प्रॅक्टिकली कशा पद्धतीने आपण उतरवू शकतो हे सुद्धा आपण जसं आपण एक असोसिएशनच्या माध्यमातून हे सामाजिक बांधिलकी जपत ज्या काही नवीन नवीन कार्यशाळेच्या माध्यमातून आपण असणारे सिनियर डॉक्टर्स आपल्याला मार्गदर्शन करत असतात आणि ह्या सगळ्यांच्या माध्यमातून ज्या वेळेस आपण नव्याने काहीतरी शिकण्याचा प्रयत्न करत असतो त्यावेळेस अशा पद्धतीची सुद्धा संकल्पना आपल्याकडे त्या ठिकाणी असली पाहिजे की आपण सुद्धा अशा पद्धतीचं काहीतरी वेगळं करण्याचा प्रयत्न माझ्या कर्जतमध्ये त्या ठिकाणी जर आपण केलात तर मला त्या गोष्टीचा मनस्वी आनंद या ठिकाणी होईल. कारण आपण जी संकल्पना घेऊन या ठिकाणी एकत्रपणे आलेला आहेत ही फार सुंदर संकल्पना आहे आणि अशा पद्धतीने जर आपण सामाजिक बांधिलकी जपत समाजाचं हित जपण्याचं काम जर आपण एकत्रपणे या ठिकाणी केलं तर फार मोठं काम आपण डॉक्टर असोसिएशनच्या माध्यमातून जे काही आपल्याला व्यवसाय करायचा तो व्यवसाय तर आपण त्या ठिकाणी करतायच, परंतु व्यवसाय करत असताना डॉक्टर हाच खऱ्या अर्थाने आज हे प्रत्येक कुटुंबाला आधार देणारं काम, प्रत्येक कुटुंबाला खऱ्या अर्थाने त्या ठिकाणी जो काही त्या ठिकाणी ज्यावेळेस कुटुंबावर कॅन्सरसारखे पेशंट आपण पाहतोय, टाटाला फुटपाथवर त्या ठिकाणी पेशंट झोपलेले असतात अशी परिस्थिती आजची त्या ठिकाणी आहे. आणि म्हणून आपण टाटाचं हॉस्पिटल आपण त्या ठिकाणी खारघरला घेतलं, मी खालापूरला आता नव्याने त्या ठिकाणी 25 एकर जागा आपण त्या ठिकाणी टाटा हॉस्पिटलला आपण त्या ठिकाणी आम्ही त्या ठिकाणी ठराव करून त्या ठिकाणी दिली आणि आज जवळजवळ 250 ते 300 कोटी रुपयाचा प्रोजेक्ट त्या ठिकाणी कॅन्सर हॉस्पिटलच्या रूपाने टाटाचा त्या ठिकाणी होत आहे. आणि ही सारी संकल्पना आपण करत असताना आपण जे काय प्रायव्हेट डॉक्टर्स म्हणून त्या ठिकाणी जे छोट्या मोठ्या आपण त्या ठिकाणी प्रत्येक एरियामध्ये आता नेरळ असेल, कशेळे असेल, माझे जे काही छोटे छोटे आपण त्या ठिकाणी शहरीकरण आता वाढत चाललेलं आहे. आणि या सगळ्या ठिकाणी आपण जे काही आपण सामाजिक बांधिलकी जपत आपण त्या ठिकाणी काम करता, हे अतिशय उल्लेखनीय काम आहे. आपल्या माध्यमातून जनतेची ही सेवाच आहे आणि सेवा करत असताना आपली सगळ्यांची सामाजिक बांधिलकी जपत आपण साऱ्यांनी एकत्रपणे त्या ठिकाणी काम केलं गेलं पाहिजे. तेव्हाच खऱ्या अर्थाने समाज एक संघ होईल, समाज सुदृढ होईल आणि ह्या मतदारसंघाची सस्टेनेबल डेव्हलपमेंट व्हावी या दृष्टीने सातत्याने मी या मतदारसंघाचा आमदार म्हणून प्रयत्न करत आहे. आणि म्हणून ही बांधिलकी आपली साऱ्यांची आहे. आम्ही शासन प्रशासन एकत्रपणे येऊन आपण सारेजण एकत्रपणे काम करू शकता. आपल्या सगळ्यांच्या माध्यमातून एक चांगला समाज घडवण्यासाठी डॉक्टर्स हा सुद्धा फार मोठा दुवा आहे आणि आपण साऱ्यांनीच एकत्रपणे येऊन हे कार्य आपण एकत्रपणे मतदारसंघामध्ये एकत्रपणे हाती घेऊया. आपल्या सगळ्यांचंच योगदान, गांधीसाहेब तुम्ही केलेलं आत्तापर्यंत या संपूर्ण समाजाला दिलेलं योगदान, पटेलांनी दिलेलं योगदान हे कदापि विसरता येणार. जैन सर आमचे आहेत, डॉक्टर साबणे असतील, अनेक डॉक्टर्स या ठिकाणी आहेत की त्यांनी संपूर्ण आयुष्य हे समाजाच्या हितासाठी वेचलेलं आहे. आणि असं काम हे डॉक्टरांच्या माध्यमातून आपल्याकडे या ठिकाणी होत आहे, या गोष्टीचा सार्थ अभिमान आहे. एका पाश्चात्य विचारवंत आहेत प्लेटो, त्यांनी असं म्हटलंय, टू कीप द सोसायटी हॅपी अ गव्हर्नर शुड बी वाईज. समाज सुखी होण्यासाठी शासनकर्ता हा ज्ञानी असावा लागतो. आणि ही संकल्पना आपली साऱ्यांची त्या ठिकाणी असली पाहिजे की आपण अशा पद्धतीचं व्हिजन घेऊन या संपूर्ण जनतेसाठी आपलं योगदान त्या ठिकाणी असलं पाहिजे. आणि हे काम या मतदारसंघाचा आमदार म्हणून मी सदैव आपल्या सगळ्यांच्या पाठीशी ठामपणे उभा आहे. ती माझी भूमिका असेल की आपण साऱ्यांनी एकत्रपणे येऊन आम्ही फक्त डेव्हलपमेंटलाच प्राधान्य न देता आपण आरोग्याची फार मोठी काळजी त्या ठिकाणी घेतली पाहिजे. मी आमदार आमच्या फाउंडेशनच्या माध्यमातून त्या ठिकाणी एक ॲम्ब्युलन्स आपण त्या ठिकाणी आम्ही दिलेले, कार्डियक ॲम्ब्युलन्स आम्ही जवळजवळ 21 लाख रुपये खर्च करून त्या ठिकाणी केले. डॉक्टर्स त्या ठिकाणी उपलब्ध करून दिले, मेडिसिन्स त्या ठिकाणी दिले आणि खेडेपाड्यात जाऊन त्या ठिकाणी आदिवासी वाड्या वस्त्यावर असणारे जे माझे आदिवासी बांधव आहेत त्यांना घरी जाऊन त्या ठिकाणी उपचार सुरू केला. आणि मग त्यांना माहितीसुद्धा नाही की मला डायबिटीस आहे, मला BP आहे. आणि अशा पद्धतीने असणारे काही बरेचसे लोक आज त्या ठिकाणी समाजामध्ये आहेत की जे पैशाअभावी त्या ठिकाणी अजून सुद्धा चेकअप करण्यासाठी जात नाहीत. आणि मग ही सुद्धा एक सामाजिक बांधिलकी जपत आपण ह्या असोसिएशनच्या माध्यमातून तुम्ही आम्ही एकत्रपणे आलो तर एक वेगळा मेसेज आपल्याला समाजामध्ये या माध्यमातून सुद्धा आपल्याला देता येईल. आणि असं काम आपल्याला कर्जतमध्ये करण्यासारखं खूप काही आहे आणि आपण ते एकत्रपणे येऊन करू शकतो. ते सुद्धा आपला परिवार, आपला व्यवसाय अबाधित राहून आपल्याला समाजाचं हित जपण्याचं काम आपण एकत्रपणे त्या ठिकाणी करूया. आपण या ठिकाणी रायकॉन 2026 ही संकल्पना जी मांडलेली आहे ही खूप छान आहे आणि अशाच पद्धतीचं काम हे सातत्याने माझ्या मते कुलकर्णी सरांनी सांगितलं की 15 वर्षांनी आमचा नंबर या ठिकाणी पुन्हा एकदा आलेला आहे. तर अशाच पद्धतीने आपण एक चांगली भरारी, आपलं एक चांगलं व्हिजन ठेवून आपण जर या मतदारसंघामध्ये कर्जतमध्ये, नेरळमध्ये, या परिसरामध्ये खोपोली असेल, खाळापूर असेल, इंडस्ट्रियल बेल्ट मोठ्या प्रमाणात आहे. खूप मोठी डेव्हलपमेंट आपण या ठिकाणी आता नव्याने आपण आणलेली आहे. जवळजवळ खालापूरमध्ये 1.5 लाख कोटीची डेव्हलपमेंट आतापर्यंत सुरू झालेल्या आहेत. कर्जतमध्ये मोठ्या प्रमाणात आपण त्या ठिकाणी डेव्हलपमेंट या ठिकाणी येत आहेत. आणि म्हणून आपण या ठिकाणी टुरिझमला आम्ही प्राधान्य दिलेलं आहे. आणि टुरिझमच्या माध्यमातून या ठिकाणी आपण पाहताय की जगाची अर्थव्यवस्थेमध्ये अनेक जगामध्ये आपण देशामध्ये आपण फिरताय. स्वित्झर्लंड असेल, मलेशिया असेल, सिंगापूर असेल, दुबई असेल, या साऱ्या देशांची अर्थव्यवस्था ही टुरिझमवर चालते. आपण विश्वास ठेवणार नाही, फक्त टुरिझमवर यांची अर्थव्यवस्था चालते. आपण सारेजण पाहताय की आपण सुद्धा सुट्टीला कुठं जायचं म्हटलं तर इंडियात जायला मागत नाहीत कोण, पण बाहेरच्या देशामध्ये मात्र 25 ना 50 लाख रुपये खर्च करून आपण त्या ठिकाणी आपला इंडियन मनी करन्सी आपण त्या ठिकाणी आपण खर्च करतो आणि त्या देशांचं भलं करतो. आपण आपला देश बळकट करूया. आपण आपल्या देशाचं, माझं कर्जत माझी ती संकल्पना आहे की माझ्याकडे टुरिझम आला पाहिजे, माझ्याकडे टुरिझम वाढला पाहिजे आणि टुरिझमच्या माध्यमातून माझ्याकडची असणारी अर्थव्यवस्था बळकट झाली पाहिजे. आणि हे विजन ठेवून आपण जसं आपण टुरिझमला आम्ही प्राधान्य देतोय तसं मेडिकल टुरिझम सुद्धा आपण कर्जतमध्ये या ठिकाणी मोठ्या प्रमाणात आपण त्या ठिकाणी करू शकतो. आणि ही संकल्पना ठेवून जर आपण चांगलं काम या ठिकाणी उभं केलं तर माझं पूर्णपणे सहकार्य या ठिकाणी आहे. जो काही शासनाच्या माध्यमातून जेवढा फंड लागतील ते फंड आपण या ठिकाणी उभे करून देऊ शकतो. आपण मात्र वेगवेगळे विजन घेऊन असोसिएशननी पुढे यावं असं मी या ठिकाणी सगळ्यांना निमित्ताने सांगेल. पुन्हा एकदा आपला रायकॉन 2026चं मनापासून सगळ्या डॉक्टर्स असोसिएशनचं आणि संपूर्ण टीमचं मनापासून या ठिकाणी अभिनंदन करतो. सगळ्यांना मनपूर्वक शुभेच्छा देतो आणि या ठिकाणी थांबतो. जय हिंद, जय महाराष्ट्र.
धन्यवाद साहेब. आपल्या दूरदृष्टीची मला कमाल वाटते आणि या आपल्याकडे जे मेडिकल टुरिझमबद्दल तुम्ही सांगितलं आहे, नक्कीच ती गोष्ट एक दिवस आपण नक्की यशस्वी करून दाखवाल याची मला खात्री आहे. आजच्या या रायकॉन 2026मध्ये मी एक स्पेशल अनाउन्समेंट करत आहे. आपण स्पेशल फेलिसिटेशन करत आहोत डॉक्टर विनायक पाटील, IMA प्रेसिडेंट अलिबाग यांचं. मी सरांना विनंती करतो की त्यांनी व्यासपीठावर यायचं आहे. डॉक्टर विनायक पाटील, pediatrician from Alibag. He got elected in recently concluded Maharashtra State IAP election as President elect 2026 of Maharashtra State Indian Academy of Pediatrics. He was Chief Organizing Secretary of Mahapedicon 2021. थँक्यू सर. आजच्या कार्यक्रमाचे चीफ गेस्ट डॉक्टर कुरुश दलाल यांची ओळख मी थोडक्यात आपणास करून देत आहे. डॉक्टर कुरुश दलाल MA आर्किओलॉजी आणि अर्ली INH इन राजस्थान या विषयावर त्यांनी PhD प्राप्त केलेली आहे. ते पश्चिम किनारपट्टीवरील प्रारंभिक मध्ययुगीन पुरातत्वशास्त्राचे तज्ज्ञ आहेत. त्यांनी संजाना आणि मंदाड यांसारख्या महत्त्वाच्या स्थळांचे उत्खनन केलेले आहे. त्यांची 6 पुस्तके आणि 40हून अधिक शोधनिबंध प्रकाशित आहेत. कलिनरी अँथ्रोपोलॉजी म्हणजेच अन्न आणि मानव वंशशास्त्र यावर गेल्या 11 वर्षापासून ते काम करत आहेत. द स्टडिंग फूड वर्कशॉप याद्वारे अन्न, इतिहास, राजकारण आणि समाजशास्त्र यांच्यातील परस्पर संबंधाचे शिक्षण ते देतात. डॉक्टर कुरुश दलाल हे सध्या ज्ञान फॅक्टरी मुंबई येथे चीफ एज्युकेशन ऑफिसर म्हणून कार्यरत आहेत. सरांचे व्याख्यान आपण थोड्याच वेळात ऐकणार आहोत. त्याआधी मी आभार प्रदर्शनासाठी RMA ट्रेझरर डॉक्टर कुमार ओसवाल यांना विनंती करतो.
नमस्कार. Respected Chief Guest, Sri Kurush Dalalji, our Honorable MLA, Sri Mahendraji Thorve, our President, Secretary, Office Bearers, esteemed seniors, and my dear colleagues. On the behalf of Raigad Medical Association and Organizing Committee, it's my privilege to propose the thanks to all the members of the annual conference. I express my sincere gratitude to our respected chief guest, our graciously accepting our invitation and inspiring us. I thank our President, Secretary, and all the office bearer for the guidance and the support, and the organizing committee for their dedicated effort in making the conference a great success. My heartfelt thanks to speaker, chairperson, panelists, and all the contributors and our sponsor exhibitors and well-wishers for their generous support. I also thank all the members and the delegates for the enthusiastic participation and appreciate the efforts of Venu staff and technical team and volunteers. Thank you all for the trust. Thank you.
थँक्यू सर. मी चीफ गेस्ट डॉक्टर कुरुश दलाल यांना 2 शब्द बोलण्याची विनंती करतो.
So, thank you very much for calling me here. Mananya Thorve Sahib, and of course, the Raigad Medical Association and the Karjat Medical Association, all of you doctors, organizers, and everybody. I am incredibly honored to be invited here and to be made the chief guest. I have some very peculiar relations with Raigad district. In 1989, I donated a lot of blood to Raigad district in an accident that took place 5 kilometers south of Panvel at a small village called Ajivali. I thought that was my complete association. I then went on to be further associated by moving to Kharghar about 17 years ago and simultaneously joining the University of Mumbai, where as an archaeologist running the first archaeology program at the university, we selected the site of Chandor to conduct the first ever archaeological excavations in 155 years of the history of Mumbai University. Thank you very much. Much to our surprise, we found a brilliant early medieval settlement. We understood why villages in this area consist of group gram panchayats, and we could trace that history back 800 years continuously. So there was a lot of very interesting work that came out of that. I met Adhikari Sahib over there, thanks to the people that I was interacting with. And thanks to him, got in touch with Mr. Kulkarni, and Dr. Kulkarni then asked me whether I would come and do this. So what a beautiful circular way in which to be associated with Raigad. So I declare the session open. Thank you very, very much for having me here. And it is a great honor and a great pleasure. Thank you.
थँक्यू सो मच सर. पुढील कार्यक्रम स्वर्गीय डॉक्टर प्रभाकर पटवर्धन मेमोरियल ओरेशनसाठी मी सर्व मान्यवरांना विनंती करतो की त्यांनी व्यासपीठासमोर आसनस्थ व्हावे. चीफ गेस्ट डॉक्टर कुरुश दलाल, प्रेसिडेंट आणि सेक्रेटरी यांना मी स्टेजवरच थांबण्याची विनंती करत आहे. मान्यवरांना विनंती आहे की त्यांनी डॉक्टर पटवर्धन यांच्या प्रतिमेस पुष्पहार अर्पण करावा. प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी, RMA सेक्रेटरी डॉक्टर प्रशांत गांगल, डॉक्टर प्रभाकर पटवर्धन यांनी मुंबईतून MS जनरल सर्जरी पदवी प्राप्त केली. 1964 साली पनवेल येथे प्रॅक्टिस सुरू केली आणि 1973 साली स्वतःचे हॉस्पिटल सुरू केले. डॉक्टर पटवर्धन हे उत्तम सर्जन, मनमिळावू डॉक्टर आणि ॲक्टिव्ह सोशल वर्करसुद्धा होते. डॉक्टर पटवर्धन हे कुलाबा डिस्ट्रिक्टचे RSS जिल्हा संघचालक होते, तसेच जनसंघाचे ते जिल्हाध्यक्ष देखील होते. 1987 साली रायगड जिल्ह्यातील डॉक्टरांना संघटित करून रायगड मेडिकल असोसिएशनची स्थापना करण्यात त्यांचा मोलाचा वाटा होता. डॉक्टर पटवर्धन यांनी 1996-97 मध्ये RMA प्रेसिडेंट पदाची धुरा सांभाळली. अध्यक्षीय कार्यकाळातच 24 फेब्रुवारी 1997 रोजी त्यांचे दुःखद निधन झाले. त्यांच्या पश्चात त्यांच्या पत्नी स्वर्गीय नीलाताई पटवर्धन यांनी त्यांचे हॉस्पिटल चॅरिटेबल इन्स्टिट्यूट म्हणून चालवले. डॉक्टर प्रभाकर पटवर्धन यांच्या कार्यास विनम्र अभिवादन करत त्यांच्या स्मृतिप्रित्यर्थ व्याख्यानासाठी आलेले चीफ गेस्ट डॉक्टर दलाल हे द करंट इंडियन डाएट ॲज व्ह्यूड थ्रू द लेन्स ऑफ कलिनरी आंथ्रोपोलॉजी या विषयावर आपले मनोगत व्यक्त करणार आहेत. डॉक्टर कुरुश दलाल.
Thank you very much. And once again, thank you very much for all the gathered audience, the doctors and others. Very, very grateful to the Raigad Medical Association, the Karjat Medical Association, Ashutosh ji, and all the organizing committee members. Thank you for calling me here, and it's been a long day, so I'll try and keep it as tight as possible and as short as possible. Thanks to coming to Raigad and starting up excavations, I rekindled a massive interest in food studies in Maharashtra. The first thing that I realized was, while sitting and talking to the people of the village of Chandor, I was shocked to find that the kind of diversity of foods that we see in most of our cities does not exist in our villages even today. So I was talking to Mr. Shinde, who was the then Sarpanch, and he told me very candidly that as he was growing up, 360 days of the year, they were eating the same food. There was no difference whatsoever in the daily diet. And this was quite astounding, considering that a large number of Marathas from the village actually joined the army. So I was wondering about all kinds of things, nutritional, health, and food-based. So I did a deep dive talking to the older people in the village about what they used to traditionally eat. And much to my surprise, I found out again that about 360 plus days of the year, everybody ate the same food every day. Now to us today, that's shocking. Imagine eating the same breakfast every day, the same lunch every day, and the same dinner every day. In most upper caste houses in Chandor village, breakfast would be either nachnichi bhakri or tandlachi bhakri with chaha or garam doodh if you had a cow. Okay? No, seriously. To add to that was the fact that lunch would be tandlachi bhakri and sukat. This was standard. Bhakri and sukat was the standard lunch. There was just no two ways about it. In the evening, you had barke batateche kap, cooked with mixed sukat. So this would be small fish, some crabs, different kinds of prawns, all mixed together. This is the cheapest protein that you could buy, and it was bought almost on a monthly basis from Koli women who would come to sell it to the village. And this was either eaten with rice or again rice bhakri. This was the standard meal pattern. Vegetables were few and far between. You would have pumpkin growing on your roof at the back. When the pumpkin was ready, you ate pumpkin for breakfast, lunch and dinner. Because there was no refrigeration. You had to finish that giant pumpkin. You would give half to your neighbor, and when your neighbor's pumpkin was ripe, your neighbor would give half to you. The only other really popular vegetable was tendli. Everybody had a tendli creeper or two. And when there were about 20 to 25 tendli ready, 5 would be overripe, 5 would be slightly raw, 15 would be perfect. This would be chopped up and made into bhaji, and everybody would get 1 spoon. If there was some important visitor who came, then there would be kala watana cooked in the house. Kala watana was the absolute epitome of fancy food to be eaten. Oil had to be made from the oil grains that you grew in your farm. So you would grow black til, black sesame in your farm, and you would take that to the teli. So oil was incredibly limited. Surprisingly, it was a very healthy diet. They were eating a lot of seafood. They were getting their carbohydrates, and they were using very limited amounts of fat. And this was because, as I said, you had to grow your own oil seed. So you used very little oil. Every single house had an iron kadai, which was called kande zalwaichi kadai. Zalwaichi, bhazaichi nahi. Where you would chop up your onions and roast them dry till the edges started burning. Then you would quickly take it off the chul and pour little oil on it and mix it up. Then you would transfer it and cook the rest of your food in it. Mutton was eaten as a ceremonial food. If somebody was getting married, if there was a gundar, there would be mutton. And mutton would be cooked only two ways. You would get mutton either cooked sukka or rasa. There were only two preparations. This was fascinating to see that there were just two preparations of cooking meat. The sukka would be eaten either with vade or with bhakri. The rasa would be eaten with rice. And the entire village would turn out because it would be fate tak mutton. So everybody was going to gang bang on that mutton. Okay? And the wedding per se would be vegetarian because there would be a bhatt who would come for the wedding and he would be vegetarian, so everybody had to be vegetarian. But you had to give all the invitees mutton the day before that. So there would be the gunda or the haldi or some such connivance. And there would be animal sacrifice. And this animal sacrifice would be at the local Devi's temple. So this was all a very interesting system that was coming up about the food that was eaten. Virtually the only fruits traditionally eaten were jambul, kokum and ambe. That was more or less it. A large amount of wild vegetables were eaten, foraged vegetables. We counted while sitting with the people over there more than 30 different types of wild vegetables which we in Maharashtra call ranacha bhajya. They are not really from the Ran. They are from around the village. And of those, perhaps the most cherished are the karande, which is basically the bulbil of the Dioscorea species, and surprisingly, a very interesting flower stem of a root vegetable, which in English is called dragon stalk yam, which we call shevla. Okay? So these, if the shevla burst at the site, people would fight over two stalks at a time. There was that much demand for it. And of course, it would be cooked with sukat, because everything could be cooked with sukat. So this led me down this rabbit hole of trying to understand what we used to eat. The first revelation of trying to trace back the history of food was that humans and their ancestors have been in the Indian subcontinent for 2.6 million years. There have been humans in Maharashtra for at least 1.2 million years. At least, maybe more. So what did they eat? How did they eat? What were they doing? And I realized that there is a cutoff. There is a period when we were scavengers, opportunistic hunters, and then proper hunter-gatherers. And then we became farmers. So the farmer deadline is roughly about 11,000 years ago and after that, depending where it takes place all over the country. So in Maharashtra, farming starts about 4,200 to 4,400 years ago, not before that. So before that, we were Khanabadosh, so we were continuously nomadic, and we were hunter-gatherers. And we were very good at what we did. We had a very, very good diet, and on average, we worked for only 4 hours a day. I would really like to be a hunter-gatherer for that. Imagine just working 4 hours a day. And if you made a large kill, you didn't work for 3 days after that, because you were busy eating it. Okay? So there was a lot of foraging, there was a lot of hunting. Men and women both did both things. Okay? And we had a very nice, tight population control. Even without having any prophylactic devices, we managed to control our population incredibly well by having a very simple rule called one child in arms. At any given time, there would be only one child in the arms of a mother, which would automatically mean a 3-year gap between children. If a child was born in between, the child would be abandoned. Because you cannot carry 2 children and fend for yourself if you're continuously moving in a hunter-gatherer environment. About 16,000 years ago, to make things more complicated, the last ice age came to an end. Thanks to this, the ice sheets that covered the northern hemisphere started melting like mad. And you know what happens in your drink when the ice cubes start melting, right? Your whiskey becomes watery. So that's basically what happened to the oceans. The ocean levels rose up. It got much wetter because an ice age is a dry period. It's cold and it's dry. At the end of the ice age, it was warm and it was moist. and food became abundant. Lots of grasses, trees, and therefore wild animals, wild foods. The coasts were completely covered in water. Where there used to be only cold, deep water, now there was shallow, warm water. And these became nurseries for food. So food was hyper abundant. And our ancestors at this time, for the first time, stopped moving around. They didn't need to move around all the time. Maybe 3 to 6 months here, 3 to 6 months there. Exploiting the coast, exploiting the hinterland. Life was getting even better because there was food for the taking. For the first time, we didn't have to worry about carrying our children, and we didn't have to worry about the one child in arms policy. Also, there was no Netflix, there was no Instagram, there was no WhatsApp. So after sunset, there was only one activity that we could indulge in. So I'll try and keep this as polite as possible. So as I said, there was no Netflix, but there was a lot of chill. And we are Indians. We really practice hard at things, don't we? And what does practice make? Practice makes perfect. So we became perfect at the procreation business. We got so good that we were procreating like mad. And our populations were going up and we were all very happy. But this happiness had a very small period. Because you see, the increase in food was a one-time increase. The increase in the human population was geometric. Soon we ran out of food. For the first time, we had too many mouths to feed. So stronger groups pushed weaker groups from their foraging areas and pushed them over the ghats into the semi-arid regions. We pushed them out of the forests, we pushed them out of the coasts, and these people were forced to grow their own food. We did not become farmers because, oh, it is so beautiful to be a farmer. This is an urban fantasy. You ask a farmer whether he wants to be a farmer or he'd rather be a chowkidar or a liftman, he'd rather be a chowkidar or a liftman. And by farmer, I don't mean the Sardarji who has 45 acres of strawberries in Ludhiana in greenhouses, not that kind of farmer. I'm talking about a farmer who has 1 or 2 acres of land and he has to break his back or his entire family will starve. I don't know how many of you all are farmers here. Is anybody who comes from farming families? 2, 3, yes. Why not? Now, all of us over here are the children of farmers, whether we like it or not. We are not really the children of the original hunting-gathering communities. We are all the children of those farmers who were forced to become farmers. If you are a farmer with a couple of cows, the first thing you do when you get up in the morning is you shovel shit. The second thing you do is wash your cows that are covered in shit. The third thing you do is milk your cows. You don't have a choice. If you have cows, this is what you have to do. And you do the same thing in the evening again. In between, if you're not doing the back-breaking labor of plowing or harvesting, you are doing the world's most exciting thing. You go to your farm and you watch grass grow. Can you imagine how exciting that must be? To watch grass growing over there. The moment your children are old enough, they have to take the animals out so that the animals get fed. And cows and buffaloes and sheep are stupid. So you have to sit on a rock and keep an eye on them. So in the sun, you're sitting on a rock and keeping an eye on them. This is the second most exciting thing you can do in your life. This is the life of a farmer. You bring the cows back home, your father has to milk them again in the night. It's not the excitable life that we all dream of. The farm that we dream of is a farm where we can stick up our legs and the mango trees are growing and Babu is taking care of them and things like that. So farming was not fun. It took us a long time to learn how to grow enough food. Pehle to what to grow? So we were forced to grow grains because it was the only thing that we could grow once a year with the monsoon, which would last us the whole year, feed us the whole year, and there would be enough to plant the next year. To 2 bad monsoons would mean the death of a village. Everybody would have to leave to go to their neighbors, relatives, wherever, and beg for food and a place to stay. It took us 4,000 years how to grow enough surplus food. And in those 4,000 years, our diet went to hell. Our diet was carbohydrate, carbohydrate, and more carbohydrate. We kept cattle and we ate beef. Yes, I know it sounds horrible to a lot of people, but that's what we did back then. And we kept those animals for meat and for leather, for nothing else. We lived in the same house as those animals. Large rectangular houses, one side animals, एक बाजूला गोटा, एक बाजूला आपण राहायचं. And as you all doctors all know what happened during COVID, disease vectors jumped across from animals to humans. The animal babies got sick and our babies got the same illnesses. For example, just an odd example, chicken pox, which actually comes from cows, through cow pox. And the cow babies got better, but our babies didn't get better. And we realized that the only thing the cow's babies was getting was mother's milk. So we started using mother's milk as an antibiotic for the first time, for the antibodies that were in the milk. We didn't know they were antibodies or that it was an antibiotic, but we understood the logic. And no mother ever gives the baby anything without first tasting it. It's got lactose, it's sweet. It's damn nice. अरे राजू के पापा सुन रहे हो क्या? ये जरा ट्राई करो दूध. And राजू के पापा said, अरे अगदी स्वादिष्ट आहे रे. थोडं उरलं तर माझ्यासाठी पण ठेव. And we started breeding our cattle not for meat, but also for milk. And milk was a renewable source we could exploit every day. Meat was a one-time exploitation. You kill the animal is dead. You have to eat the whole animal. So you cannot eat a large animal by itself. You can't get up in the morning and say, आज मेरे को मटन खाने का है, मैं एक गाय एक बैल काट डालता है. It doesn't work like that. There has to be a reason where the entire village will eat that animal. Then you can think of slaughtering it. Right? Here there was milk, a renewable resource. And once we started breeding for milk, we had enough milk that we started having excess milk. Now, how to store excess milk? So we learned how to make butter by churning the milk. Butter lasts for 4 to 5 days, loni. But after 4 to 5 days, without a fridge, even the loni starts getting ambat and going. How do we stop it from becoming ambat? What do we do to milk? We boil it twice a day, every day. It lasts 2 days at least. So we decided to boil our butter. And as we boiled our butter, the milk solid separated, the water evaporated, and we were left with just milk fat, which is ghee. Ghee was the first fat that we cooked with. And fat is very rare in nature. And it was something that we absolutely took to like ducks to water. Ghee became a major savior. Those of us who talk about lactose intolerance today, and I know a lot of doctors who talk about it, lactose intolerance is how we should be. All mammals should be lactose intolerant. The lactase production should stop when your mother weans you. Those of our ancestors who learned how to keep the lactase production switch on in our stomachs had an edge. We could consume milk and milk products. And that gave us a survival edge over all of our other brothers. Food was, as I said, grain, and more grain. Ghee was a welcome relief. Dal production started very, very slowly. Vegetables were eaten in very small amounts. And this continued till 1970. Till 1970 in most of India, our diet was shit. In Raigad district, we are lucky we have the sea right next door. And most people who live in Raigad will eat sukat. And therefore, we had an edge over a lot of other people. The reason that Raigad was so instrumental in the medieval period, when the Rashtrakutas and the Shilaharas appeared, was because of our dietary choices. Because we had a lot of protein in our diet. and because the number one vegetable that we grew, when we grew a vegetable, was wangi. So wangi is one of the original Indian crops. We have evidence of wangi going back 4,400 years from Harappan sites. And Raigad has maybe 12 to 15 different kinds of wanga that grow over here. Most famous, of course, is the Deoichi wangi, the famous streaked green and purple wangi, which is almost disappearing these days, sadly. So the iodine in the fish and in the wangi also led to the lack of iodine deprivation. As we doctors all know, especially pediatricians who are here, that if you don't get your iodine till the age of 10, you have mental development problems. So again, when we look at our good friends, the Brahmins from the coast and the Brahmins of Raigad, one of the reasons that they are the smarter Brahmins is because of wangi consumption. Now, yeah, it's funny, but it's also true. Think of the amount of wangi that is eaten by vegetarians on the coast and in Raigad. Wangi used to be eaten 1 out of 3 meals. There was no batata, there was no tomato, there was no mircha. All of this came with the Portuguese, and all of this came from across the seas from the New World. Tomatoes, potatoes, chilies, they are all South American and Mesoamerican vegetables. Rajma, we all like to eat rajma, also comes from there only. Vanilla in a vanilla ice cream also comes from there only. So jokingly, I tell people that, we just ripped off the Mexican diet and we made it our own. Beans, potatoes, tomatoes, chilies, guavas, chikus, pineapples, ramphal, sitafal, all from South America. So much of what we eat today has actually been the diet of less than 200 years. Potatoes became prominent because the British needed potatoes to feed their army. So they encouraged people to grow potatoes. And potatoes grow very well in the high rainfall of Raigad, and at one time Raigad was very famous for its potatoes. Sadly, Raigad has stopped growing potatoes, but then that's kismat. That's the way it works, right? So many of the people who lived in these areas took to these new vegetables. Cauliflower and cabbage have been in India for less than 200 years. Rajma came to India 150 years ago with the French from Mexico. The French went to Mexico. Listen to me carefully because it will sound impossible to believe. The French went to Mexico to support the brother of the king of Austria as the emperor of Mexico. What? And all armies need dry food to take with them so they can cook it on the way. And the number one food available over there was corn and beans. So it was corn and beans that the French army carried. They were soundly defeated by the Mexicans and retreated. That poor prince was shot. Okay? And when they came back home to Pondicherry, they brought rajma back with them. So the OG food of the hills has been in the hills for less than 125 years. All that we are from Jammu, we eat rajma chawal with ghee, less than 125 years. North India ate a lot of barley, jaw, not jowar, jaw. Jaw was the original grain of North India along with gehu. And then the British started pushing corn, makkah. And farmers realized that you got more makkah from 1 acre than you got jaw. And local insects did not eat makkah because they didn't know what it was. It was a foreign plant. Said, let's start growing this. Not realizing that barley had way more protein than corn does. Corn probably has the least protein of any grain that exists. Corn is 4% and less protein. Even the worst rice, the cheapest rice is 6% protein. And we used to all eat millets. every farmer would grow some amount of millets. Number one, as a backup crop. If your rice failed, you planted it once, it failed. You planted it twice, it failed. Third time, you planted millets. Natsni, jowari, bajri, vari. What else? Kang. So Kang, vari and Natsni were the millets of Raigad. Raigad was known for its variche tandoor. Raigad almost does not grow any vari at all any longer. In the last 45 years, we have stopped growing vari. The vari that we eat for upvasacha tandoor now comes from South Rajasthan. And when I went to South Rajasthan to ask those people how they had started growing vari, they said, we don't like it. But these fellows in Maharashtra, they pay us a lot of money for it. So we are growing it for them, not for us. It's like, so we stopped growing it for ourselves and we are paying twice and thrice as much for people in Rajasthan to grow it for us. Nachni is one of the last millets that is still grown to some extent. Kang has almost totally disappeared. There was a very interesting millet either called harik or bharik. Synonyms. That has completely disappeared from Raigad. I can't find a single farmer, and I have been looking for the last 19 years. I can't find one farmer who grows this at all. This was one of the most interesting millets and was also a very good friend of Vaidyas who lived in Raigad at that time. So, Dhananjay Karnik's father, Vaidya Karnik from Goregaon, once sat down and told me about bharik as his teacher had told him. So bharik tends to get, if you don't keep it very dry, it tends to get a fungus. And in the early stages when you can't see the fungus, after eating the bhakri you feel very sleepy, uncontrollably sleepy, which is when you realize that you have to now burn the rest of the bharik because it has got infected. So the local Vaidya would keep some of it and would keep it in a damp place in a pot to encourage the fungus to grow. And when there would be somebody, and there was, I don't know who it was who was speaking about euthanasia over here. Is the gentleman here? Right? So when somebody had a disease where there was only pain and no cure, you would make a small bhakri out of the bharik grains full of fungus, dip it in milk and give it to that person to eat, and that person would go to sleep and never wake up. So food is as much medicine always as it is nourishment, and nourishment is just one part of food. And those of us who study Ayurveda know that it is a holistic method of curing people, that the disease that manifests is only the manifestation, is not the disease in toto, but the disease needs to be sorted out holistically by looking at your health in all patterns. Today's Ayurveda is a shadow of what Ayurveda used to be, and I apologize to my Vaidya friends in the audience for saying this. There was a lot of meat-based preparation and metal-based preparation that was used in Ayurveda. Today, Ayurveda is almost completely herbal. If you read Sushruta and Charaka in the original, they will always tell you to eat less red meat. They will always tell you to eat seasonally and hyper-locally. But the moment you are recovering from a bad illness, both of them will ask you to drink beef bone soup, because they know about the nourishment that your body needs now that it has fought this disease and is terribly weakened. मटणाचा सूप आपण महाराष्ट्रामध्ये सर्वांनाच द्यायचो. आजार संपलं, बाळणपण झालं, आपण मटणाचा सूप द्यायचो. So this is the ancestor of matnaza soup. So all of these things are incredibly practical. And this was a very practical way in which we ate. With the coming of the foods of the Columbian exchange, they disrupted a lot of food patterns that we had. With the coming of the Portuguese foods, as I call them, we stopped using tiracha tel and we shifted to shengdanecha tel. Shengdana is not even an oil seed. It's a legume, it's a dal that grows under the ground. Not the best thing. I mean, very delicious, but not the best thing to really use for oil. And we then stopped eating ghee, which was one of our primary sources of B9. And then we advocated for reasons best understood, and I'm not judging, I firmly believe that you must eat and let eat. We started advocating a diet that was more and more vegetarian. Somebody today spoke about veganism. Veganism and vegetarianism, if you are going to get all the requirements of your body, is a diet of enormous privilege. Enormous privilege. Okay, it is not a diet for poor people. It is not a diet for the common man. If you are going to get all your micros and macros. You eat fish, no problem. You eat red meat, no problem. Nobody is telling you to eat it by the kilo. Nobody is telling you to eat it every single day. But to get the vitamin D requirements on a daily basis, before you can go out in the sun and let your body convert it in sunlight to vitamin D, you got to put the petrol inside, no? So for a vegetarian, it's either 1 glass of full cream milk a day. Okay? For a fish eater, it's 30 grams of fish. There is a reason why mothers make you drink milk when you're younger and you hate it. It's collective memory, knowing that you need vitamin D growing up and you need to shove that milk down that child's throat, whether the child likes the milk or doesn't like the milk. There is virtually no vegan source of vitamin D in quantities enough for your body's daily requirements. So for example, if you wanted to get your body's daily requirement of vitamin D on a purely vegan diet, you would have to eat 5 kilos of button mushrooms every day. You would be very sick after the first week. Today, interestingly, a lot of research has shown us that the inside of the mango seed, the dried kernel of the mango, if you dehydrate that and crush that, a spoonful of that every day will give you your vitamin D requirements. This is research that has come out in the last year, and we are all completely blown away by this. This could be a huge thing for doctors to use and Ayurvedic doctors to look into for solving the vitamin D problems. If we line up even the doctors in this room and the non-doctors, I am sure that we will find lower than normal vitamin D levels in most of the people in this room. Indians have low vitamin D levels, low hemoglobin, low B12, B6, B9, and one of the problems is that we don't get enough animal protein. So getting that animal protein gives you an edge. It's not that you can't get it from vegetarian food. You can, but you need nuts, you need dry fruits, you need legumes, and you need them in quantities that most poor people cannot afford to eat them in. In India, all anthropological research shows us that whatever is the accompaniment to the carbohydrate, which is your varan, amti, sambar, rasam, whatever it is, podi, is only meant to make it easier for you to consume vast quantities of carbohydrate. Amti is not, sir, dal has got protein, sir. I'm having amti every day. How much dal is there in your amti? 2 spoons? I mean, probably if you're lucky, you get 1 spoon worth of dal in the amti that an individual person eats. And dal is not a protein. Dal is a complex carbohydrate. I will show you parts of Odisha where they make chapati out of urad dal. The original idli was 100% urad dal. Then you have Agrahara grants given to North Indian Brahmins by South Indian kings who grow rice. So you start adding rice because it's cheaper and you're growing it. So you do 10% rice, 20% rice, 40% rice, 60% rice, 80% rice. Finally 100% rice is your idli. That is why the difference between Maharashtrian idlis and Tamil idlis are still between 25 to 35% urad dal. Most Maharashtrian idlis are 100% rice. You aren't doing yourself any favors by eating them. They might be delicious. Poha. Think of poha. अरे पोहेमध्ये कांदे असतात. किती असतात? पोहेमध्ये हळदी असते, that is a मेहरबानी. That we at least putting curcumin into ourselves. But what is there in pohe? Mirchi is post-Portuguese. कोथमीर, हल्दी, मीठ आणि पोहे, कांदे. बटाटे टाकले आपण त्याच्यामध्ये, बटाटे पोहे. Carb on carb. Right? So the food that we eat today is to an enormous extent vastly changed in the last 200 years. And there have been galloping changes. I'm all for fast food, I'm all for Maggi noodles. Why not? If you want to eat them and make you happy, good for you. But when that becomes your diet, then you're going to need your doctor more and more. So I can understand doctors endorsing Maggi noodles. Okay, because it's going to bring more people to doctors. But Maggi noodles can be eaten raw. You don't need to boil them. It's already cooked. It's cooked, extruded and dehydrated. That's why it cooks in 2 minutes. Now, the atta is not going to cook in 2 minutes. Anybody who makes dal dhokli at home knows how much time it takes that atta to cook. Right? We are all excited about pasta. We've been eating pasta forever in Maharashtra. Dal dhokli, ghawne, kheer. What is that? That is all pasta only. There are at least 9 kinds of pasta that the Konkani Muslims make and dehydrate and dry and keep in burnis to cook with things. There is tons of pasta around. Okay, we just have to look for it. But we don't look for our own pasta. We want Italian pasta. Chinese Chinese. So I had a really lovely man who used to work for me at Chandor. And I'll close with this anecdote. Closing with it, closing. So close with this anecdote. Every time he would get paid on Saturday, I would ask him, कुठे चालला? सर थोडीशी घेणार आणि चिनीस खाणार. चिनीसमध्ये काय खाणार? लालीपाक आणि लूडल. This man would walk 2.5 kilometers to eat 2 ice cold lalipak that had been fried probably in the morning and stacked up over there with a bowl of hot noodle. But he'd eat it once a week for 1 meal. When you eat it every day, then you're having problems. So, a little bit of thinking. There was a very nice gentleman who was speaking some time back and who said, if you eat like your grandfather used to eat, you'll be healthier than you are today. And that's not really wrong. Probably if you eat like his grandfather ate, if he was well off, you'll be even better off. But if he was really poor, then your diet is probably crap. Okay? So, Anna should be Purna Brahma, not Apurna Brahma. And on that note, thank you very much for having me here and for patiently listening to me.
Thank you, sir. प्रेसिडेंट डॉक्टर आशुतोष कुलकर्णी यांना विनंती करतो की त्यांनी डॉक्टर दलाल यांचा सत्कार करायचा आहे.
त्याच्या आधी काय प्रश्न असणार तर आपण 1-2 प्रश्न घेऊया ना. इकडपर्यंत मला बोलवलं तर आहे का काय प्रश्न? हा, डॉक्टरांचा प्रश्न आहे समोरच. हा, मला माहितीच होतं की होणार आहे. थांबा. महाराजांचा डाएट भाकरी आणि मटण. महाराज व्हेजिटेरियन नव्हते. चिकन कोण खायचं नाही त्या टायमाला. चिकन अंडेसाठी ठेवायचे आपण. जेव्हा ते चिकन मरायला यायचं तो खायला एक नसायचा. कौला चिकन लय महाग असायचा. मटण आणि भाकरी, वरण आणि भात, वरण आणि आमटी हेच व्हायचं त्यांच्या घरी, जे सर्व मराठी लोक खायचे. आमच्याकडे एक अगदीच मस्त स्टोरी आहे. आता तेवढ्यामध्ये केवढं खरं केवढं खोटं की महाराजांनी त्यांचा पोरगा संभाजी पाठवलं थांजावूरला की तो थांजावूरला जाऊन जरा जपून राहणार तिकडे, कारण परिस्थिती बरी नाही आपल्याकडे कोकणात, तर तो तिकडे गेला तर तो म्हणायचा की ही काय डाळ बनवतात तुम्ही, हे मला पोटातच जात नाही, ह्याच्यामध्ये काय आंबटच नाही, कारण आपण आमटी बनवतोय ना. तर त्या लोक आमटी बनवायला लागले, तर त्या आमटीला थांजावूरमध्ये संभाजीची आमटी म्हणायचे आणि त्यावरनं त्या एरियाच्या आमटीला सांबार म्हणतात. सांबार सर्व नाही, सांबार कम्स फ्रॉम द वर्ड समभार, वेन यू पोर्शन आउट मसालास. आणि सांबार सर्वीकडे असतोय, गुजराती लोकांकडे पण सांबार मसाला असतोय, पण समभार इज वन थिंग अँड सांबार ॲज अ आंबट डाळ is another thing. So one of the possible origins of the modern sambar that we eat, the Karnataka sambar, is thanks to Shambhaji and the Marathas. I don't know how many of you all know that महाराजांचे केवढे भाव होते. चला चला कोणतरी सांगा मला, महाराजांचे भाव किती होते? 1 2 महाराजांचे 9 भाव होते. 9. त्यांचा एक मोठा भाव होता शंभाजी नावाचा. ही वॉज द एअर बिकॉज ही डाईड. महाराज वॉज विथ ड्यू रिस्पेक्ट द स्पेअर became the heir. Okay, he loved his elder brother, that's why he named his eldest child after him. But Maharaj had a lot more brothers from a lot of other mothers. Shahaji became so powerful that they made him separate his jagirs and give the Pune Jagir to Maharaj, and he retreated to Bangalore. Half of the food of Karnataka is Maharashtrian food. Today the Kannadigas and the Maharashtrians might be fighting over Belgaum. But what they should realize is they need to embrace each other and not fight with each other, because they have very common origins. Davangere is where Shahaji's, where the famous Davangere dosa comes from, is where Maharaj's father's tomb is. His chhatri is there. Nobody goes to that samadhi, sadly. But in that entire area, there are what are called Marathi hotel. Okay? And these Marathi hotels are all mutton hotels. And in every one of them you will see an image of Shivaji Maharaj. So, there is an enormous amount of Maharashtrian culture in Karnataka, which sadly today we have missed out on. So mutton and bhakri was Maharaj's favorite food. Yes, please.
माणगाव आणि मसा यांच्यामध्ये चांदोर आहे आणि माझे पणजोबा चांदोरेला राहत होते आणि त्याच्यावरून माझं नाव आडनाव चांदोरकर पडलं. आणि तुम्ही सुरुवातीपासून जे सुकट भाकरी आणि वांग्याचं बरंचसं काय तुम्ही सांगत आहात, म्हणजे तुम्ही ज्या ज्या छोट्या छोट्या गोष्टी सांगितल्यात त्या मी लहान असताना म्हणजे मी माझ्या आहारामध्ये खाल्लेल्या आहेत त्यावेळेला. आणि लहानपणापासून अगदी पहिलीपासून ते 12वीपर्यंत मी फार ब्राईट स्टुडंट का होतो याचं कारण आता मला कळलं. आम्ही रोज वांगी खायचो आणि आम्ही जांभळी वांगी खायचो रोज, आणि त्याच्यामुळे कदाचित. आणि तुम्ही सांगितलेल्या एक एक गोष्टी मी आता माझ्या वाईफला सांगत होतो की सर हे सांगतायत हे सगळं आम्ही लहानपणापासून केलेलं आहे. आणि चांदोरे हे गाव आणि त्यानंतर मग आम्ही स्थायी या गावाला आमच्या स्थलांतरित झालो. आपलं लेक्चर फार प्रतिभावंत होतं आणि खूप छान होतं. हॅट्स ऑफ. थँक्यू सर.
थँक्यू. तुम्हाला माहिती आहे का, चांदोरा गाव आहे ना, वॉज पार्ट ऑफ मराठा एम्पायर, नॉट पार्ट ऑफ द सिद्धी एम्पायर. इट वॉज द टिप ऑफ वन फिंगर गोईंग फ्रॉम द मराठा डोमेन into the सिद्धी डोमेन. एवढाच एक पातळ रस्ता होता गोळेपासनं चांदोरला. चांदोर वॉज मराठा, साई वॉज सिद्धी ऑन दिस साईड, मसला वॉज सिद्धी ऑन द अदर साईड, बट चांदोर वॉज अ मराठा टाउन. आणि बाबासाहेब आंबेडकरच्या टायमाला लय मोठा तिकडे हे झालेलं, जेव्हा ते व्हेरी फेमस, आता जाऊ द्या ते हिस्ट्री जाऊ द्या, अधिकारी साहेब जास्त बरं सांगू शकतात ते. सो चांदोरला मी राहिलो आहे 4 वर्ष. ते सुकट भाकरी मी पण खाल्लेली आहे तिकडची. तिकडे एक लई फेमस कोलीन बाय होती, ती गाणारी कोलीन म्हणायची त्याला. ती गाणं गात गात यायची आणि तिचं गाणं ऐकलं की लोक बाहेर जायचे पटकन सुकट घ्यायला तिच्याकडनं. सो वन लास्ट क्वेश्चन बिफोर वी शट शॉप. येस प्लीज. Sabudana is tapioca. Tapioca came to India in the middle and late 19th century and became popular in the early 20th century in South India. The reason for that was that there was a great problem with rice cultivation. There was a drought and tapioca could be grown. So the Maharaja of Travancore promoted the growth of tapioca, what they call kappa. So then what to do with this kappa? So they started doing various kinds of complicated experiments with it and then turning the flour into these pearls. Now, उपवासाचं जेवण काय असते? उपवासाचं जेवण हे असतं जे आपण रोज खात नाही. तर उपवासाच्या जेवणमध्ये नॉनव्हेज नसतं, म्हणजे सुकट विकट काय नसते. जे आपण रोजचे धान्य खातोय, भात तो नसते, डाळ नसते. तर आपण जे आता खातोय ना ते सर्व फॉरेन गोष्ट जे आहे ना ते आपण मान्य केले उपवासासाठी की हे आपले नाहीत ना, हे बाहेरून आलेत. शेंगदाणा बाहेरून आला, साबुदाणा बाहेरून आला, तो चालतोय. बटाटा बाहेरून आला, तो चालतोय. जे आपण 1-2 फळं खायचो आणि काय राजगिरा वगैरे खाऊन पोट भरून त्या दिवशी चुपचाप उपवास करायचो, आता काय एकादशी दुप्पट खाशी.
सर, तुम्ही म्हणालात की बऱ्याचशा भाज्या हे आता 100-150 वर्षापूर्वीपासून आल्यात. मी पेण विभागातून असून पेणमधला असून खारेपाट विभागात राहतो. आता बऱ्याच प्रमाणात भात शेतीच्या ऐवजी मच्छी शेती केली जाते कारण ती जरा फायदेशीर असते. पण आता बऱ्याचदा बघितलं ना की मच्छीमध्ये सुद्धा बरेचसे आता नवीन प्रकार यायला लागलेत. म्हणजे तिलापिया तिलापिया किंवा पापलेट म्हणून वेगवेगळे, म्हणजे आमच्या लहानपणी आम्ही कधी पाहिली नव्हती. तर अशा बऱ्याचशा मच्छी सुद्धा याच्यामध्ये आता यायला लागल्या. असं
साहेब, जे बेस्ट मच्छी खायला असते ना ते लोक खायला तयार नसतात. बांगडा, तरली, करली ही बेस्ट असते. ऑइली फिश जे आपण म्हणतोय ते. कुप्पा म्हणजे काय? ट्यूना. त्याला ट्यूना नाव दिलं आणि टीनमध्ये टाकलं ना तर लोक खायला तयार आहे. तर कुप्पा म्हणलं आणि ते लाल लाल त्याचं मटण दिसलं आणि तो काळा झाला फ्राय करून, तर छी हे कोण खाते असं असतं. आपण पण जरा हिपोक्रिटिकल आहोत काय. आणि भरपूर प्रकार नवीन आलेत. हे बासा आला आहे. बासामध्ये तुम्हाला माहिती आहे का, बासाचा साईज वाढवायला त्याच्यामध्ये ऑक्सिटोसिन टाकतात. जबरदस्त मोठ्या प्रमाणामध्ये ऑक्सिटोसिन टाकतात. तर तो बासा फुगतोय माझ्यासारखा काय, नाहीतर तो बासा असा असायला पाहिजे. तर आपण ते हॉर्मोन दबवलेले चिकन आणि हॉर्मोन दबवलेले मासे खातोय. तुम्हाला माहिती आहे का, आपण रविवारी फक्त मटण खायचो. रविवार म्हणजे मटण, आता रविवार म्हणजे चिकन. त्याची मेहरबानी काय आहे? तिची मेहरबानी ब्रिटिश आहेत. ब्रिटिशने आपल्याला रविवारी सुट्टी दिली म्हणजे आरामात उठायचं, नाश्ता करायचं आणि बायकोनी बाहेर हाकायला जाऊन मटण घेऊन या काय. तर मटण घ्यायला जायचं, लाईन लावायची मटणवाल्याकडे, 2 बिड्या घ्यायचे, 2 चहा घ्यायचे, मित्रांबरोबर गपशप करायची, मटण घरी घेऊन यायचं. आरामात बायको शिजवणार. कारण काय, घाई नाही. रोजच्या दिवशी घाई असते. सकाळी नाश्ता बनवायचा, जेवण बनवायचं, डबा पॅक करायचा, सर्वांना बाहेर काढायचं काय. ते नसतं रविवारी. तर रविवारी लोक मटण खायला लागले महाराष्ट्रामध्ये. ही ब्रिटिशची देणगी होती, रविवारची सुट्टी. इंडियामध्ये सुट्टी नसते अशी. त्यानंतर लेट 1950s अर्ली 60s मध्ये पहिल्यांदा मुंबई, पुणे, रत्नागिरी बाजारात मोठे मोठे बॅनर लागले. मटणाच्या भावात चिकन. तेव्हापर्यंत चिकन वॉज 3 times more expensive than मटन. अरे मटणाच्या भावाने चिकन, चला चिकन घेऊन जाऊया, बायकोला जरा इम्प्रेस करूया घरी. हो अगं चिकन घेऊन आलीस तुम्ही? हो आज चिकन खाऊया. नवरा कमवायला लागला असतं जास्त काहीतरी, चिकन बनवायला लागले. पण हा चिकन कोणता होता? तो देसी चिकन नव्हता, ब्रॉयलर होता. आणि ब्रॉयलर तर पटकन शिजतोय. त्याचे मसाले सर्व बदलून टाकायचे, कमी मसाले जातात, शिजवायला टाईम कमी जातो. अगं ऐकतात का, पुढच्या रविवारी पण चिकन घेऊन या. ते आता आपण रविवारी चिकन खातोय असं असते. आणि नशीबची गोष्ट असते हाऊ वी चेंज थिंग्स. बट चिकन हॅज बिकम one of the greatest protein sources for Maharashtra. So there are good things. Every dark cloud has a silver lining. Chala.
Thank you, sir. डॉक्टर कुरुश दलाल यांना विनंती करतो की त्यांनी चेअरपर्सन यांचा सन्मान करायचा आहे. मान्यवरांचे आभार. यानंतर RMAची GBM आहे. रायकॉन 2026चं फर्स्ट डेचं सायंटिफिक सेशन आज समाप्त झालेलं आहे. थँक्यू टू ऑल स्पीकर्स, ऑडिओ व्हिज्युअल टीम, कॅमेरामन, मेडिकल रिप्रेझेंटेटिव्ह, हॉस्पिटल रिप्रेझेंटेटिव्ह, MOC for the lucky draw and PCC for the lucky draw. स्क्रीनवर एक QR कोड डिस्प्ले होत आहे. ॲडिशनल सिव्हिल सर्जन यांनी रिक्वेस्ट केलेली आहे की ऑर्गन डोनेशनचा हा QR कोड सर्वांनी स्कॅन करून त्याच्याबद्दल माहिती घ्यायची आहे. या कार्यक्रमाची सांगता करताना मी डॉक्टर कुणाल राठोड आपल्या सर्वांची रजा घेतो. एन्जॉय द इव्हनिंग. थँक्यू सो मच.
मी अध्यक्षांना विनंती करतो की त्यांनी RMAचं GBM लवकरात लवकर सुरू करावं, कारण पुढील फार महत्त्वाच्या कार्यक्रमांसाठी अनेक लोक ताटकळली आहेत. त्यामुळे त्यांनी लवकरात लवकर RMAची GBM सुरू करावी, म्हणजे मग पुढील व्यवस्थेसाठी आमचं तिकडे जाणं सोयीचं राहील. रायगड मेडिकल असोसिएशनच्या GBMसाठी थांबावं असं मी रिक्वेस्ट करतो. आपले प्रेसिडेंट, सेक्रेटरी आणि ट्रेजरर पुढच्या 1.5 ते 2 मिनटात GBM सुरू करतील.
चला चला स्टार्ट. सेक्रेटरी,
डॉक्टर प्रशांत गांगलांना विनंती आहे की त्यांनी लवकरात लवकर ऑडिटोरियममध्ये यायचं.
आपण GPM चालू करतो आहोत. हां, प्रेसिडेंट इलेक्ट सचिन नाईक सर, तुम्ही जरा स्टेजवरती यावं. हो जा. नाही नाही, रेकॉर्डिंग बंद केली तरी चालेल. नो यूट्यूब प्लीज. हो, नको नको.